হচ্ছে। But we could make up to 90 presentations, including in-person and virtual presentations, to be done in 3 halls, and a pediatric emergency medicine workshop by Dr. Debashish Das Adhikari, sir, and his team. All were very well received, and I have few people to thank before I start today's day. And Dr. Mohan is one of them. He's from faculty from PGI Chandigarh. Dr. Ashray, a faculty from St. John's Medical College, Bangalore, and Dr. Sahana, a faculty from Vedahi Institute of Medical Sciences, Bangalore. So thank you to all these 3 people. They made it very easy for us to coordinate in the halls and get the things going in. So we start our day today with Professor Navneet Sharma, sir, from PGI Chandigarh, who will be talking to us on minimally invasive hemodynamic monitoring in ED. Sir, we welcome you here.
Well, good morning. And I can see we got a very busy hall, so of great learners. And first of all, I'd like to invoke the goddess Saraswati for the learning. And may she grant us all the knowledge that we so desire. And with these words, I foremost would like to thank a few personalities before I begin my talk. And I think Dr. Ashima and Dr. Einstein have done a wonderful business in organizing this event. And Professor David as well, with his kind words and his humor. And no doubt Dr. Selvarajan, who's been instrumental in organizing. It's wonderful seeing his smiling face and his encouraging attitude all the time. I'm yet to see a person who's so much involved and done so much in so little a time. With these words, I think most of you, how many of you, I can see there are advanced trainers and they are, how many of us starting your careers in emergency medicine? Just maybe point a finger up. Oh, you're just starting? Okay, very good. Then I have somebody I can address because I can see all the seniors must be well versed with whatever I have to tell you now. Think of a scenario. You're dealing with a person who's there in the emergency and crashes in front of your eyes. You do your best, you stabilize him, and you upgrade the call to the ICU person that this person needs ICU care. His physiology has become too unstable to be handled there because of, and my monitoring is limited. I can only do a non-invasive blood pressure, I can check the ECG, I can check the ABGs and all, but there's a limitation. How many times the ICU says, sir, regret, no bed available. They come and write it down. You're flummoxed and you're caught with a patient who is very, very unstable hemodynamically. There is a high impending risk of death. So what do you do? So with these words, just think about it. There is a concept of what is known as a minimally invasive hemodynamic monitoring. Now, I would be going into the territory of what was traditionally anesthesia territory, but somehow around the line, it needs to be brought down. And I'm a person who firmly believes that the upstairs cares must come downstairs so that it can reach a more number of people that need it for saving lives, for saving heart, for saving brain, for saving the kidneys. Name any organ, and this has a role. Now, before we embark on this, I would like to go over what it involves. Hemodynamics is a very simple, if you try to define it in terms of words, put it into words. It is just an assessment, it's a measurement and detection of changes in blood flow for the tissues and the body organs, okay? But unfortunately, we only measure what is known as pressure. That is the only metric we have as far as of today's science is concerned. And it is the flow and the pressure both which make a difference as far as when you're trying to save organs, trying to save organs and indirectly trying to save lives. This term was coined by this gentleman, Werner Frossman, in the year 1928. And since then, more than a century now, we've come a long way because tools for measuring hemodynamics way back at that time were pretty ancient. And with advancement in science has given us numerous other tools that we can use to upfront and make a patient's, unstable patient stable. So what we do is we assess, we detect, and we measure. I call them ADM. Okay, you all heard of ADP, this ADM. What we do for detection and measurement is the blood volume, the fluid balance, and the pumping of the heart. Okay, this lecture is going to be a little bit long, so I will take permission from the dais to go a little bit up because it involves going into territories which are a little bit more invasive. So I need to, level the playing ground and make our new learners also understand. So I call this the 70s show. This is what we all grew up with, and myself, no exception. We used to do mercury using blood pressure, we used to do the urometer, we used to do the temperature monitoring, thermometer, and so on and so forth. And clinical examination, of course, AVPU scale, and you all heard of capillary refill time, and a clinical examination in patients who landed up with unstable cardiac issues. But the board has changed, and change has brought in ultrasound. It is surprising, it's such an old technology. It was used in the Second World War to detect submarines. You're just bouncing off waves of the submarine, detecting it, and the surrounding structure, and you know the thing is over there. But it has taken quite some time as far as arriving to the critical care emergency departments are concerned. You have the piezoelectric technology, ultrasound thermistors for measuring body temperature, and these thermistors in their appropriate equipment can be inserted into the rectum or the esophagus. Core temperature, which is far better measurement of the overall hemodynamics rather than others. You have the principle of Wheatstone bridge, which is what the intra-arterial pressure monitoring that I'll be alluding to a little later. And you even have more invasive devices like your pulsio cath and all, which can measure temperature differences of setup of the intra-arterial catheters. I'll be talking about some of these, so don't worry. It is not very confusing. Slide is a little busy, and I borrowed it from this particular journal of respiratory care. The pump is the cornerstone of measuring hemodynamics. A good pump, and the stroke volume is the volume which is pumped out by the heart with every beat, depending on the preload, the afterload, and the contractility, 3 factors, and the heart rate. So cardiac output times the heart rate, stroke volume times the heart rate makes it cardiac output, and what delivers oxygen to the human body. The oxygen content being indirectly governed by these 3 factors that are displayed in front of you. So I could, as simple as I could make it, though the equation is very complicated, but I've tried to keep it as simplified as possible because I think understanding simpler things, particularly in emergency departments, are the best. So what can we do to make delivery of oxygen optimized? You need to optimize this. Simple terms, optimizing cardiac output equals optimized hemodynamics. Okay? Arterial content, I've already talked about in this previous slide. All the part above the blue bar is what we've already seen in the previous slide. The therapeutic options available for you for checking oxygen is increasing FiO2, setting up the PEEP. For hemoglobin values, you can give transfusions. Heart rate can be taken care of by pacemaker, depending on what the patient is depicting, bradycardia or tachycardia. Though I'll say in emergency situation, bradycardias are far less common as compared to tachycardias. Fluids, to make sure that the pump is effectively being filled and it is able to pump out, there's no volume deficit. Dobutamine, again, taking care of the contractility, and for reducing afterloads, we have nitrates in areas where the blood pressure also may tend to go very high. But the flip side is what I've depicted in red column. Okay, these are the dangers. Oxygen and PEEP, okay, to some level, but above SaO2 of 790, they do not impact. Rather, you tend to land up sometimes with oxygen toxicity when you find values going pretty high. Transfusion has associated transfusion risk. There may be TRALI, transfusion-associated lung injuries. There may be hypocalcemia. There may be hypothermia if the blood bag is not appropriately warm. Pacemaker, again, not very effective. If you look at for severe, unless there's severe bradycardia, for tachycardia, you don't use pacemakers at all. But tachycardia brings its own issues that the mixed venous oxygen saturation, it goes down because you don't have effective offloading. Tachycardia is a very rapid circulation. It's like a high output situation going on, and the oxygen does not offload. So MVO2 will definitely go up because it's not offloading to the tissues. Fluids, problem again, third spacing, lung edema. They're the biggest problems and the bane of all fluid therapy that we are administering because we are in danger of landing up with fluid overload. Because you have a sick person, there's a breakdown of every barrier. So the capillary barrier of the pulmonary interface is the first one to go, and that's what impairs oxygenation. For dobutamine, again, decrease in MVO2, same problem as with tachycardia. And nitrates, you may go a little bit overbound with them, so they have to be carefully looked at. Tools that are available now. Coming to the tools that we have for our minimally invasive, we have arterial catheterization, which is something I'll be talking about. You have a central venous catheterization, and for CVP, I will not be discussing much because CVP doesn't yield too much of a useful information except in only volume depleted states. Okay, there are far better methods to detect certain issues as compared to central venous monitoring. It's okay to administer drugs, it's okay to administer vasopressors, to administer inotropic agents, antibiotics, infusion, prolonged infusion, potassium infusions, and so on and so forth. But as far as hemodynamic is concerned, CVP has got a sort of a background role, a very limited role. So don't rely too much on CVP measurements, though it may be useful to get other measurements, which I'll be talking. Then there is a pulse contour analysis. These are now becoming a little bit invasive. So you have to insert an arterial catheter, and setup is not too different. There's an arterial, there's a venous, and we'll be going over this. It uses the principle of thermodilution, which is the gold standard of measuring hemodynamics so far. Okay? Echocardiography, now that would be a topic for the afternoon's workshop. So I will not be talking too much on this, but yes, echocardiography has a big role. And the new tools that are available is that of an electric cardiography. Some of you may be familiar with these particular tools. And they use totally non-invasive, 3 electrodes in the neck, 3 electrodes in the torso, and you measure the flow of current as the RBCs align. When the valve is closed, aortic valve, they are haphazard. When it opens, they become parallel, and you have the electricity generation. Very useful tool, and I'll give you a scenario later on to think about. Certain hemodynamic parameters, I think you can keep them and revise them from time to time, values here. Only thing, I think the systemic vascular resistance, that it's not MPA, it's MAP, mean arterial pressure minus right atrial pressure times 80 divided by cardiac output. So keep that in mind. We come to the invasive pressure. Now, what is the need for invasive pressure? Now, on the left-hand column, you find the fallacies of recording NIBP. That is the NIBP most of us have been taught in our MBBS and internships. It is totally inaccurate. It usually underestimates high blood pressure and overestimates low blood pressure. There is an error, 15 mmHg, if you use in chaotic situation, particularly emergency department, even in the equipment that might be state of art. I'm talking about NIBP, I'm not talking about IABP. And in arrhythmia, accuracy is even worse because it's just a one-time measurement. It has to be done repeatedly, okay? So therein, a role and indication for using IABP, labile blood pressure, you anticipate hemodynamic instability, there's a very obese patient coming in, and we heard all dangers of obesity yesterday that was alluded by a particular speaker. You need to titrate vasoactive drugs. So my recommendation is that if you need to think of using a vasopressor like, noradrenaline, adrenaline, or vasopressin, I think about IAP, okay? They require frequent blood sampling, ABGs, yes, otherwise multiple pricks and so much damage. And I said, edematous states would be others where NIBP again becomes unreliable. Just to tell what mean arterial pressure, 2 times diastolic pressure plus systolic pressure divided by 3, values in range of 90 to 105. Okay, this is the material that you require, arterial line, and 48 inches of non-compressible rigid fluid-filled tubing, pressure transducer, pressure bag, automated slow saline, 312 ml per hour with 500 units heparin, and electronic transducer ampli. Transducer is only a piece of equipment that translates a wave energy into electrical energy that can be displayed on a particular monitor and for you to interpret, and gives quite a lot of useful information. Rather, if you consider hemodynamics as of today's world, you would probably stop here and leave it at that. But then a lot of trend is happening, a lot of new equipment is coming, and they may soon, after standing the test of time, come into play. And those would be very useful as far as EDs are concerned. Just technique of insertion, one with guide wire, the other without a guide wire. Usually measuring the radial artery, you check for arterial sufficiency by doing the test, and then you insert it. Whether you use ultrasound guidance is up to you, but since radial artery is too superficial, it's very easy to puncture. You don't normally require an ultrasound because it's well protected by the surrounding bones. Okay, the system that you use consists of a fluid-filled tubing. That is the way to the patient. You have a 3-way tap for leveling. You have the flush system for checking whether the system has been dammed or over-dammed or under-dammed. And you have a specialized saline to keep it patent. so that the blood doesn't coagulate, because blood outside the veins will always coagulate, tend to coagulate, so you have to keep the line going, and a cable to processor that interprets the signal. You, again, hydraulic system, an electronic system, catheter, tubing, transducer, flush device, amplifier, oscilloscope, digital display, processor, and recorder. Okay? And this is what you get. Now, the dichrotic notch is that hump that you see. That's where the aortic valve closes. And from the downslope to, do you have some pointer? Pointer? Do you have a point? Yeah, here. Okay, the mouse, it's a little sluggish. This is the dichrotic notch. This part, entire part is the stroke volume, and this is the diastole. Okay? Systolic pressure, diastolic pressure, and all of this graph. Okay, you have this. It's hardly see. Can you see? Okay, and this entire is the mean arterial pressure display that you get. And difference between this and this is the pulse pressure. So one graph, and you have so many things. And you can even calculate the heart rate by these 2 beats. Okay? Just a mechanism by which it is, the system works. Vascular pressure causes pulsation of saline column. It displays the manometer's diaphragm, which has a built-in strain gauge. Deformation leads to change of resistance. Okay, 3 resistances are known, 1 is unknown. And that's the Wheatstone bridge for you. Waveform built up by Fourier analysis, because the peripheral flow is always a little bit different and of lower amplitude as the central flow. So you have multiple wavelets generated, they superimpose on each other, and that's what the machine displays. That does it for you automatically. Okay? That's Fourier analysis for you. For multiple waveforms superimposed to get the 2 sine waves display. Okay. I was asking for a collar mic, but they don't seem to be having. Am I audible? Huh? Bending over becomes a little bit of an issue, but I'll try to raise my voice. I thought I'm pretty loud enough. You can't hear me in the back. I am just. Is there an issue? Do I need to raise my pitch? Okay, they've raised that. Fine. If you need any sort of this, we can have a discussion later on also. So sum of 2 sine waves, and this is what you get. Okay, that's what is displayed. Wheatstone bridge in simplified terms from physics, knowledge of physics. Young people, please come forward, I think, if there's an issue, because I think all these seats are vacant. Come in front. Okay, that's the Wheatstone bridge for you. Fine. These 3 resistances, 1, 2, and 3 are known, and the Rx is the unknown resistance. That's what the display detects. Certain prerequisites. You have to level it to the atmospheric pressure, and for that you have a 3-way tap that I showed you before. You open it to the atmosphere and put the leveling on 0. Once it's leveled, you have to make sure it's targeted to the center of the right atrium. And normally we do that by putting it on a attached stand with pipe sort of structure, or you put it next. Best thing is to tie it to the left arm with a gauze piece, okay? And make sure that when you're taking a measurement, the bed is flat, the head end is not raised. So you need to make sure of that. It requires nursing, it requires flushing, it requires you to maintain the pressure in the pressure transducer, the bag, saline column bag to at least 200 mm. Make sure that is there, and for that you require it to be nursed every 4 to 6 hours. So that it involves a certain amount of care, and that's the invasiveness part. What we get is this busy slide. As I showed you before, mean arterial pressure, entire column, stroke volume. If you just remove this part, and how we do that I will tell you in subsequent slide. Check the under-dampened system, because under-dampened, if it's more than 2, it's under-damped. It will affect the systolic pressure and diastolic pressure, but remember, mean arterial pressure by under-damping or over-damping is not affected. That's usually very reliable. Okay? So make sure damping is not there. This would be the ideal setup you'd want. Okay? So ideally 1 fluctuation or so after using the flush system. We get a very useful information. Pulses, paradoxes, inspiration, expiration. You see the variation. Just by looking at it, you don't need to do anything. You just look at it, you eyeball it, and it's there. Pulses alternance, okay? Pulses bispherians, that is, there's too much holding. I think I'll do that. Okay. This is aortic regurgitation, aortic stenosis, and you have pulsus parvus et tardus. Again, similar etiology, aortic stenosis being the dominant lesion. So just by looking at it, you get so much information. You have a mean arterial pressure, and you have the systolic and diastolic pressure. And just this slide, just look at, this pointer is again gone. These two, what is known as pulse pressure variation, Stokes pressure variation. Look at the area under curve. This has been organized by Merrick et al. In the year 2001. He's, I think, one of the big names in hemodynamics. 0.94, 0.86. The other one, where you're more invasive, which is the left ventricular endostolic or echocardiography, area under curve goes down considerably. So, mean arterial pressure, just by arterial waveform, again 0.94. You have, and that is a pulse pressure variation, mean and a stroke systolic pressure variation of more than 10. This is what we do in non-invasive also. Somebody is losing blood, you see a fall of systolic pressure of about 10, you think this is an unstable patient and I need to get up my ante and get the blood bags in. And pulse pressure variation, again, same, more than 15, 10, well, there is a little bit of an issue. More than 10 to 15 is the borderline zone, and more than 15, definitely, this patient will need. So your fluid requirement or blood requirement can be taken care of this particular issue. And you know you have a fluid depleted patient, whether it is fluid or whether it is blood, that is the scenario will decide. And look at the thing for central venous pressure, 0.55, not very good. Complications are all of these. I don't need to tell you, you can imagine a catheter put in, what can happen. It can cause damage, it can thrombose, it can cause punctures in different areas where it is put. It can cause aneurysm formation. We've seen many of these complications. Second thing, and I switch gears here, is the continued cardiac output. Okay, just going on for a mean arterial pressure. You had an invasive way of doing it, the Swan-Gons classical, what all of you must have read, but it is no longer advocated for practitioners of emergency care or for critical care. Cardiologists are using it, cardiothoracic surgeons are still using it, and there have been a lot of literature on the lack of usefulness of pulmonary artery catheterization as far as critical care or emergency departments are concerned. So this is a device not to use. I would not advocate it at any point in time, and it is highly invasive. Okay, a lot of problems with it. You have then the non-invasive or minimally invasive devices. I think this thing is dead. Can I use this? No, can't use this. I think your battery is dead. Yeah. No, it's not coming. I can't see. It's going down. Okay. So you have, on the other hand, then you've got a transthoracic echocardiography or a transesophageal. You have continuer, you have LIDCO, which is a lithium dilution method that is in favor in the United Kingdom. And electric cardiography is something we'll be talking about. The other hand, esophageal Doppler, aortovelography, and transthoracic impedance need to be studied in more detail to make out their value as far as EDs are concerned. They may be having ICU issues or use in ICU, but I would not advocate their use in the emergency departments per se. Okay? PICO is a continuous pulse contour analysis, thermodilution method. Only additional thing it requires, it measures cardiac function, distribution, and it also gives you the vascular tone. Setup is not too difficult. This slide is a little busy. It looks, you have a central venous catheter, you have an arterial catheter in the femoral artery. All you need is the plumbing part. The plumbing part is an extra temperature measurement catheter that is attached to the system. The other one is just like a mean arterial pressure. Same thing that we were talking about before. And the central venous line. You flush 50 cc of cold saline into the central venous catheter. Goes to the right side of the heart, goes to the pulmonary circulation, the left side, and you detect this temperature change down there when the aortic valve closes. Okay? What you get is a temperature reference of temperature difference of the blood that is circulating from the central venous system to the femoral artery. This is the graph you get. And this is what you get for mean arterial pressure. You put them two together and you have your stroke volume as depicted by this red color over here. This one. I'll take a little bit more time, so you can stop the beeper. Okay? Just a display of what it looks like. It brings to the table cardiac index, continuous cardiac output, minute The moment you record it, it will be displayed on this, and you may have a display showing you the cardiac outputs in real time at different time points. Apart from the major non-invasive hemodynamic, you have extravascular lung volume. Again, will have you take decisions on adjusting your ventilator settings or restricting fluids. Intrathoracic blood volume, resistance, global and diastolic volume, and your systemic vascular resistance. I apologize for this little blurred slide because the resident who did it, his camera wasn't very good. This is what again, it gives you more information about. What situation, end diastolic volume, stroke volume variation, systemic vascular resistance, extravascular lung water. So think about this picture, but this would not be an OPD type, emergency OPD type picture, but more of an HDU area where you can get the patients in and monitor them, and you got adequate nursing care available. Okay, values for you, just to look at this range of all these values. Okay, stroke volume variation, as I said, less than 10, pulse pressure variation, very useful fluid monitoring dynamics. And lastly, I come to you for the third part, which is the electrical cardiometry. Now, this device, if the cost is a little bit not prohibitive, would come a long way as far as EDs are concerned, the chaotic environment of the EDs. It brings quite a bit to the opening board. This device is marketed by Aeme-Con or Sipca Medical, and there's one more company working on it. I have not used this device per se, I don't have it, but we are in the process of purchasing it in my institute. It gives you blood flow, fluid status, contractility, cardiac function, resistance, blood pressure, oxygenation. Everything, virtually, with one machine which is totally non-invasive. As I told you, this is what it brings. It brings in certain parameters, like you have the TFC, which is the thoracic fluid content. You have the Aeme-Con index of contractility, and you have the STR, which is systolic time ratios. Their value needs to be defined. You have all the other parameters, stroke volume variation in just one small portable machine. 3 electrodes in the carotid, 3 electrodes over here, and that's what it does for you. And this is based on the principle of thermodilution. This has been tested against thermodilution before FDA released it to the market for marketing. So think about a situation in the emergency department, you have a crashing unstable patients, biochemistry, examination, everything is fallacious because they're often delayed. Biochemical values have a turnaround time, okay? Meanwhile, the hemodynamics is unstabilizing. You're having unstabilizing, but you can only monitor it by means that are not optimum. You have this device. How much of a decision making will change over a period of time? You can think about this in a patient who's not on a ventilator. How soon can you put him? And in emergency, I say time is everything. Time is muscle, as I reiterated earlier, time is brain, time is life. So the earlier destabilization, the better you are to make sure the patient goes for more better care. You can administer certain dynamics, you can change, you can add fluids, you can add antibiotics, you can add vasopressor faster, and you can look at kidney functions if you suspect they may be deranging. Okay, and lastly, I leave you with this slide from a very prominent practitioner of Joel Lou Vincent, who always advocates this. And I would say here, I would add on to this slide and say here that clinical decision making by the person who should be met with, should be carefully applied to each and every patient before you take the entire gamut into consideration. Okay. With that, thank you very much for your patient listening.
So I invite questions for the day from the students and our delegates. Whatever are your concerns of initiating hemodynamic monitoring, comments on what you felt is possible or not possible in the emergency department. So I think so that you were the description was so good. Or many of them joined late, sir. So I just wanted to, say to you this. We had this person, Aeme-Con, coming to us, and we did this, and we did 5 cases with him. So I think so, there was a patient where we were not able to maintain the temperature. And because it is based on this electrodes, so hypothermia is one thing where we will have fallacious readings. So that is the only thing which I felt in the last one. So thank you so much, sir. Thank you a lot. And I invite now Dr. Shakuntala ma'am. Ma'am would be speaking on life-threatening electrolyte emergencies.
Thank you, Dr. Aeme. So the topic is life-threatening electrolyte emergencies. A very good morning to all of you, and I thank the organizers for this opportunity. So there are many, but I will be focusing on hyperkalemia, hypokalemia, and hypomagnesemia, because those are what we see most commonly as a serious disorder in the emergency. I'm just starting with one aphorism. It says, here's the truth, your situation is never permanent, it's what you make it. You know, life isn't solid, it's fluid, it changes. So this is true of the topic I'm going to talk about, which is electrolytes and fluid, because it keeps changing. So remember that it is never static, it's dynamic, and which means constant reassessment is very, very important. By definition, hyperkalemia, which I'm starting off with, which is obviously the most serious one, and every emergency physician, I think anyone working in emergency department for more than a month would definitely have seen some hyperkalemia and would have treated patients. So by definition, according to European Resuscitation Council, it's defined as more than 5.5, and severe hyperkalemia is characterized as more than 6.5. The main risk for mortality, of course, which everybody knows in hyperkalemia, is on the heart, causing cardiac rhythm or conduction disturbances. There's a good classification. This is a very recent update from the KidGo group on acute hyperkalemia, specifically in the emergency department. So notice that according to this classification, the presence or absence of ECG changes are very, very important. So if you look at it, with ECG change, even a potassium of between 5 to 6 will be considered as high, but it is mild, and moderate. Without ECG change, it is mild. But 6.1 to 6.5 with ECG changes is considered moderate, and without is with is considered severe, and without is considered moderate. Anything above 6.5 is severe. So this means that the presence of ECG changes is very important. If they are not there, then it does not rule out hyperkalemia. So when is it associated with poor outcomes? So we might have seen a lot of patients who have a very high potassium, but nothing much is happening, their ECGs are normal. So patients with cardiac and renal disease, any critically ill patients, patients with AKI, acute MI, and heart failure. So these are the patients where any potassium which is even above 4.5 may lead to a serious outcome, and which are sort of the red flags where you have to be worried about these patients. Mechanisms, I will not go into detail. So all of you know about the kidney, that altered renal clearance is the most common or severe condition associated with high potassium. There may be increased release from cells due to hemolysis, rhabdomyolysis, or tissue injury, or there may be an altered transfer to the intracellular space, which is due to acidosis or due to lack of insulin, beta blockers, or hyperglycemia, etc. Now, what are the cardiac effects? So there's an increase in conduction velocity, decreased threshold for a rapid depolarization. So this is what will cause rapid depolarization, and increase the automaticity can cause arrhythmias. There's also altered conduction in the later stages, which leads to the PR prolongation, loss of P waves, QRS widening, and a bradycardia, and ultimately the classical sine wave pattern. But again, remember that the ECG changes correlate poorly. So if you find an abnormal ECG, it's important, but if you have a normal ECG, think of the red flags. Do not rule out hyperkalemia. Anybody with an abnormal ECG has got a higher mortality. So if you look at the lower part, hypokalemia is above, depressed ST segment, biphasic T wave, flattening of T waves, and the opposite changes will happen with hyperkalemia. So a tall T wave followed by the wide QRS, flattening of P waves, and finally sinusoidal wave. Now, we always think about the cardiac part, but remember, it can rarely present with neurological features, such as weakness, flaccid paralysis, paresthesia, fasciculations, and decreased DTRs. So some patients may present with these kind of symptoms. Few ECGs from our department. So this is very classical, a tall T wave due to hyperkalemia. Now, this is the patient with a wide QRS, no P waves, and almost going into a sine wave pattern in the bradycardia. Here you can see a Brugada pattern in the V1 and V2, a Brugada type pattern, which is also commonly seen, rarely seen, not that common. This is a very interesting patient where I think all of you can see the ST elevation, which is classically seen in lead 2, 3, and AVF with the reciprocal changes in 1 and AVL. So this patient came with severe chest pain, breathlessness, and shock, and it looked exactly like an inferior wall STEMI, but his potassium was 7.4. And this was a repeat ECG after correction of the potassium. So they can present with these kind of rare atypical changes. So one point I wanted to make is the point of care test reliable? So many times we would have done the point of care and said, okay, I'm not sure, I'll send to the lab and I'll wait for the report. But that may delay a lot because you have to wait for the lab results. So this study compared the POCT with central lab measurements, and it was found sufficiently accurate. So the mean difference is only 0.1 to 0.5 millimoles from the POCT and the lab potassium. So that means you can use it, especially in patients where you're suspecting hyperkalemia. So they have got symptoms or they have got the risk factors. You use the POCT, treat the patient, and then of course you can always double check with the lab values. These are the red flags, as I mentioned earlier, where the patient has risk factors. So CKD, AKI, heart failure, diabetes, anybody with a severe tissue breakdown, patient on RAS inhibitors or non-steroidals or potassium-sparing diuretics. A word about pseudo-hyperkalemia. So very often you look at it and you say, it doesn't look like no ECG change, I don't think this is correct, the potassium. So when do you think of that? This is the false elevation which is happening due to the blood draw. And if there are no ECG changes, absolutely no risk factors, then maybe you can suspect this, but always double check. And the causes would be because of a tourniquet tied for more than 1 minute, fist clenching, trauma, small needle or too much of agitation of the sample. Management of hyperkalemia, I think bread and butter of emergency physicians. So everyone knows the usual routine of management. I'll just go into some changes or differences. So calcium, of course, is always the first drug you will give when there are ECG changes, and it stabilizes the myocardial cell membrane, prevents arrhythmias, acts very fast within 5 minutes, and the effect will last for 30 to 60 minutes. There was a theoretical risk of even recently, we do teach that anybody who is on digoxin toxicity or say any cardiac glycoside toxicity, that you should not give calcium because it will cause a systolic contraction of the heart and can lead to more risk of arrhythmias and cardiac arrest. But this was a very small study done, published in 2011, which said the use of calcium, they compared patients, all patients with the digoxin toxicity, who received calcium, who did not receive calcium. And they found there was no risk of life-threatening arrhythmias if you give calcium, even in somebody with digoxin toxicity. So the only point here is many times patient, you see a high potassium and you don't know whether the digoxin level, you do not know what is the cause. So you might end up giving calcium anyway. So the point is you need not worry, so don't think that you've given calcium and the patient had an arrhythmia because of what you have done. If you're not sure, you can still give it. Whether to use chloride or gluconate. So gluconate is 3 times less. It means the chloride has 3 times more calcium than gluconate. That means you can give 10 ml of chloride versus 30 ml of gluconate. So this is well proven that if you have calcium chloride, it's better to use chloride. This is recommended by the European resuscitation council. If there is no response, there's no change in the ECG, you can repeat a second dose within 5 to 10 minutes. Hypertonic sodium or sodium bicarbonate, there is some controversy regarding this. Now, it is supposed to also act as a membrane stabilizer. So apart from the role of bicarb of pushing potassium back into the cells, it acts as a membrane stabilizer, so it can be given as an alternative to calcium when you think that infusion of calcium is risky. Loading with hypertonic bicarb may also increase GFR and increase the urine output. In that case, the potassium excretion may increase. So in somebody who has got metabolic acidosis, that is a pH of less than 7.20, bicarb can be given at a dose of 100 to 250 ml of 8.4% sodium bicarbonate over 20 minutes. But it is not found to be very useful or not advocated when the pH is normal. That means there is no metabolic acidosis. The next drugs would be the ones which move the potassium into the cell. So here you have two options. You have insulin dextrose and you have beta-2 agonists, which act in different ways. Now, among these, the insulin dextrose has a faster action. So it acts within 15 minutes. And if you give both though, then both meaning insulin dextrose plus beta-2 agonists, there's a better response. Side effect of insulin dextrose, of course, is hypoglycemia. So you have to monitor the glucose. And they have found that, it's been found that a lower dose of insulin is as effective as the higher dose. So we usually add 10 units in 25D 100 ml. You can also use just 5 units, which is as effective as the 10 units. Beta-2 agonists, which is salbutamol nebulization, the only problem is the tachycardia. So tachycardia and arrhythmias if the patient already has severe tachy. So here, if you don't want to use salbutamol, you can use the insulin dextrose instead of salbutamol. The dose of salbutamol would be 10 to 20 milligrams, a higher dose. Now, to increase potassium excretion, of course, diuretics do increase it, but in the acute situation and a sick patient, they have unpredictable effects. Most of these patients would have kidney problems or heart disease, and they may not respond well to diuretics, and you may cause more hypovolemia. So in the acute phase, there is no role of giving diuretics for the decrease in potassium. Gastrointestinal excretion, now these drugs were available. Now sodium polystyrene sulfonate, or the K-bind, which we commonly use, there have been a lot of recent studies saying it causes GI ulcerations and can cause complications. So it is supposed to exchange potassium for sodium in the colon, but again, no studies have been done on this. And in the acute phase, or at least in the emergency department, this is not really useful. See, patient may not be able to take orally, and it's going to act only after 1 to 6 hours. So there is no need to use this in the acutely ill patient. There are some new treatments in the same line, which is patiromer and sodium zirconium cyclosilicate, or ZS9. So these are being tried, and there is some meta-analysis which say it can decrease potassium. But whether the patiromer can be used in emergency setting is being studied now. And the second drug has been studied in emergency in 45 patients in the emergency department with potassium of more than 6. So they found that in about 1 hour, the potassium dropped to less than 6. So, but these are still in the experimental stage. Maybe in foreign countries it has been approved, but I don't think it's been used here yet. Renal replacement therapy is the best way to remove potassium from the body. So, but every patient may not require dialysis. So the patient is already unstable, maybe the BP is low, pushing for dialysis immediately may not be required. So again, this comparative study, which compared patients who received bicarb and those who did not, found that if you use bicarb, the RRT can get delayed, and the need for RRT also may be avoided. So that means you give all your medical management, and then of course if it's absolutely required, you will have to get nephrology for dialysis. So these are the indications where absolutely patient will require RRT. So a severe AKI with oliguria, unresponsive to hemodynamic optimization, end-stage CKD with very severe hyperkalemia, or if it is resistant to medical therapy. Frequent reassessment, so as I said, you have to keep reassessing. So when do you reassess? The first repeat potassium you need to do at least 1 hour after you have given your first drugs. The second point is very, very important. So a retrospective study done in a large academic ED, they found that the mortality of patients with hyperkalemia dramatically reduced in the patients whose potassium was normalized, which was brought less than 5.5 during the ED stay. So your role is very, very important. So do not think, okay, I've given some correction and I'm going to shift the patient, because it's always better to establish that you have brought down the potassium to less than 5.5 before you dispose of the patient anywhere. It's a busy algorithm. Don't expect, I'm not going to go through each of it. It's just summarizing whatever I have told you till now. Now this ECG, so it is very obviously showing opposite changes. It is showing a ST depression, a flattened T wave, and a U wave. So I think you can all see the U wave and a prolongation of the QT interval, or it's almost looking like a QU interval. So this is an ECG of hypokalemia. One study done in Japan says that the prevalence is 0.4. So the reason in an emergency department. So the reason I put this up is I think many of you can do studies where you will find a much, much higher prevalence of hypokalemia, not just 0.4%. So they found only 0.4. Most common symptom was weakness, and main causes were malnutrition, use of herbal medicines, and use of diuretics. Normal potassium range is 3.5 to 5, and life-threatening hypokalemia is considered only when it is less than 2.5. Diuretics are very, very important cause. So remember, 80% of patients who receive diuretics can become hypokalemic. Now the cardiac effects are the opposite. So instead of leading into a decreased conduction, bradycardia, like hyperkalemia, here there is hyperexcitability. So the patient will develop arrhythmias, and we are particularly concerned with the ventricular arrhythmias. Increased mortality, so just like hyperkalemia, patients with MI, CKD, heart failure, all of them at a higher risk of problems with hypokalemia. So in these patients, ideally their potassium should always be between 4 to 4.5. Should not be allowed to go high nor come low. If there is hypokalemia with concurrent hypomagnesemia, that leads to a more risk of an increased QT interval. And any QT interval more than 500 milliseconds have a double or triple risk of Torsades points. So remember that may need to correct magnesium as well. Clinical effects, again, there are a lot of effects. Remember, two important things are the cardiovascular system and the respiratory system. So respiratory system, it can cause respiratory failure due to the muscle weakness and of course neurological weakness. And the cardiovascular, what we are most worried about is the cardiac arrhythmias. Concomitant magnesium deficiency. So often in the emergency department, I don't think many of us will be able to get a magnesium level as a point of care. So we send to the lab and it takes time. But 38 to 50% of patients with hypokalemia will have a concomitant hypomagnesemia, and especially those who are on diuretics. And this will aggravate hypokalemia, and it may be refractory to treatment with potassium. So anybody with a severe hypokalemia less than 2.5, you may need to empirically correct the magnesium before you get the result. So causes renal losses. The kidney is an organ which mostly excretes potassium. So you can have renal losses, non-renal losses, that is through GI tract, decreased intake. So ethanol abuse is a very, very common cause of hypokalemia. Intracellular shift due to metabolic alkalosis or hyperventilation, and endocrine causes. The ECG changes. So this was one study again done in the emergency department patients where they found maximum incidence of U wave. This is the percentage, so 24% or so, U wave, ventricular ectopics, ST depression, and flattened T wave. But again, the earliest change was found to be flattening of the T wave. Most common is a U wave. Early change is flattening of T wave. The red flags similar to hyperkalemia, but severe hypokalemia, less than 2.5, will need quite urgent management. if the potassium is likely to fall further. So remember, DKA, total body deficit of potassium, is very high, and even if the normal serum level is found, it may fall. Cirrhosis, because increased risk of HE, severe ECG changes, especially prolonged QT, and patients on digoxin, myocardial ischemia, heart failure, etc. A few principles of how do you replace potassium. So this is often quite confusion with people. Sorry, just maybe 2 minutes more, 2 or 3 minutes. So that you have to think of so many things, the dose you want to give, the dilution, and the rate. So remember that 1 milliequivalent drop in serum potassium leads to a deficit of 200 to 400 milliequivalents in the body. That means you will have to replace that much. But of course, you cannot give it too fast. If the level is 2.5 to 3.5, you may not need IV. So very often we overdo IV potassium replacement. So anything above 2.5, and if the patient can take orally, you can give just oral potassium. If it is less than 2.5, then IV replacement is mandatory, or those who cannot tolerate oral potassium. So if there's no red flags, hemodynamically stable, potassium less than maybe 2.5 to 3, you can give orally just potassium chloride, 10 to 40 milliequivalents every 8 hours. It should be accompanied by a lot of water, because otherwise it's irritating to the esophagus and the stomach. Sometimes you can also give a combination of oral and IV treatment. Now, IV potassium infusion, so it should be always diluted in 0.9% saline or 0.45. Okay, never dilute in dextrose, because dextrose will make the potassium go into the cells again due to insulin release. The general rate of infusions recommended is 10 milliequivalents per hour only through a peripheral line, or 20 milliequivalents per hour through a central line. That's because it is very irritating to the veins. So you can't give a concentrated solution through the peripheral line. And in special situations, you can give 40 milliequivalents per hour. Now the last 2 points, the bolus of 20 milliequivalents in 10 minutes, that is 2 milliequivalents per minute. This is, I have not found any authentic reference for this, because it's obviously very, very difficult to study. But I didn't find an authentic reference, but it is quoted in all the emergency medicine sites and blogs and things like that. There is a very old reference saying it can be given. So this, remember, it's only during arrhythmias or cardiac arrest, which is known to be due to hypokalemia. So you know the patient had a very low potassium, you started treating, and the patient arrested. Then only you can use this dose, which is 20 milliequivalents in 10 minutes during arrhythmias, or in cardiac arrest itself, 20 milliequivalents in 2 minutes. So dilution, you're supposed to put only maximum of 60 milliequivalents in 1 liter. In 100 ml, you can give 10 milliequivalents, and in 1 liter, the maximum is 60. Now, if you want to correct it more aggressively, and you have only peripheral lines, so start 10 milliequivalents per hour in one peripheral line, and another 10 milliequivalents in the other peripheral line. So that way, you're giving the patient 20 milliequivalents per hour without a higher dilution, higher concentration. What about if the patient has got volume overload? So if you're giving 60 milliequivalents in a liter and you want to give him that 60 milliequivalents in 2 hours, that means you have to give him 250 ml per hour. But that is not possible if they're volume overloaded. So in that case, you will have to have a central line, and you can dilute 40 milliequivalents in 100 ml and give it through the central line over 1 hour or 2 hours. The response to replacement, so initially it may rise very fast. Because the serum potassium will rise, but then it goes into the cells and later it will drop. So there's no point in a very rapid correction. You have to do a slow correction to allow the potassium to go into the cells. When do you monitor? So for hyperkalemia, I said you monitor it after 60 minutes. Here you should monitor it every 2 to 4 hours at least, or more frequently if you're giving it very rapidly. So rule of thumb is, after giving every 60 milliequivalents of potassium, you have to repeat a test. So again, an algorithm which is summarizing everything. So these are all available. You all can look these up, and it's quite useful to look at these algorithms. This ECG, anybody quickly? I know I'm exceeding time, but just come. Tossards, okay? So this tossards is very, very common with can occur with hypokalemia, but very common with hypomagnesemia. And if there's a combination of both, then extremely common. So it is quite common in hospitalized patients, hypomagnesemia, and frequently coexists with other electrolyte abnormalities, especially in heart failure patients who are on diuretics. And these are the fatal complications. So you can have ventricular arrhythmias, coronary artery spasm, and sudden death. Is the level reliable? Now, firstly, we will not get the magnesium level in the emergency department. And is it reliable? Now, because it's an intracellular cation, often serum magnesium may be normal, but the body deficit will still be there, just like for potassium. And you may have false low levels if the albumin is low. So the clinical assessment of patients at risk for hypomagnesemia is very important so that you can treat it. So remember again, patients with heart failure, MI, already have hypokalemia on diuretics, they may have magnesium deficiency. So causes, again, renal loss and GI. So chronic GI disorders more commonly will cause things like diarrhea, malabsorption, bowel resection, and renal loss due to alcoholism, chronic fluid therapy, diuretics, metabolic acidosis, etc. Common drug, most common drug is diuretic, and remember also amphotericin B. Clinical features, here again we are most concerned with the neurological and the cardiac. So cardiac, they can cause ventricular arrhythmias, AF, SVT, coronary vasospasm, acute MI, acute cerebral ischemia. So a lot of risk with severe hypomagnesemia. When do you say it is severe? If it is less than 0.5 millimoles. So if it is less than 0.5 millimoles, then you have to give parenteral magnesium, and an IV infusion will increase the magnesium. And you may have to give a higher dose. So again, just like potassium, you have to replace it slowly because it has to get into the cells. If you give it too fast, you may cause hypermagnesemia, which will again cause muscle weakness, respiratory failure, which you have to treat with IV calcium. So the dose of magnesium, if the patient is symptomatic, hemodynamically unstable, you give 1 to 2 grams initial dose. You can give it even fast within 5 to 60 minutes, followed by an infusion, which will go over about 12 to 24 hours. If the patient has got torsades, give an immediate dose of 2 grams, around very fast. You can even give it within 2 to 15 minutes. And pre-eclampsia, I've just put it here for you to know that's the other indication for magnesium, but the regime is quite different there. So thank you very much. If there are any questions?
Any questions from the audience?
Just some comments. Excellent presentation. So I had a patient a few years ago, came with vomiting and diarrhea, and he was vomiting in the emergency department. So I asked them to give ondansetron, and the patient went into torsades. And immediately we gave magnesium and everything came back, but the ECG, the QT was 523 milliseconds, and the potassium was 1.9, and the magnesium also was like 0.9 or something like that. So what I'm saying is, this patient, the nurse asked me, that patient is vomiting, can I give Zofran, which is ondansetron? So I said, I was busy with the other patient, I said, okay. So then when I went and asked the patient, the history was the patient had been vomiting and having diarrhea for like 3 days, So that's what I'm saying. When patient is having this chronic for that, you always think that they might have hypokalemia, hypomagnesemia. Don't give ondansetron without a ECG, before. That's a very important point. I learned from that, number one. And another patient, this is hyperkalemia. The patient was a type 1 diabetics. He was in diabetic coma. The EMS brought him, and they intubated the patient on the way because his GCS was very low. And anyway, whatever. They intubated and brought him to the emergency department, and the patient was like having sine wave and pulseless electrical activity. So immediately we gave calcium. We started chest compression, gave calcium, and then after 2 vials of calcium chloride, his QRS narrowed, and he was in sinus tach. So his potassium came, this is the highest potassium I had seen, 9.8. And his potassium was 9.8. And what had happened is this guy had also renal failure, diabetic nephropathy, type 1. And his creatinine was 8.4. And he had not taken his insulin. He ran out of insulin. And he was having polyuria and polydipsia. And he was drinking orange juice. Orange juice has a lot of potassium in it. And so that caused the hyperkalemia. And while coming, the EMS had used succinylcholine to intubate the K. So that causes hyperkalemia. So that is why he was like, from the EMS stretcher to our stretcher in the ED, he arrested. And with calcium chloride and everything. And he went to dialysis after that. So that's what we have to always think of. You know, you don't have any time to even diagnose hyperkalemia. You have to look at the sine wave, or if the patient has a left bundle branch or wide QRS, bradycardia, always think of hyperkalemia. When the patient is having like bradycardia, wide QRS complex, and is pulseless electrical activity, just push calcium. That's all I can say. It's very, very life-saving. And, you know, you need to know this. It's very important. Thank you.
I think the other issue you should also realize is that these potassium disturbances, whether they are hypo or hyperkalemic, if allowed to persist for a longer period, can lead on to rhabdomyolysis. And the setup required that it may occur is in a setup of thyroid disease. And it becomes very tricky at times, because what happens, you have a disease called thyrotoxic periodic paralysis, which is peculiar to the Southeast Asians. It's a genetic predilection. These patients come with hypokalemia, and you treat potassium, and you start treating the other disease with altroxin and all that, and you land up with hyperkalemia. And this happens like, let's say, within hours. So you have somebody with potassium 2, you start treatment, and you find at about 4 o'clock, maybe 3-4 hours later, potassium is 7, is 8. So these are very patients where you need intensive monitoring. Maybe you might have to do every half-hourly potassium levels to keep a track on them until their metabolic milieu has been restored. And rhabdomyolysis is a well-known complication. Once you land with rhabdomyolysis, then the nightmare starts.
Yeah, this thyrotoxicosis, periodic paralysis, the potassium supplementation has to be very, very careful. IV and frequent checking. The patient has to be admitted in ICU and all those things. And otherwise, if the patient is having vomiting, diarrhea, and all those things, if they can tolerate oral, give bolus orally. 60 millicoulomb, if you give oral, nothing happens. And then you can give slow IV also. But because, but don't give like that for a thyrotoxic periodic paralysis patient.
Yes. I've been instructed it's supposed to be a short comment, but this is not going to be a comment actually, it's going to be a question to all the young people who are here. Because you've heard a lot about hyperkalemia, and as the wonderful lecture given by Dr. Shakuntala, if you've been working in an emergency for a month, you would have encountered a patient with hyperkalemia quite often. Let's say you've been working in the emergency for 6 months or so, and I'm talking about a real patient which happened to me, where a young resident came up to me 6 months down the line of his training and said, "Sir, I've got a patient who's got a potassium of 8.7. I said, "Oh my God, that is significant, because I don't think I've seen 8.7. What's wrong with the patient?" So basically, he's not come with any particular problem except that he's had dermatitis for the last 6 months. So I said, "Oh, okay. So what would you like to do?" So I'm posing you the same question. What would you like to do? Those of you who know the answer, please don't say anything. What would you like to do? I'm asking you. It could be you, or it could be your resident coming to ask you this question. I've got an 8.7 in a patient who's got dermatitis. Come on. I haven't heard anybody speak this morning. That's why I'm asking you this question, because for the last 2 speakers, there has been absolute sound of silence. Huh? Anybody? Come on. Take a chance, man. ECG. Repeat the sample. You're the man of the day. Okay? You're the man of the day. Well done. Please remember the caveat that I wish to add whenever we are managing hyperkalemia, if the patient doesn't have a problem. See, all the ones that we have talked about are patients who have had problems in whom we have confirmed the fact that the patient has got hyperkalemia. But I'm talking about the converse, where there is a patient who doesn't have a problem to be having hyperkalemia, but if you find the value is high and the patient is okay, it's fine if they want to give calcium, no harm done. Okay, that's cowboy style. Shoot first, ask questions later. Calcium is fine with me, not a problem. Okay, go ahead, give calcium. But don't start the other things. Check the sample, because the commonest error, if you talk to a biochemist, a clinical biochemist, they'll tell you, so the commonest error for hyperkalemia that we see in a series of errors in the lab are because of either iatrogenic, or it could be delay in transport to the lab, or it could be a problem in the lab, whichever it is. The commonest error which occurs due to investigation, investigational error as it is called, is hyperkalemia. So keep that as a caveat to what you've heard today on electrolyte imbalance. Okay?
This one small. And the other one, please be careful when you're always question the resident. If it's a fast draw through a small needle, you may have hemolysis. And that is a very common mistake made.
Thank you, ma'am. That was an excellent discussion. Now we have our next speaker, Dr. Bhavesh Jarwani. He's an associate professor at NHL Medical College from Ahmedabad. He would be talking about our substance guidelines for resource-limited countries.
And it's a big problem. Skills. Very good morning. I'm Dr. Bhavesh Jarwani, Professor in Head, Department of Emergency Medicine, NHL Medical College, Ahmedabad, Gujarat. Firstly, I apologize for not being there with you. I miss you all. I tried my best, but because of NMC assessment, my leaves were not granted rather than cancelled at the last moment. Anyways, I thank you and all organizer for inviting me. And yeah, congratulations all of you for starting this new chapter. And it's a nice event by the educators of emergency medicine. It's a new chapter in history of emergency medicine of India, and all the best for the same. Yes, my topic is, are sepsis guideline appropriate or applicable to the resource constrained emergency departments? This slide itself says, like, you can see there is a Bhuvan, he is a well-known character in the movie Lagan. It represents a resource constrained setting. And here is a resource rich emergency department. Whether the applicable resources or the guidelines are applicable to both the place same or not, there is a topic that I'm going to talk. This is a beautiful place where I work, SVP Hospital Ahmedabad. So the burden of sepsis is immense. You can Google, and on WHO website, 2017 numbers are scary. 49 million cases of sepsis, of which 11 million died. That constitutes 20% of global deaths. So it's a big number and it's a big problem. Skills scarier than that is the children under the 5 years of the age, they are 41%, and the mortality is 46% among them. And in resource constrained country, this case is 85% and 84% mortality. So you can imagine the burden on the resource constrained setting and see the mortality. So what are the weapons we have to fight against in mammoths? Well, in resource restrained and resource rich country, we'll talk about that. The sepsis guidelines are there, and it started with early goal-directed therapy in 2001 by reviewers, and it has evolved by sepsis bundles, early identification, lactate, culture, antibiotic, and so on and so forth. So now this therapy has been, now we can say it's a standard of care. But whether the standard of care applicable to resource constrained countries or not. Well, for the benefit of the resident, I brought the simpler slide to begin. In early goal dietary therapy, the goals are to achieve CEP more than 8 to 12 mm of Hg, MAP of more than at least 65 mm of Hg, and SCVO to be more than 70%. But you can imagine how to measure these things in a resource constrained country where CEP line is not put, or where good SCVO2 measurements are not possible. So guidelines are there since years, but it's difficult to apply in a resource constrained country. We will talk about the recent guidelines and their limitations for the resource constrained country. Like these guidelines, known as the Royal Sepsis Campaign, they were published October 2021, and now the emphasis more is on early diagnosis as well as on the post-sepsis recovery care. That was not that much highlighted in the previous versions. Yes, the guideline says that lactate measurement should be there, not only for diagnosis but for follow-up therapy. Initially, if the level is more than 2 millimole per liter, it should be measured every 2 to 4 hours. Now, in many resource-constrained setup, lactate levels are not available. So it's very difficult to apply this line. Apart from that, lactate level also guides for the resuscitation progress, like how much fluid to be given. But that is also not feasible because of not availability. For fluid responsiveness, nowadays, dynamic measures are better than the static measure, as guideline says. And yes, dynamic measures like cardiac output measuring, stroke volume, SVR, and all things are good, but they're very difficult. You will agree with me that in poor setups. Yeah, for that part, we can still use capillary refill time or straight leg raising, like SLR is done for 60 to 90 seconds. And if mean BP increases by more than 15%, is suggestive of a fluid responsiveness. So this kind of measures can be substituted, but this guideline to be applied directly for the resource constrained country, it's difficult to measure dynamic parameters that way. For antibiotic, it is recommended in septic shock, it should be within 1 hour, and in sepsis, unproven shock, within 3 hours. But in many parts, it's difficult to take blood culture as required before starting antibiotics at 2 in number and 2 different sites. It's not possible because of the financial constraint. And antibiotic supply is not consistent, good quality. And like the recommendation is to start MRSA coverage and multi-drug resistance organism guideline. Now that's difficult to apply in resource constrained country, and that will within 1 hour. Other biomarkers like procalcitonin, it guides for not only starting antibiotic but to de-escalate antibiotic. It's not available in many setup. For hemodynamic measurement, a balanced crystalloid is advocated, but it's costlier than the normal saline. But if you give more normal saline, there are more chances of hypochloremic metal acidosis and other untoward side effects. So, but balanced crystalloid are costly, so that thing has to be kept in mind. For vasoactive agent, norepinephrine and vasopressin are advocated more than the dopamine and epinephrine. But the cost-wise, it is other way around. Norepinephrine and vasopressin are costlier. So norepinephrine may be 300 rupees per vial per ampule in India. But other things like dopamine epinephrine are cheaper. So it's difficult to apply norepinephrine vasopressin as a first line, as it is recommended first line as a norepinephrine and then vasopressin to be added on, depending on the response, depending on the responsiveness after obviously giving proper fluid resuscitation. But it's not also feasible. Apart from this, these are few of the points taken from the guideline that these bigger points are also not possible in your resource constrained country. But other major things are also lacking are like in say resource restrained country, malaria is a big problem. But that is not there in the guideline. Dengue, tuberculosis and its complication, HIV and secondary infection, opportunistic infections. These type guidelines are not there, but they are more problem in sub-Saharan and resource constrained countries. But in guideline, it is not highlighted very well and when to get the reports done for this and how to go about. These are things not there in the guideline that are applicable more to the resource rich countries. So these are few limitations of the guideline apart from the guideline, apart from the limitation we saw in a couple of slides before. Well, the guidelines were applied in United States and the studies were suggestive of encouraging result. But at the same time, once these guidelines or this, you can say, standard of care nowadays, because this thing are known as standard of care as well. So if those things are applied in resource poor countries in sub-Saharan study of this, it was showing more mortality. I think because the case selection, data collection was not appropriate, apart from maybe because of certain limitation, the protocol cannot have been done properly because, one size never fits all. In one another example of protocolized treatment experience in LMIC, the fluid was rather more given than the required. I think because of lack of expertise, of training in all level of staff and equipments, inadequacy, maybe the cause of this kind of results. Likewise, in one study, it was found that to put a center line almost took 2 hours rather than putting peripheral line and giving resuscitation measures. So these things, because of limitation of expertise and maybe gazettes there, are a cause of difficulty application. In one meta-analysis, it was found that this meta-analysis tried to find what are the causes in resource constrained countries for applying the survival sepsis guideline appropriately. And it was found that it started with the community level challenges like community has ignorance, poverty, they come very late. Here we are talking about 1 hour, 3 hour, 6 hour bundles, and they are coming maybe 1 day, 2 day later because of the patronage of the quack. So these are main constraint as well. Coming to the hospital level challenges, as I already said that there is a delay in diagnosis, poor laboratory, inconsistent supply of maybe antibiotic and other equipment. So these are all the limitations of resource constrained country that hinders the application of this guideline for optimum outcome. And again, malaria, dengue, and all things are not touched upon. So if you put all the limitations in a single slide, let me go very fast. Like staff training and ICU beds are lacking. Norepinephrine, dobutamine, a bit costly for the setup. Selected level and prolactin not available. Dynamic hemodynamic measures not feasible. Central line, arterial line difficult because of lack of expertise and equipment. And SCVO2 again out of the scope. So all these limitations leads it makes it very difficult for all these guideline updates that come very frequently by even pediatric societies for pediatric sepsis guideline and for adult guideline, but difficult to apply in this resource constrained setups. So what are the options available for those setup? Early recognition, for that simpler definition, society approach, that is important, and then some acute and post-acute intervention that can be tried. We'll talk in a couple of slides. Like sepsis 3 definition touches upon like life-threatening condition caused by dysregulated host response to the infection, resulting in organ dysfunction. Right? But in many setups, it's difficult to find and diagnose the organ dysfunction without investigations, obviously. So difficult to apply in resource constrained country where the simpler definitions still are advisable, like patient of suspected infection with more than two following, like heart rate more than 90, respiratory more than 20, temperature more than 38, or malaise and apathy. Even two of these are there. Uh, Patient can be diagnosed sepsis and can be maybe referred to appropriate setup or treatment can be started earlier. So what are the acute intervention that can be applied even in any setups where resources are a problem, like oxygen administration to maintain the saturation more than 90%, semi-recommended lateral position, non-invasive ventilation so far possible, adequate fluid to achieve adequate tissue perfusion by monitoring arterial BP or non-invasive BP and capillary refill time. For fluid responsiveness, you can use straight leg raising test, as I said before. Norepinephrine is the first line in sepsis management should be made available in all countries by appropriate political commitment. And like simpler time for the patient and repeated blood pressure, pulse, heart rate, respiration, capillary refill time, monitoring, that helps for knowing more need of fluid or resuscitation measures and other guidelines wherever possible to be applied and timely intervention by appropriate adequate antibiotic. And last but not the least is source control. It's very important even in all setup any resource recent country. It is very important to find the source and multidisciplinary references to take care of that and find even malaria, dengue, HIV, certain things are there or not should be definitely touched upon. These are all the acute intervention. What about post-acute intervention? Apart from that, simple hand hygiene, uh, simple things to take care of the hospital-acquired infections can also help in the resource-constrained country, like uh, peripartum sepsis, children's sepsis. All that can be taken down by simpler measures like hand hygiene or appropriate hospital infection control commitments. Coming to the post-intervention, acute intervention like regular assessment of antibacterial therapy, because procalcitone is not available, you have to go with the clinical interventions. Avoid hypoglycemia, maintain it around say not less than 60 and not more than 140 either. DVT prophylaxis, yes, by stockings or LMWX, whatever possible, but add on to that early mobilization, resumption of the oral food intake, and active weaning from invasive support whenever possible. So these are the things, simpler things can also go a long way for optimum or better results in resource constrained country. And I always, and you may have 3 times the same thing like malaria, dengue, and all. Yes, because these are the big problem in resource constrained countries like dengue, malaria, and all. They're causing more death than the septic shock because of other causes as well. So this thing has to be kept in mind while we apply the guidelines that are made for resource rich countries, but it has to be modified for our local environment. Like I said, hand hygiene, patient monitoring, multidisciplinary care, and transport to appropriate facility for applying better care should be definitely a priority in the mind once we are dealing with a sepsis case in resource constrained settings. Here's the same thing in maybe flowchart form, like active search for infection is always a priority. Then the circulation by fluid, vasoactive, ventilation, antimicrobial, and then source control and appropriate diagnosis by like malaria, dengue, etc. So these are the things for acute intervention and post-acute intervention. As already said, glucose control, DVT prophylaxis, oral feeding, and start mobilizing as soon as possible. So this simpler thing can go a long way for taking care of the patients rather than applying the guidelines that are made by and for the resource rich countries. Yes, those take home messages that guidelines are there and they are coming very frequently but difficult to apply in mainly LMICs, that is low and middle income countries, and that needs to be modified as per the local need as we have discussed in the slides. and that should be made available. And again, the local problems should be dealt so as source control. So thank you, and these were my guideline, my thoughts on sepsis control in the source constrained countries as well. And I'm again sorry for not being there with you, but I miss you all, and I'm here for any question to take. Thank you.
Talking about whether we can apply the sepsis guidelines to the country which is still resource constrained. So,
Hi, my name is Professor R.K. Singh. I'm from SGPGI Lucknow. You talked about the low resource settings. So how do you compare the central line versus a peripheral line for the infusion of vasopressors? Your take on central line versus a peripheral line for infusion of vasopressors in septic shock?
you are muted.
Can't hear. We can't hear. No, just show by sign, because he probably can't hear you also.
I can't hear you.
You're muted.
The link is gone.
Mr. Shiva? Should we keep this something? Can you please speak now? No, we are not able to get you. So there's some technical issue happening wherein we are not able to get you. The team is looking into it. Once, check once. Please start speaking once. Sorry, we are not able to get you even now. Yes. So that is a good thing, sir. I was suggested that I'll make a phone call. Yes. We can't hear you. So what we'll do is we'll take a phone call and you can answer it and I'll put the phone on the speaker mode and I have a phone. My phone is there. Yeah, my phone was there. Yeah? No. Dr. Asher, please. So while I'm making a call to sir, I would appreciate if there are other questions or some comments on this.
Actually, in the US, in our institution, we put peripheral line, and if they don't, and we monitor for any extravasation every 4 hours. There is a nurse who will, look for extravasation and make sure that the IV is very good. Then it can be done. But that's very.
Yes, so he's online. So please, you can speak your answer, please. You were able to hear the question which was put to you, Dr. Bhavesh? Yes. Yes. please answer. He's gone mute. What has happened? We have lost him again. Are you able to hear us? Okay, no. Yeah. So can you please answer? Probably the problem is there. Even his phone is not able to. So what I'll do is that I request Dr. Bhavesh to please record an answer also. I'm so sorry. We are not able to technically connect with you. And we'll move to the next talk. Thank you so much, and please be with us. And I will move to our next talk with Dr. Just a minute. Dr. Chirag Patel, who would be talking to us on Dr. Suthanithara Kanan Ramamurthy sir from Royal Darwin Hospital, Australia, and he's talking to us on hematological and oncological emergencies. Thank you, sir.
Good morning, everyone. Thank you for the organizer. I think we are running short of time, so I will finish as much quickly as possible. See, these hematological malignancies can present to any ED or even any general hospital anywhere, and it is for for a general physician to know what common emergencies they face with, and they have to deal with that. Mediastinal mass is a very commonest presentation. It can present in ED or any hospital, and these patients may come with respiratory distress, chest pain, or even may have positive Pemberton sign. So, what is the difference between the previous one and the current one? Patient has pleural effusion here. There is no effusion. So what it makes a difference. Here, if the patient is asymptomatic, you just send it to a center. If you don't have a interventional radiologist to do a core biopsy immediately, send it to a center, and then you can wait for the result to start the treatment. But if the patient has symptoms, then there are many tumors which can produce mediastinal mass, and they can respond either to urgent radiotherapy or steroids. So you can give both of them and then go for a core biopsy. Basically, this radiation and urgent steroids may produce some necrosis. So you may have to be, if you have done prior to the diagnostic biopsy, you have to make sure that interventional radiologists do multiple core biopsies to make sure that you don't stick onto the area of necrosis, which can be caused. But if there is a pleural effusion, it is very easy. If you tap a pleural effusion and you run in a flow cytometry, the flow cytometry will tell whether it's a hematological malignancy, and it will give an exact diagnosis as a large cell lymphoma or T lymphoblastic lymphoma. Some of the non-hematological malignancy may not be diagnosed, but it will tell you that it is a non-hematological malignancy. Yeah, so this is what. And SVC obstruction, if it is present, you have to go for steroids and RT immediately. This is diagnosed by Pemberton test. In a good center, a true cut biopsy will give a diagnosis in 48 hours. So you have to make sure the patient is in a place where intervention radiology is available. You have to make sure that somebody is there to do a flow cytometry if there is a pleural fluid. Flow cytometry can be done not only in the blood, but in any fluid available in the body. Second thing, say, as a pancytopenia, most of them don't recognize that a fever in a patient with a neutrophil count, normal absolute neutrophil count is more than 1.5. It is around 2.5. But if it is less than 1.5, it is mild, and if it is less than 0.5 to 1, it is moderate. If it is less than 0.5, as it is shown here, it is very severe. The problem is these patients, because they don't have neutrophils, they get infections not from outside. They get the infections from their own body, from the gut flora. When it goes into the bloodstream, it causes infection. And because they don't have neutrophils, they release a lot of cytokines, and these people may go into septic shock. And if they go into septic shock, you may think that the patient came with a mild fever and may die with the septic shock within 4 to 6 hours. So the recommendation worldwide is you have to start a broad spectrum antibiotics. If it's a known center, they will have the guidelines on what antibiotics you have to start. But if it is some other hospital which don't deal with the hematological malignancies, you can start on cefepime or cefoperazone sulbactam or tazocin or meropenem, whichever you think it's suitable for the patient. And in some centers where MRSA is prevalent, the guidelines say to add vancomycin at the initial presentation, and then you can always step down. Within 24 to 48 hours, you may get a blood culture report, and then you can step down to one antibiotic, which is a suitable antibiotic. Yeah, so based on the patient's penicillin allergy or not, you decide the antibiotic. Make sure you give the antibiotic within 30 minutes. That is very important. So, the other thing which I always tell people is there are 3 tissues, three cells which liberate potassium. Number 1 is lymphocyte, number 2 red cells, number 3 liver. So, any malignancy or a hematological problem, if you suspect, please do LDH, which is not routinely done even in very major hospitals. And it will give a very quick clue that you are dealing with a hematological problem. This patient has come with the anemia, and the platelet count is very, very low. And LDH is high. Okay. So if the LDH is high, then you know that the red cells are damaged. So it may be, so this is not a pure patient may, so this is not, this may be a pure EVANS, which is a autoimmune thrombocytopenia plus autoimmune hemolysis, or it can be a microangiopathy. A microangiopathy is a very serious condition. There may be it can be a simple TTP or this CAP syndrome, or it can be any other types of microangiopathy, which is serious and in which the transfusion of platelets are contraindicated. So that is why you need to know when you are dealing with a patient with a pancytopenia, whether I am dealing with it can be just an ITP, patient had a bleeding and come with a low hemoglobin, or it can be just a destruction of both RBC and platelet, or it can be a microangiopathy where platelet transfusion, patient can come with the microangiopathy, patient can come with the platelet count of even 4,000. And we advise platelet transfusion only to insert a central line. You can just give platelet, insert a central line and leave it. And they don't need prophylactic platelets, they will never bleed. And fortunately, whether it's an autoimmune or a microangiopathy, steroids will be the first line of treatment. But steroids alone may not be enough in microangiopathy. You may have to start plasmapheresis and anti-B cell antibodies like that immediately. So, but the diagnosis can be made within 4 to 6 hours if you have quite a good lab with people who can look at the blood smear and tell you what is happening. If you have a good blood bank and the lab, they will give you a diagnosis in 4 to 6 hours. And AHA, I have to, this is a very common disease, which I have to emphasize because, see, once you know the direct home test is positive and there is evidence of massive hemolysis by high reticulocyte count, high LDH, don't waste time, because these people, even if you transfuse, the transfused blood is not going to stay, and they're going to form more antibodies. So if they don't respond to steroid, if they come with a hemoglobin of 6, you have plenty of time. If they don't respond within 24 to 48 hours, you have to add rituximab, you may have to add a few more drugs which can add immediately. So you can't allow the patient to go down to hemoglobin of 3 or 2, and in fact they cannot be resuscitated because no other treatment will help them. Okay, so patients coming with abdominal pain, sometimes it may not be radiating, it may be localized to right lower quadrant. This patient, it's a patient which I saw a few months back and has come to ED 2 or 3 times with persistent pain in the lower quadrant, and they did a CT with CT was found to be normal, and the patient had only symptom being weight loss, mild weight loss. So he didn't have any other systemic symptoms. Pain has been intermittent, but he was on analgesics managing that. But sometimes when the pain is severe, he again comes back to ED. The only caveat in this case is sometimes when there is repeated pain, we forget to look at the vertebra, which is often missed by the CT scans. So he had an MRI which showed a spinal cord tumor, and sometimes they have a classical radiating pain, sometimes have a neurologic deficit, bladder dysfunction, which you can easily find out. But if they don't have, they come at an earlier stage, you have to remember that you may have to do a MRI in a case of abdominal pain. And management of spinal tumors is similar to mediastinal mass. It can be due to any tumor, but because myeloma is very common, these are the various tumors which can present in the vertebral column. I will tell you a simple clue for a myeloma. Myeloma, if you do a basic blood test, you may or may not have CRAB features, which is hypercalcemia, renal dysfunction, anemia, which you may or may not have. But the most important diagnosis which can be made in 2 hours is you can do a serum immunoglobulin levels. You do IgG, IgA, IgM level, okay? And this won't confirm the diagnosis, but it will give a clue, because serum protein electrophoresis will take 3 to 4 days, even in good labs. And serum free light chain, which is quite sensitive, usually takes 1 week. So these 2 tests are necessary for confirming, but by doing a serum immunoglobulin level, say for example, the normal IgG level is up to 8 grams. In myeloma, you get an IgG of 25 grams. And how do you differentiate between reactive hypergammaglobulinemia, which occurs in a lot of autoimmune diseases and sepsis? You have hypergammaglobulinemia, even in HIV infections. The difference is very easy, because here you have an elevated IgG, but depression of IgA and IgM levels will be low. That's called immunoparesis. The immunoparesis never occurs in any reactive condition. And in a light chain disease is one where it is caused by lambda or kappa light chains. It is not by heavy chain. In the light chain disease, which can be picked up only by serum free light chain, which can take 1 week, it can be picked up by pan immunoparesis. You can see IgG, IgA, IgM levels all are low. So you can suspect myeloma within 2 hours when you do these levels, and other diseases may need an urgent biopsy, and then depending on if the patient has a spinal instability, go for urgent neurosurgery. If he has a local pain with no fractures, go for radiotherapy, and if there is no local pain or fractures, you go for high dose steroids. So these are all general things which everybody will know. Okay, so this is another young male presented with mild cytopenia. Patient presented to gastroenterology because of ascites, and to our center. Is absolutely fit patient, suddenly crashed within 1 or 2 days and has developed ascites. So the one tumor which grows very, very rapidly is Burkitt's, or a high-grade lymphoma. It will grow as if like a mason building a wall with the bricks. Yesterday, if you had seen an ultrasound, it will be 3 centimeters. Today, it will be 5 to 6 centimeters. And what it causes is it infiltrates into the peritoneum, causes massive ascites, and then it liberates a lot of uric acid, producing renal insufficiency, and the patient may die. This is also picked up by high LDH. And if you take a diagnosis, if you take a sample of ascitic fluid, you can get a diagnosis in the flow cytometry in 2 to 3 hours. And you start steroids and give low dose cyclophosphamide, make the creatinine, give hydration. Once the creatinine drops, then you do a CT, and the CT abdomen showed multiple huge masses. Then you can do a true cut biopsy, because histological diagnosis is always needed. You can't only rely on the fluid diagnosis. Then you can do a biopsy after 4 or 5 days. Malignant hypercalcemia, I think the thing is, you know how to manage hypercalcemia. I don't want to go into it. It's just hydration, give zoledronic acid, then calcitonin if needed. But the most important thing is hypercalcemia worsens renal failure, and hypercalcemia, you have to identify the cause of hypercalcemia. That is very important. So what you are dealing with, are just dealing with elevated parathyroid hormone or a malignancy. If it's a malignancy, it can be occurred like a thyroid. So you have to find out where it is, and then the treatment has to be initiated, or it can be an established tumor with a spontaneous tumor lysis syndrome, which can be managed. So management, everybody knows, but you have to identify what is the reason for the hypercalcemia. I think that's it. You start allopurinol fluids, don't combine raspabric acid with allopurinol, and that's it. Your nursing team is also very important in managing any emergencies. Thank you.
Can you hear me?
Yeah.
Yes. My name is Suresh David. I'm a fellow of the Australasian College of Emergency Medicine.
Okay.
I've lived in Australia for nearly 6 years. Which part of Darwin are you from? And which department do you belong to?
Hematology. I belong to
Hematology.
Yeah. It's in Royal Darwin. Yeah.
Right. Because you don't sound like a person who is aware of the Australasian system, because that's not the way we do it in Australia. And this is not the way we do it in the emergency department in India. Because between your cases of 1 and 2, which was going back and forth, I didn't know whether I was coming or going. I could not make out head or tail of what you were trying to tell us.
This is for common physicians and general
This
people.
is an emergency medicine conference. So
yeah.
Thank you very much for your presentation.
Questions? Thank you, sir. So we invite Dr. Chandni ma'am for our next session on endocrine emergencies. Ma'am, Dr. Chandni ma'am, please.
Respected, esteemed colleagues, postgraduate students, and dear friends, thank you for the opportunity. Special thanks to Dr. Arunachalam and Dr. Ashima, who are the master brains behind this great meeting. I'll be, over the next 15 minutes, I'll be taking through important endocrine emergencies that we are likely to see in the emergency medicine when we practice. Hope I can move the slides. Okay. As we all know, endocrine emergencies are complex, uncommon, yet life-threatening conditions. And they usually present with non-specific early clinical signs. And if we are really aware of these things, we will be able to identify and will be start to initiate the right treatment at the right time. And it's most of the time, they are really life-saving. So I'll be just taking you through the life-threatening conditions or life-threatening endocrine emergencies that we are going to see. And most of them, I'm sure all of us are doing in our daily practice. and we know how to manage them. So I'll be taking you through some of the important points I thought needs emphasis. So it could be diabetes related, like diabetic ketoacidosis, hyperglycemic hyperosmolar state, and hypoglycemia. Hypoglycemia is always the one that we have an immediate diagnosis and we have an immediate way to treat, and it's usually life-saving. And thyroid related could be thyroid storm and mixed edema coma and adrenal insufficiency. So we'll be just going through 3 of these situations. And diabetic ketoacidosis, as we all know, the triad, hyperglycemia, metabolic acidosis, and ketoacidosis. And in type 1 diabetes, it could be the first presentation, insulin omission in most of the situation, and sometimes people fail to follow the sick day rules. They may be having some infection and they really skip when they are not eating properly. And of late, maybe insulin pump failure once in a while, we all are likely to see, and some of them might have already encountered the problem. And type 2 diabetes, there's an entity that is coming in a big way, that is ketosis-prone type 2 diabetes. We need to recognize it, and patients may go back to oral drugs once stabilized. And pen or pump failure, technological failure, always a problem we need to keep in mind. Drugs, infections, infarctions like myocardial infarction or stroke, we may be carried away by the presentation, but they may be having coexisting diabetic ketoacidosis or hyperglycemic hyperosmolar state, or that may be the cause or the effect. And there are many drugs that we use causing ketosis in patients with type 2 diabetes. And euglycemic diabetic ketoacidosis, we all know because of the use of SGLT2 inhibitors, we are likely to see this kind of presentation where the blood glucose may not be that high as we expect in diabetic ketoacidosis, and alcohol and pregnancy related, we may have low blood glucose not to the value that we expect in DKA. Hyperglycemic hyperosmolar state, we all know because of the relative insulin deficiency, happens in type 2 diabetes with extremely elevated blood glucose, may be as high as 600 milligram per deciliter or more, with increased serum osmolality to the tune more than 320, with significant dehydration and absent or mild ketosis. Understanding this, the volume depleted state, the fluid resuscitation will be more important, and insulin requirement may be less compared to diabetic ketoacidosis, but we can also see mixed hyperglycemic hyperosmolar state and diabetic ketoacidosis as well. And in euglycemic diabetic ketoacidosis, glucose may be less than 250 milligram per deciliter, serum beta hydroxybutyrate generally more than 3 milliequivalents per liter, and patient presenting shortly after receiving insulin. Somebody referred from outside and referred to our ED. We may get a low blood glucose, maybe they have already received insulin, but not the other management of diabetic ketoacidosis. Type 1 diabetes with vomiting on patients with impaired gluconeogenesis, as in alcohol abuse or liver failure. All these situations may have a normal or near normal blood glucose, and still patient will be in diabetic ketoacidosis. And the indication or the reason that has come up is of late is SGLT2 inhibitor use, because it's widely used in the diabetes practice nowadays. And the blood glucose value, the initial estimations we'll be doing will be the serum glucose. Diabetic ketoacidosis, the value is more than 250 milligram per deciliter. Euglycemic DKA, normal to slightly elevated blood glucose level, and in hyperglycemic hyperosmolar state, usually more than 600 milligram per deciliter. HbA1c of help to know, especially the first onset presentation, it could be the diabetes undiagnosed or undetected diabetes, and it will also help us to know what is the glycemic control the patient is having for the last few months. Acidosis, as we all know, it's high anionic gap metabolic acidosis, and in our setting, it's always venous pH is equally good as arterial pH in the management and reassessment in patients with diabetic ketoacidosis, and it is always we need to follow with the standard protocol that we have in our own practice, and always it should be monitored with basic monitoring chart for the best outcome. Go for ketones in blood or urine. beta-hydroxybutyric acid, but beta-hydroxybutyric acid is not measured in urine. So we may get astatic acetone in urine, and sometimes there may be absent ketones, but later it may reappear as it gets converted to astatic acid and acetone. And we know all other electrolytes, sodium, potassium, magnesium, phosphates, lactase, RFT, and serum amylase and lipase is also important. It might be due to diabetic ketoacidosis per se, or it could be a pancreatitis, which is the cause that has resulted in precipitation of DKA as well. ECG is very important in identifying electrolyte imbalances as well. We can also identify whether there is some associated problems like acute myocardial infarction in those patients presenting with DKA, or especially in hyperglycemic hyperosmolar state where we expect thrombotic events more. Cultures are very important. Undiagnosed or undetected infection is the predisposing cause for this sort of presentation. Management, I'm not going to elaborate because we have actually doing it in our day-to-day practice. Fluids, as we tell, in the first 2 hours, we need to give nearly 20 to 30 ml per kilogram, and then for the next 4 hours and next 6 hours, maybe we can reduce the volume, but need to be assessed depending upon the need of the patient as well as the cardiac status and the renal output. Electrolytes, as we have already had a good talk on hyperkalemia, initial presentation may be hyperkalemia or hypokalemia, but hypokalemia at presentation has got more detrimental results, so we need to be more cautious in a patient coming to us with diabetic ketoacidosis, and hypokalemia needs immediate management. Insulin monitoring and consultations, but the therapeutic priorities will be volume resuscitation first and foremost, then correction of potassium deficits, and then insulin administration. So go for volume resuscitation, C for the electrolyte imbalance, especially hypokalemia and hyperkalemia. As we give the insulin, the glucose, potassium may be a relative deficiency, and apparently it will be hyperkalemia and it will be shifted to intracellular. And the rapid development of severe hypokalemia, I have already emphasized, the most life-threatening electrolyte derangement during the treatment of diabetic ketoacidosis. Overall mortality is less than 1% in diabetic ketoacidosis, but we need to remember the number of patients and number of type of patients that we are seeing. It may be different depending upon the center where we are practicing. But in children, especially cerebral edema, and in patients with hyperglycemic hyperosmolar state, the mortality is higher, maybe as high as 20 to 25% in children. So we have to be more careful about that. Complications of diabetic ketoacidosis, as we manage the patient and patient started improving and then coming altered mental status, headache, features of raised intracranial pressure, decreased oxygen saturation, we need to be alerted about the cerebral edema. Hypoglycemia, hypokalemia, hyperchloremic acidosis, hypophosphatemia, hypomagnesemia. These are the electrolyte abnormalities that we are likely to see and should be looking for in the appropriate time. Acute kidney injury is very commonly seen, especially when there is a delay in resuscitation in these patients. Severe dehydration is leading to cerebral or vascular thrombosis, and when we manage a patient with diabetic ketoacidosis, always look for the associated precipitating events. So these patients needs reassessment and examination to identify what precipitated the DKA, and it's not unusual to see patient coming again and again with diabetic ketoacidosis into the ED if we are actually not really looking into the precipitating event in these patients. Complications of HSS, as we all know, it's peripheral arteriovenous thrombosis. It could be myocardial infarction, stroke, rhabdomyolysis, cerebral edema, seizures, lactic acidosis, shock, and acute AKI, and hyponatremia related with the correction-related problems as well. So when this talk was planned, so we know a lot of things that happened in COVID, in the COVID ICU. So we were having a very small ICU connected to ED, but most of the time patients will be transferred. So we have looked into the patients have come to us in the ED in our ICU. We have managed 11 diabetic ketoacidosis patients during the period. And type 1 was 36%, it's only 11, and then type 2, and 18% that 2 of the patients were unclassified, because we know nowadays type 2 diabetes is also presenting with DKA, especially in the young. And we know these patients presented with nausea and vomiting, shortness of breath, dysuria, fever, fatigability, abdominal pain, chest pain, loose stools, cough, hematemesis, and loss of consciousness. And 36% were on oral drugs, 18% on insulin and oral, and 18% type 1 on insulin. And 2 were the first diagnosed cases presented to us. Reason for DKA was non-adherence to medication. First presentation of diabetes mellitus, infection contributed to 73%, respiratory, urinary, and 1 patient leptospirosis with diagnosed diabetes, admitted with DKA, and tropic ulcer with secondary infection. CAD acute MI, 1 presentation, acute coronary syndrome, 2 patients were there, and 1 patient was presented with pancreatitis. And one of the patients of the 11 was with dapagliflozin 10 milligram daily with a blood glucose of 240 milligram per deciliter and presented with DKA. All patients received the standard treatment of diabetic ketoacidosis, and few of them has acute kidney injury, and our patients, few of them, 27% had acute and chronic kidney disease. And I presented this data because our patients, the overall mortality in our ICU is 30 to 35%, because most of the patients taking to ED ICU are really very sick, and among them, this also the mortality was very high. And in this data, infections are the most important cause of precipitating events of DKA. So we should not be carried away by diagnosis of DKA and management of DKA. We should be prompting into what caused the DKA, as we see in any other situation, and appropriate cultures and all those things has to be sent from ICU itself or in the emergency department. And comorbidities and complications decide the outcome, and the type of patients we see in our emergency department that decide the outcome, and we need to modify the treatment according to, along with standard treatment, the ICU care or the immediate management is also critically ill in patients presenting to ED. So this is that most of them had high anion gap metabolic acidosis, and 3 of them had hypokalemia at presentation, and 1 patient had hyperkalemia. So this is the situation that we have come across. This was in the non-COVID ICU, because we see a lot of patients in the COVID ICU, and even the ED ICU was working as COVID ICU during the earlier period. So these were the cause of death. 1 patient with leptospirosis, myocarditis, AKI, DIC, pulmonary alveolar hemorrhage, and LRTA, CAD, acute coronary syndrome with high-risk non-ST elevation, acute coronary syndrome, and cardiogenic shock, urosepsis, septic shock, and acute on chronic CKD, upper GI bleed, pneumonia, pancreatitis, sepsis, and septic shock. So these are the situations, and these are the type of patients that we see critically ill or very serious coming to the emergency department. So we need this I presented because we need to act fast, act appropriately in those situations. So I've discussed about acute diabetic complications. Primarily, we have stressed upon diabetic ketoacidosis. Hyperglycemic hyperosmolar state causes more severe disease and high mortality. And hypoglycemia is the one prompt recognition and treatment is needed in all the patients with diabetes complications. Primary adrenal insufficiency can present with glucocorticoid deficiency, like fatigue, reduced appetite, weight loss, abdominal pain, arthralgia, myalgia. Usual presentation to an ED, and it is really we need to think about it to pick these patients from a busy ED. And patient may have salt craving, low BP, post-BP fall, and it is precipitated by one of the infections or some of the other coexisting problems. So in this patient, they may be first presenting to ED, and we have to be more cautious when a patient coming to BP fall and difficult to resuscitate this patient. We should have quick assessment, and we should think this in our mind. Increased skin pigmentation. So it is in palmar creases knuckles is an important clinical manifestation, and I remembered of a patient. This patient came with acute adrenal insufficiency. We have managed, and patient became better, and patient went home. And then she came with one of her friends, and then I asked, why you have come to me? Then she said, you treated me, and now I become very fair. So there is some treatment here available that makes my color, I look better. So everyone is saying I have gone back to my normal color. So this is the importance of skin pigmentation. Very quick assessment. We don't have much time to evaluate the patient, but quick assessment, quick examination will give a typical clues, because these are the patients we see day in and day out with hypotension. So how to pick up a patient coming with adrenal insufficiency, but it's at most important because we need to act fast. So primary biochemical cues, hyponatremia with hypokalemia. So we should think about it. And in our place, we usually ask whether there is history of snake bite, whether there is any history of significant blood loss, whether you have received transfusions in the past, like postpartum hemorrhage. Snake bite is an important cause we get in. And adenocrisis is nothing but acute deterioration in health status associated with absolute hypotension, systolic BP less than 100 millimeters of mercury, or relative hypotension, systolic BP more than or equal to 20 millimeters of mercury than usual, with features that resolve within 1 to 2 hours after parenteral glucocorticoid administration. So if we are practicing in a very busy ED, it is very difficult to identify this situation unless and until we have a clear-cut suspicion or clear-cut cues that raise the suspicion. This I have just pasted from Tintinali. These are the causes. But as I told, the way we practice, in our place we always ask for snake bite poisoning, postpartum hemorrhage, severe bleeding, and autoimmune is always an important cause for presentation. So we have to think of these things. And treatment, we know that try to get serum cortisol and ACTH level from immediate presentation itself, but we need to start before getting the values. Begin therapy immediately in any suspected case of adenocrisis. And prognosis is related to the rapidity that we start the treatment. Give IV fluids and steroids early. And if hypoglycemia is present, identify and give dextrose-containing solutions as well. Thyroid emergencies, myxedema coma, and thyroid storm. So we all remember those pictures of myxedema coma where patients obese, usually elderly, female, coming with slow response, hoarse voice, that give us a clinical suspicion. It is also a clinical diagnosis. We have to send samples as we suspect, but we need to act immediately. Coma or pre-coma appearing in the setting of hypothyroidism. Clinical findings are very typical. Hypothermia, decreased mentation, generalized edema are the usual hallmarks of hypothyroidism, elderly woman, hoarse voice, and there are so many precipitating causes. And central hypothyroidism, always we need to suspect and we need to start corticosteroid, but if we cannot rule out, or in an acute crisis, always we will be supplementing with hydrocortisone as well. Most of the drugs that we use in ED, sedatives, analgesics, antidepressants, hypnotics, antipsychotics, all will push a patient already ready to go into this myxedema coma. So we have to be very careful. And usually both of them together act a respiratory depression, and we have to act faster. So we have very typical presentation, very typical features. If the patient is speaking, it is very easy to identify. PG is always asked to see for general examination, like a surgical scar on the neck, hypokalemia, hypoxemia, hypercarbia, and secondary to the ventilatory drive. All this will give us important clues, and we have to be more careful in these patients because airway obstruction because of the perilaryngeal edema, large tag, and low respiratory drive, all this will be pushing into the patient for respiratory depression, but definitive diagnosis is always by lab test. Admission to ICU, patient should be managed for hypoglycemia, hyponatremia. Fluid replacement should be careful because depending upon the volume status of the patient, look for precipitating event like infections. Ventilation strategies has to be optimized and may become difficult as well. And thyroid hormone therapy, the textbooks say in IV T4 and T3, but most of the time we don't have, so we will have to go for oral supplementation through Rice tube. Thyrotoxic storm is also not unusual because we manage so many thyrotoxic presenting with atrial fibrillation and other arrhythmias and other manifestations. But typical thyrotoxic storm may be 1 to 2% of hospital admissions for thyrotoxicosis. And here also we need to look for the precipitating events, and diagnosis is always clinical, and we need to start treatment, supportive care, and these are the steps. And I don't think I need to elaborate. We need to manage in all the stages of thyrotoxicosis management and preventing peripheral conversion from T4 to T3. We need to give hydrocortisone 300 milligram IV initially, then 100 milligram every 8 hourly. and treat the precipitating cause and all the things that we need to manage in these cases as well. So I've taken only the important situations and important points that we need to remember, think of diabetic emergencies and thyroid related as well as adrenal crisis or hypoadrenalism. Thank you so much.
So thank you so much, ma'am. So it was covering almost all the emergencies, and a lot of them come to emergency department especially, and you shared an example of how the young girls felt to become fairer by visit. It's good, nice in between. But to the students, please ask questions. Yep, we have a question.
Good morning, ma'am. It's a wonderful presentation. Actually, in our hospital also, we have found so many DKA patients admitted daily basis. And we have done our studies, and there also we found that infection is a very important precipitating factors of the DKA patients. So, along with the fluid management and glycemic control and electrolytes, what we done day to day. So if there is any use of empirical antibiotics, broad spectrum antibiotics before having the lab reports for definite infection or sepsis of this patient. So
It always depends upon the cause of infection that we could identify. What is the, it's like any other illness. If you suspect urosepsis, you go, or depending upon the broad spectrum of infection that's in your place. There is nothing like that, but the important thing is we need to start, as we act in sepsis, get the blood cultures and initiate the antibiotic therapy within 1 hour or as early as possible. And the most important thing is try to identify the focus by clinical examination so that we can initiate appropriately, and as early as somebody told, we can de-escalate. But if we don't have, the problem is if there is no focus of infection, that may not work as well. But usually we will be identify the focus of infection very early.
okay, thank you.
And the mortality is also very high. It's not like the usual one that we see in textbooks in our patient. And most of them get readmitted with DKA. So we need to have a lot of education based on our experience in the peripheral doctors also, because everyone should treat it as an emergency. Thank you. Thank you so much.
Okay, ma'am.
Good morning, ma'am. Thank you for the wonderful presentation. Ma'am, I had a doubt. During the management of the DKA, we usually may come across a situation when the RBS come down, but the ketones are still staying high. So we will have to balance the dextrose-containing solution insulin therapy. So, ma'am, do we have a practical approach how to go
The
up?
problem is most of the time, what we say that less than 250 milligram per deciliter, we start with dextrose and continuous insulin infusion. And most of the time what I see is the infusion will be, dextrose will be going like anything, and the insulin will be going. So as soon as the patient starts eating, we start changing into basal bolus regime. That is what we can do, and we should correct DKA within 24 to 48 hours, because the resident should be there with the patient, continuously monitoring. That's something that we should tell everyone. Continuous monitoring and convert into normal glucose within 24 to 40. The earlier you correct, the better will be the outcome. And transformation as the patient starts eating, move to basal bolus. If we continue with dextrose and insulin patient is taking, it will be very difficult for us to get the target. So that is what we can do. But when the acidosis is there, usually we say that we need to continue the infusion till the acidosis gets corrected. But in real practice, if the patient starts eating, that means it is the time to change to basal bolus. And we should document all the insulin that patient received for the last 24 hours so that it will be easy for us, especially when the patient comes for the first presentation, how much dose that patient will require. Okay,
Yes,
thank you.
Thank you.
Thank you. Thank you so much.
1 minute.
Let me comment for this young man. The insulin is used for correcting ketonemia. It's not for the sugars at all. We monitor the sugars only to avoid hypos. Yeah, there's no other reason why we are monitoring the sugars. The sugar levels doesn't really matter because we are giving a fixed dose. Yeah, ketonemia is corrected by the insulin, acidosis by the fluids. There it ends.
Thank you so much, ma'am. And the, actually, we should go in for the next lecture, but the coffee is ready outside. So can we have a short 15 minutes coffee break? Because then they will, and then we'll move ahead. Yeah. Thank you. So it's just outside. Please have your short tea, coffee, snack break.
Nice meeting. Nice meeting you for the first time, but I heard you speaking at the back. I got a glimpse of it.
Good morning to one and all of you gathered here. I'm very grateful to the organizing committee, Dr. Einstein in particular, for having given me this opportunity. And this is a very significant component of an emergency physician's care, shortness of breath. To define shortness of breath in the simplest of medical terminology, we call it as dyspnea. But for a patient, a shortness of breath can mean anything from air hunger to a feeling of severe tightness in the chest or a feeling of suffocation. And the causes can be so varied. The commonest that we encounter in the critical care setting is due to heart failure, pneumonia, ARDS, pulmonary embolism, and acute exacerbations of bronchial asthma and COPD. But as I have put it here, the causes can range from a problem in the upper airway, which can range from a foreign body which is aspirated, or even to an anaphylaxis, which can cause a laryngospasm or a bronchospasm. It can be a respiratory cause, it can be a cardiac cause. Unfortunately, most of the time we consider only the respiratory and the cardiac. And we have toxins. Snake bite is one thing that we very commonly encounter. Chandini ma'am was talking about snake bite. It's very common in Coimbatore, Kerala. And we have patients coming with a neurogenic component of snake bite with shortness of breath. In fact, they present with bradypnea. And many of the times, if recognized and treated, they get home walking. So you can have problems with the nervous system. You can have neuromuscular disturbances, disorders. Guillain-Barré syndrome is quite common that we see, presenting with different gradations of respiratory difficulty. Hematological, we have cases of sickle cell anemia presenting with the acute chest syndrome. Why? Even a patient who has a chronic anemia, we have people coming from the peripheries who are chronically anemic, who have all along had a compensated heart. But then one episode of amenorrhagia is sufficient to make them go into a state of shortness of breath. It can be just metabolic, where a patient is having a diabetic ketoacidosis and presenting with shortness of breath. And poisoning, many of the times we do not recognize carbon monoxide, methemoglobinemia. So you have a wide range of reasons why somebody feels a shortness of breath. So the shortness of breath is what the patient experiences. But a clinician, an emergency physician has to recognize if the shortness of breath is a respiratory distress. So to define or to identify at the entry point in an emergency or a critical care setting, if the patient is in a state of respiratory distress, is number one, to monitor the SpO2, less than 92 to 93%, and it is significantly going down, and two, an increasing respiratory rate. So this will be the defining characters for the clinician to identify the respiratory distress in a person who comes with an undifferentiated shortness of breath. So what are the signs which are indicative of severe respiratory distress? That is respiratory distress. Now to say that the person is going into a severe state, you find that there is involvement of the accessory muscles of respiration, a progressive dyspnea or a tachypnea, people appear anxious, the speech is short, the sentences are incomplete. All of you should be aware of the decrease in the single breath count, and a single breath count has to be undertaken by asking the person to take a deep inspiratory effort and to count. All of us should be able to count at least up to 50. And it should be in your normal voice. So that is exactly how to go about with a single breath count. Next, an inability to lie supine. Many of the patients you see will be in a tripod position or sitting bolt upright. They are afraid to lie down. And you may have profound diaphoresis, especially if the patient has a coronary syndrome as a cause of acute breathlessness. In fact, a dyspnea is an angina equivalent. And patients who have an acute exacerbation of bronchial asthma also have severe diaphoresis. And many a time, if there is a block in the airway, you may hear a stridor or a wheeze. So these are all to suggest that the person is going into a state of a severe respiratory distress. So this is how a person may prefer to sit, a tripod sign, when he or she is breathless. Now, what are the signs that portend an imminent respiratory arrest? So we saw that there is a respiratory distress, there is a severity of respiratory distress, and now you may know that the patient is going into a state of a respiratory arrest. So number one is an alteration in the sensorium. On a broad scale, we have seen that patients who are hypoxemic are irritable, and patients who have a hypercarbia are confused. So this is, at the entry point, you do not know, but this may give you a clue. So this is one thing we have seen. We have patients coming with partial hanging. They may come to us in a state of unconsciousness. Even as they recover, if the patient is irritable, I will be happy. Because there is a hypoxemia, it causes an irritation, and we know that the patient will come out of it. Second, an inability to maintain a respiratory effort. I just told you about snake bite and toxicity. This is one area where we have very commonly seen they will be in a state of severe bradypnea. And this is also portending a respiratory arrest. And number three, cyanosis. Cyanosis may be indicative of severe hypoxia or hypoxemia. Sometimes the cyanosis may also be indicative of a methemoglobinemia. I still remember a nursing student who was admitted with acute shortness of breath with blue. She was blue. And just a week earlier, she was started on dapsone for leprosy. And this gave us the clue. So I have created one slide to say what is this targeted observation. See, we all come from a completely a clinical background. So for us, an observation is absolutely essential before we actually get to handle machines or whatever it is to evaluate or to at least make a differential diagnosis of a patient who comes in a state of severe shortness of breath. So there are certain reversible causes which, if identified at the appropriate time, can make a difference between life and death. So number one, stridor. So as we all know, there can be a block in the upper airway or the lower airway. So if it is above the vocal cord, usually it's an inspiratory stridor. If it is below the vocal cords, it can be both inspiratory or expiratory. There can be a foreign body. Number two, even as the patient comes in, you observe that the patient has signs of angioedema. You understand that the stridor is because of the anaphylaxis, because of the ongoing angioedema. So that makes the difference. You can treat the patient immediately. Number three, you have a reduction in or absence of breath sounds. So as the patient enters, all of us, I'm very sure, would like to put the stent on the patient's chest, and you find that there is an absence of breath sounds. It may mean two things. Either there is air or there is fluid. One percussion note is sufficient to differentiate whether there is a pneumothorax or whether it's a pleural effusion. The presence of rales. All along we have been taught that bilateral, basal, fine crepitations. Yes, all these are fine signs, but they do make a great importance as the patient enters into the emergency department or the critical care setting. And a hypoxia with clear lungs. This is an area where many of us may miss. I still remember a young girl who came to the OP, this was about 15 years back, who came to me with a prescription of injection Derifilin. She told me that she had attended the OP the previous day for breathlessness. I do not know who had examined her, and you know Derifilin was one of the commonest things that was used those days, but she had not improved. Now when I auscultated, her lungs were clear. The second thing that struck me was she was very lean. I sent for an immediate random sugar. It was high. We got her admitted. She had a ketoacidosis. So this is just to say that many a time we have many patients coming or presenting for the first time with diabetes because of diabetic ketoacidosis. They have a clear lung. Clear lung may also be because of pulmonary embolism. A patient with methemoglobinemia or a carbon monoxide poisoning can also have a clear lung, but still they may be breathless. How do we approach? So initially, we have seen how to target the approach in order to find out reversible causes so that you can make a difference in the life of the patient. Now let us see how we approach the patient. Any person who is in the emergency department as an emergency physician should, in the first place, see for the airway, breathing, and the circulation. This is mandatory. Yes, we are yet to make a differential diagnosis.
So take care of these preliminaries and provide supplemental oxygen. Whatever be the status of the patient, supplemental oxygenation is mandatory. And we must know what should be the ideal oxygen delivery device to administer the oxygen. If patients are severely hypoxemic, you can straight away start, provided the airways are free, with a non-rebreather mask. The advantage being you can give in as much as 10 to 15 liters of oxygen, which can provide you from 85 to 95% of FiO2. And if it is a patient who's hypercarbic, you suspect there's a hypercarbia, we always prefer the target saturation to be between 88 to 92. So this is how we decide a target, and we determine what should be the exact mode of oxygen delivery device as the patient comes to us. Next, determine if there is a need for emergency airway management. If you feel that the patient is not having adequate or there is an alteration in sensorium, you need to take care of the airway. The tongue can fall back. There is possibility of aspiration and worsening of his condition. Next, immediately establish an IV access and collect blood for the lab investigations, and always have a continuous cardiac and SpO2 monitoring, and also have a conscious observation of his hemodynamic status and maintain the hemodynamics. Next, go into the relevant history. There may be specific triggers, there may be a bee sting, there may be a snake bite, whether there has been a non-compliance to therapy, if the patient has been recently immobilized, or there has been a history of surgery or trauma. Chest trauma is something that we might have missed, or even the patient might not find it important to tell you. And a past history of asthma or COPD is important. And it is to be remembered that a patient who is asthmatic, who has an exacerbation, who has had a previous intubation, is likely to need an intubation even during the recent or the present admission. And what has been the time course of dyspnea? It is not that on day one, if a patient has developed a pneumonia, he's going to become short of breath immediately. It may take a period of a day or two. So you find out the time course of the dyspnea and what has been the severity of the dyspnea, whether there is an orthopnea, whether there is a paroxysmal nocturnal dyspnea. These are the things that we are taught right from the beginning. For fever or productive cough, chest pain, all these are very significant, important history which all of us will definitely ask. And hemoptysis, you must remember that hemoptysis can be because of a pulmonary embolism. Hemoptysis can also be because of an anticoagulation therapy. Why I am mentioning? Because we may forget, or the patient may not know that he has to give that history. And of course, history of trauma. Why this is mentioned is because these are some of the important or vital points which many a time we fail to ask, or sometimes we are hesitant to ask, or maybe we do not know that we have to ask. So history of medications, including oral contraceptive pills. We have had cases where with oral contraceptive pills, patients have come with venous coagulation, thrombus. Family history of hypercoagulable states. Again, it's a very difficult arena unless the patient is educated enough to tell you. Psychiatric illness. So the patient has a panic attack, has a shortness of breath, and we may fail on that account. Recently, we had an admission of 3 nursing students. One girl was so apprehensive of the COVID vaccination, she started hyperventilating. She was brought to the ICU. We found that the carbon dioxide levels were so low, as you all know, she went into tetany. Seeing this, 2 more girls started hyperventilating, and we had a mess around in our IMCU environment. So this can, maybe there is an underlying a psychological or a psychiatric illness. Substance abuse, again, not a very comfortable zone, and you may not get the appropriate history. And a recent delivery. Delivery, yes, they may tell you. Abortion may not be told. So that can also be a reason why somebody has got a hypercoagulable state. So these are all some of the things that become very important. You can have your own set of questions so that nobody is missed out when they come to you with shortness of breath. How do we go about the physical examination? Yes, the hemodynamics. Always, this is how I teach my students, head to toe examination. Observe. So you may have an angioedema, you may have urticaria, you may have pedal edema, you can have cyanosis, of course, and clubbing. So all these may be giving you a clue. And observation of the vitals, the blood pressure, and if feasible, pulsus paradoxus has a lot of stories to tell you. I had a patient for whom we did a sternal puncture, and suddenly the patient, as I was observing and entering into the room, I found the patient collapsing. And then when I tried to see the BP, it was the first time in my life I encountered a pulsus paradoxus. There was a sharp drop in the systolic blood pressure on inspiration. So there was a puncture into the pericardium and this patient had gone in for almost a cardiac tamponade-like situation. So cardiac tamponade, tension pneumothorax, all these are well known to produce pulsus paradoxus. And a consistent monitoring of SpO2, the peripheries, observation of the skin, and the systemic examination, the heart, the lungs, the abdomen. You can have a subdiaphragmatic cause, which is responsible for the breathing difficulty. The diagnostic testing, make it very simple. There is absolutely no advantage in ordering a huge list of investigations. Make it very simple. What is most needed is you need to know the anemic status of the patient, you need to know the sugar status of the patient, and it is always not necessary you find out the acidotic status only by an ABG or VBG. It is enough if you can just get to the carbonate levels, and of course, we have to monitor for the renal status. A plain X-ray chest is mandatory for every patient. Unfortunately, now it has become the norm, or I do not know if it's the norm across the country, where every patient is subjected to a CT chest, which is not mandated in any kind of literature that I have gone through as far as this topic preparation is concerned. Because for the purpose of a CT chest, you keep shifting the patient. In the process of shifting, you are going to lose out on the appropriate oxygenation status of the patient. So get a plain X-ray chest. Many things can be identified with a plain X-ray chest. An ECG, if you have access, if you have the skill, go ahead with an echo and a bedside ultrasound. I know addressing a group of emergency physicians and emergency department needs to have a very good working knowledge of POCUS, which is still in a nascent stage among many of us. So this point of care ultrasound is one among the well-researched area which shows that it has a long way to go in appropriate diagnosis in an emergency setting in a patient with acute shortness of breath. So there are several strategies for POCUS. One is the blue protocol. It's the bedside lung ultrasonogram in emergency. LCI protocol, lung cardiac IVC, LUCAS protocol, etc. And studies are also going on relating to the multi-organ POCUS ultrasonogram, wherein there is POCUS done for the lung, the cardiac, the IVC, and the renal ultrasound. So this multi-organ POCUS, it finds reference in the International Journal of Emergency Medicine, and the cardiac status relating to the LV systolic function, the RV status, a pericardial effusion, a pericardial tamponade, and the Aeme-Con sign. This is less sensitive but very specific when it comes to identifying or considering the possibility of a pulmonary embolus. You find that the right ventricle is akinetic, but the apex is kinetic. It moves. So that is the Aeme-Con sign. The IVC diameter and collapsibility helps us to determine the fluid or the volume status of the patient. The lung ultrasound, of course, gives you a lot of information relating to a parenchymal injury or a pleural pathology, and a renal ultrasound, of course. This combination is called the multi-organ POCUS strategy, which is being tried. Even it is very effective in low resource setting, provided you have the expertise. And these are some of the directed studies. Now, despite all your studies, you still fail to make a diagnosis. We can think of the following possibilities depending upon the situation, depending upon the history, depending upon the clinical presentation and the physical examination that has been done so far. As I told you, you can have anything from the upper respiratory tract down as a cause of breathing difficulty. You can have an epiglottitis, there can be a retropharyngeal abscess, there can be a parapharyngeal abscess, there can be a Ludwig's angina. So if you still have to evaluate, you can go for a CT neck. And if you still suspect that there is a block in the trachea, maybe there's a foreign body which is radiolucent, that happens with organic materials, then maybe a trial of fiber optic laryngoscope or bronchoscopy can be tried. And cardiac biomarkers and BNP by themselves do not find a place in the system of evaluation of a patient with shortness of breath. You have to determine if you are to really evaluate if the patient has got an acute coronary syndrome on the basis of your echo or on the basis of your ECG findings, you go ahead. Otherwise, you know that troponin can be positive in a patient with pulmonary embolism, with myocarditis, pericarditis, sepsis, etc. And patients for BNP, that is brain natriuretic peptide, again does not warrant that you bring it in your spectrum of analysis for each and every patient. Only a BNP which is greater than 500 holds a significant validity or usefulness wherever you are suspecting decompensated heart failure. In fact, if you have a POCUS and if you can assess, this should be the best way to identify a decompensated cardiac failure. In fact, even an X-ray is going to give you the information rather than undertaking a set of biomarkers which may not necessarily give you the most appropriate diagnosis. D-dimer again does not find a specific place in the list of investigations that need to be done. A CT pulmonary angiogram is definitive whenever you have a pulmonary embolism. A ventilation perfusion scan again can give you a very strong clue to the possibility of a pulmonary embolism if you cannot shift a patient and you have a strong feeling that the patient has a pulmonary embolism. And I have mentioned here VBG because you need not go ahead with as an invasive procedure to get an arterial blood gas. A VBG does not find a very specific or a definitive place in every patient of shortness of breath. Only when you find that there is a discrepancy, you are not able to find out the appropriate SpO2, you find the peripheries are cold, you have a suspicion of hypercarbia, or you want to estimate the degree of metabolic acidosis, then you may go for a VBG. It's more than enough. It's not always necessary you go for an ABG. And of course, FVC measurement at the bedside. So sometimes this is out of possibility for many of us. In fact, the simplest things that we do at the bedside is you ask the patient to lift the neck. You find that there's a neck muscle weakness, especially in patients who have neuromuscular disturbances and snake bite. You find that there is a difficulty in holding the neck and the single breath count is very low. And this is very good enough to find out that the patient is going into a state of a respiratory distress. So some of the points to consider. An unremarkable pulmonary and cardiac examination does not rule out that there is a significant disease. That is why I gave you a huge list of conditions. It's not always respiratory or cardiac. And never go for a random testing. Always come to a differential diagnosis before you determine what kind of test you need. Routine use of dyspnea panels like the biomarkers which were mentioned do not find a place in the panel of investigations. Arterial blood gas analysis and CT chest need not be used routinely. So make it patient specific. Let it be tailor-made to the patient's needs. And ABG is used to identify hypercapnia and VBG is more than sufficient. See, to give you a classical example, if you are in a resource-rich environment and if you have access to the arterial blood gas analysis, maybe a person who is hyperventilating, what we should be identifying that there should be a carbon dioxide washout. On the contrary, if you find that there is an increase in the PaCO2, that should give you a clue that the patient is inching towards a respiratory distress. That may be a strong clue that you're going to get. And in most clinical circumstances, an emergency physician can determine the diagnosis with the history, the clinical examination, the X-ray, and the ECG. To a great extent, 75 to 80% of the time, we will be having a good diagnosis with us. But it is also to be remembered that there can be a radiological lag between the clinical presentation and the radiological finding in conditions like pneumonia and in a heart failure. So that is the reason why we would always prefer for a POCUS and for the evaluation of a cardiac ultrasound and a lung ultrasound. And a lung ultrasound is more sensitive than the chest X-ray, as I just mentioned, in patients with acute decompensated heart failure and should be used if the operator is knowledgeable. And studies integrating the focused multi-organ ultrasound into routine clinical evaluation in the patients with dyspnea has a high accuracy for differentiating the causes of dyspnea. And a study has shown that it is up to 88%, that is concordance between the emergency diagnosis and the final diagnosis in patients where this multi-organ POCUS has been used has been found to be very high. So that is the biggest advantage and the role of POCUS in identifying, diagnosing and managing a patient with shortness of breath, undifferentiated shortness of breath. Thank you very much. I always have a message to give. This is from Robert Frost. The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. We are in the process of learning. There are so many youngsters in front of me. I know you may know much better than what I know. We have come through a system which was purely clinical. Now, at this stage, I'm entering into a system which needs more skill. So nobody can say that he or she knows everything in this world. So we keep moving forward. Thank you.
Thank you, ma'am, for that very comprehensive talk on management of acute shortness of breath. Your clinical insights and important points were very, very valid, I think, especially to the younger crowd and and to everyone in this hall. I now request any comments or questions from the audience, if anyone would like to ask any. Yes.
Good morning, madam. Actually, I'm sharing cases so that actually we got confused in this case. So I just want to share and ask your opinion about that. A 26 years female having a history of Eleusis 7 months back.
History of?
History of Eleusis 7 months back. So she presented to us Eleusis. Cesarean section, okay. So, cesarean section. So, but postpartum incidents are uneventful. There is no such problems at that time. But whenever she presented to us in the emergency department, she was having shortness of breath. So we have examined thoroughly, and on examination, crypts are there. And there is a history of pedal edema also there. So we are suspecting there may be a heart cause. So we have done the 2D echo. And there is a picture of peripartum cardiomyopathy. So till now everything was okay. But suddenly the patient, during the admission period, patient is having the hemoptysis. So then we thought that there may be pericardium cardiomyopathy or any kind of pulmonary embolism is there. So but in the echo, what you have already told the Aeme-Con sign, I personally saw the echo, there is no hyperkinetic apical RV. So now we have sent the sputum AFB and Sebin and whatever in our country setup. So, but D-dimer is surprisingly very in the high range. Now we are planning for the CTPA, but the patient was so much sick that we cannot send the patient, and the creatinine is very high range. So what will proceed next? Do we give at least low molecular weight heparin for this patient? But we are suspecting that if it will also precipitate the hemoptysis. So we got confused actually. So last week when we came here, so that time the patient was still admitted. I don't know what happened to the patient right now. So can you give some light about this patient? What
I think
should
from what you say, it's a peripartum cardiomyopathy, but it is 7 months later, is it?
Yes,
7
yes,
months.
that's
But we do see, sometimes we don't see exactly in the peripartum period. We have patients coming to us 3 months hence, 4 months hence, but it is related to the pregnancy. And of course, the guidelines as we manage a patient with the postpartum or a peripartum cardiomyopathy, it's the same thing that we follow. And you have to reevaluate. Now that the patient is bedridden and immobilized, maybe still you have to evaluate to find out. Of course, there is a difficulty in getting the CTPA, but still you'll have to consider its possibility and go ahead with evaluating. But of course, it also is dependent upon how much the patient is at this point of time, whether you can mobilize her, she's conscious, is she hemodynamically stable. So all these basic parameters need to be stabilized before you're going to consider further evaluation.
Okay. Okay, ma'am. Thank you.
Thank you. Any other questions from the audience? No. Okay. Thank you, ma'am.
Thank you.
I now would like to call upon our next speaker, Dr. Brinda ma'am, who's the professor and head of JSS Medical College in Mysore. Madam will be speaking on the topic of anaphylactic shock.
Good morning, everybody. I wish to thank the organizing committee for giving me an opportunity to be here, and a special thanks to Dr. Ashima, being a great friend of mine and also putting in a lot of efforts to make this a success. So I'll start my talk with a case history here. so which is more interesting. And I think most of you would have come across many, many cases of anaphylaxis during your stay or your work in the ED. So here is a 37-year-old healthy woman who comes to the ED which complains of itchy red rash that started soon after eating idli at a restaurant. She complains of difficulty in breathing, speaking or swallowing. On examination, she is very, very uncomfortable, scratching her neck, and raised patchy red urticarial rashes are present all over the neck, torso, swollen lips and tongue. Her voice is hoarse. She is not able to complete sentences when she came to the ED. On chest auscultation, the bilateral rhonchi is present. The saturation is around 88% at room air with diffuse rhonchi. The blood pressure is around 70 millimeters of mercury and the blood sugar is 90 milligrams per deciliter. I think at this point of time, I think anybody would come to a final diagnosis of an allergic or a hypersensitivity reaction at a go. So what the impression would be from my side and from everybody's side, it would be in a hypersensitivity reaction. So I would like to proceed further with my talk on anaphylactic shock. So what is anaphylaxis? So there are various definitions which are put forward by many authorities around the country, but the WHO stands the best definition as far as anaphylaxis or the anaphylaxis shock is concerned. So it is a severe life-threatening systemic hypersensitivity reaction characterized by being rapid in onset with potentially life-threatening airway, breathing and circulation with or without cutaneous or mucosal manifestations. So this is the definition of anaphylaxis. So how do we diagnose anaphylaxis? So at least one of these manifestations to be present. Either it is cutaneous and mucosal manifestations or respiratory manifestations in the form of shortness of breath, stridor, breathlessness, hypoxemia, etc. Or it could be a circulatory collapse wherein the patient collapses because of fall in blood pressure, because of the widespread vasodilatation which happens, which leads to collapse. Or the patient can present to us with a GI symptom also, with crampy abdominal pain and vomiting. So if any one of these symptoms are present in a patient who presents to the ED, you will have to think of anaphylaxis first. So these are the various examples of anaphylaxis elicitors, the various foods. Anything under the sun can produce a hypersensitivity reaction. There are very many food products here which can produce anaphylaxis: insect venom, bee, wasp, fire ants, horsefly, etc. And drugs, of course, all antibiotics, analgesics, biologicals, contrast media. Many of the times we get patients from the CT following contrast media reactions, they come to the ED. So these are all the few examples of anaphylaxis elicitors. So how do they present to us? So they can present to us in a biphasic manner or as a uniphasic manner. By uniphasic manner, I mean the patient presents to you with hypersensitivity reaction or anaphylaxis. After treatment, the signs and symptoms subside and the patient feels okay. So this is the uniphasic pattern of presentation of anaphylaxis. About 1/5 of these patients who come with anaphylaxis, they also present to us in a biphasic manner, that is the protracted manner. Here there is recurrence of symptoms that develop following apparent resolution of the initial anaphylactic event without additional exposure to the trigger, which may last for few hours to even weeks. So these are the two varieties of presentation of an anaphylaxis. So let me just brief you about the pathophysiology. So the allergen, it can be anything which can enter into the body through the skin, through the air, through the food. It enters into the body. So it stimulates the B cells, which stimulates the production of IgE antibodies. As you all know, anaphylaxis is a type 1 hypersensitivity immunological reaction mediated by IgE antibodies. And these IgE antibodies have a strong affinity to the receptors which are present on the mast cells. So once they get attached because of the affinity to the receptors on the mast cells, and further subsequent exposure to the same antigen will cause an antigen-antibody reaction, which causes degranulation of the mast cells and release in the histamine and other mediators of anaphylaxis, which produces the various manifestations following release of histamine and the other mediators, leading to cardiovascular, respiratory, and cutaneous manifestations. So histamine, along with histamine, there are other mediators which are released into the blood. They are leukotriene B4, leukotriene C4, E4, and prostaglandins. All these are responsible for the various life-threatening manifestations, including the respiratory, the mucous membrane, the skin, and the cardiovascular systems. So there is a lot of fluid shift which happens from the intravascular to the extravascular compartment, which results in massive edema, especially the life-threatening edema of the airway would be an angioneurotic edema. There is a swollen uvula, the patient is breathless, stridor, etc. And these are all the various receptors which are blocked by histamine and produce various clinical features which are elicited. Okay, so coming to the respiratory system, as I already told you, the patient can manifest with pulmonary edema, hemorrhagic petechiae in the lower airway. In the upper airways, there is sneezing, rhinorrhea, and all these things can happen. These are mild to moderate anaphylactic reactions, but in shock, the patient may land up in hypoxia and asphyxia. So this is the picture how the manifestations of an anaphylactic shock can look like, with swollen lips, and the uvula is so much engorged because of the angioneurotic edema here, and the glottis is almost closed here, which gives rise to a threatened airway, and the patient may go in for a respiratory arrest anytime. So what is the treatment protocol here? The treatment protocol can be divided into initial management, the first line, and the second line. So what is the initial management? As we all know, being emergency physicians, we'll have to go through the protocols like A, B, C, airway, see whether it is threatened or not. Most of the time in anaphylactic shock, it will be threatened because of the edema. Then coming to the breathing, whether the patient has got an obstructed breathing, whether there is stridor, hoarseness, etc. So act accordingly. 2 large bore IV needles are a must, IV catheters are a must at this point of time. An IV infusion with a 0.9% saline is important, very important to make the patient more hemodynamically stable in case the patient is unstable. And supplemental oxygen, like Dr. Geeta was telling, oxygen, maintain the oxygen saturation above 95%, give supplemental oxygen, and always make the patient to lie down. The patient should not be sitting or walking around with all these disabilities. Always make the patient lie down, start oxygen, give fluids. 30 ml per kg would be sufficient. That is the basic care you need during the initial assessment. So coming to these are all this is the latest anaphylaxis 2020 practice parameter which I have taken, the recommendations, assessments, and all the other guidelines have been accepted here, and the World Allergy Organization allergy guidances have also been referred to for my talk today. And the main line, the first line of treatment would be epinephrine or adrenaline. This is the most important treatment of anaphylaxis. It should be administered as soon as a diagnosis of anaphylaxis comes across. So delayed epinephrine injection is associated with fatalities. Potent stimulator of, as you all know, epinephrine is a potent stimulator of alpha and beta adrenergic receptors. It acts on beta 1, beta 2, and produces various derangements which can be rectified with adrenaline. Dosing. So dosing can be given various routes, IM, IV, and infusion. But the standard approved mode of administration would be an IM injection of adrenaline, 0.5 mg as a single dose, which is given in the anterolateral aspect of the mid-thigh. This is the recommended standard treatment is the IM injection of adrenaline. So once the 2 doses of IM injection have not benefited the patient, then the clinician may think of an IV administration of adrenaline in the concentration of 1 in 1000 dilution. 1 in 1000 dilution is the one which is required for an IV infusion, IV injection. However, 1 in 1000 can be used for IM injection. So 3 minutes of observation before considering a repeat dose of IV injection of adrenaline is sufficient to make any improvement. If there is no improvement, then one can think of an infusion at the rate of 0.1 micrograms per kg per minute. So these are the various references which I have taken into consideration for epinephrine in anaphylaxis. Why IV is not advocated and IM is advocated, the reason being the adverse reactions with IV adrenaline is more. It causes dysarrhythmias, it can also cause ischemia, it can cause angina, it can cause hypertension. That's the reason the mainstay of treatment would be IM injection, and if there is no sufficient improvement with IM and the patient's clinical condition is deteriorating, one can go in for a IV infusion or stat doses of IV. So these are all the various cohort studies which I have referred for this talk. So in conclusion, the risk of overdose and adverse CV events is significantly higher with IV boluses of epinephrine administration. Hence, that is not the standard treatment as of now. So along with adrenaline, we also have adjunctive therapy with corticosteroids, antihistamines, and bronchodilators. Corticosteroids in anaphylaxis, there are plenty of retrospective cohort studies which have been put forward where they say steroids are not of much use in anaphylaxis. Steroids can be it does not prevent emergency department visits within 7 days of anaphylaxis. However, biphasic reactions can be treated with corticosteroids. So corticosteroids are not the mainstay of treatment, it is only adrenaline. So these are the various references. I have made systemic review of evidence regarding glucocorticoids. Although RCT may not be possible, more evidence is needed on treatment and outcomes through at least prospective cohort studies. So it still is not a mandatory. It is only adrenaline. So glucocorticoids, why it is not mandatory? So because it takes several hours to act is number one, and they must be given preferentially to adrenaline. Must not be given preferentially to adrenaline, sorry about that. And it is used to prevent biphasic or protracted reactions and consider after initial resuscitation for refractory reactions or ongoing asthma. So this is the only reason why glucocorticoids are recommended here. So along with glucocorticoids, we have H1 antihistamines and H2 antihistamines, which are also used along with epinephrine. So H1 and H2 are simultaneously given the standard route here of administering antihistamines would be an intravenous route, and it's not recommended as part of the initial emergency treatment of anaphylaxis. So however, antihistamines, they are very useful in treating the cutaneous manifestations rather than the cardiovascular or the respiratory complications. Later on, once the patient stabilizes, after stabilization, a non-sedating oral antihistamine like chlorpheniramine can be preferred over diphenhydramine. Bronchodilators like ipratropium, albuterol, salbutamol, all these can be used, which causes relief of bronchospasm, and it improves the respiratory complications. It used as an adjunct therapy. So anaphylaxis and anesthesia, as you all know, there are many anesthesiologists here. Almost all the drugs used in anesthesia produces anaphylaxis, starting from your narcotics to induction agents, the neuromuscular blockers, all of them are known to produce anaphylaxis. So when a patient who is on general anesthesia suddenly develops dysarrhythmias, or patient goes in for cardiovascular collapse, the BP is not recordable, the peak pressure on the ventilator goes up, there's absolutely no air entry into the lungs, the patient is in a state, all this happens in a very abrupt manner, within seconds to minutes, all this happens. So one has to think during anesthesia also that it could be an anaphylactic reaction which has produced this condition. So at this point of time, if the patient is on general anesthesia, it's better to cut off the nitrous oxide, give them 100% oxygen and infuse fluids, give a 30 ml per kg body weight of normal saline, which can resuscitate the patient and make the patient more stable, and simultaneously think of giving adrenaline. It could be either IM or IV adrenaline. And if the patient, even local anesthetics also can produce anaphylactic reactions. If the patient is not intubated, I think this would be a very life-threatening situation where it really panics the anesthesiologist here, because it is a very difficult situation to intubate these people, because intubate these patients because of all the manifestations which has already occurred as a result of anaphylaxis. So the only way bag mask ventilation is difficult, intubation is difficult because of the angioedema and the swollen tongue, swollen lips, etc. So the only way to intubate these patients would be a fiber optic intubation. Even the surgical interventions are also very difficult here because the landmarks are obscured here. Even needle cricothyrotomy may also be very difficult in such patients. So the only way of rescuing these patients would be a fiber optic intubation. So the other drug which is of much use to us would be vasopressin. It acts on the AVP V1 receptors. It acts on the V1 receptors and produces relief in anaphylactic shock. So the other drugs which can be used in selected patients are on those patients who are on beta blockers and AC inhibitors. They are resistant to the effects of adrenaline. In such cases, glucagon can help us, which bypasses this adrenergic pathway and improves the bronchospasm, etc. So here it is given in the dose of 1 to 5 mg, slow IV bolus over 5 minutes, followed by an infusion of 5 to 15 micrograms per minute. So another drug which comes as a rescue in such life-threatening condition is methylene blue. This acts by inhibiting the nitric oxide synthetase and glycinate cyclase. 1 to 2 mg per kg is given over 20 to 60 minutes. So there is another entity which is a rare entity which is called exercise-induced anaphylaxis. When the patient exercises or the person exercises, the patient may develop certain features of anaphylaxis. So these are the various literature survey which I have done for the study. So here we have a 2020 update on anaphylaxis in pediatric population, and there are 5 independent risk factors of lethal anaphylaxis in children, whereas these children who are, there is a history of an asthma. Almost immediate onset of symptoms happen in pediatrics, and it has the incidence is also quite a huge incidence in pediatric anaphylaxis, which need to be addressed as early as possible. So this is again about the pediatric anaphylaxis. Anaphylaxis is also seen in pregnancy. 1.5 to 3.8% of 100,000 pregnancies develop anaphylaxis during pregnancy as well. A systematic review of clinical presentation to determine the outcomes have been studied here. So if it happens during labor and delivery, the positioning of the patient again is very important here. Put her onto the left side, prompt administration of epinephrine, maintain the blood pressure to around 90 millimeters of mercury, give oxygen and monitor their heart rate to assess the fetal status. So there is one more entity which is very, very life-threatening, would be Cownes syndrome, is a hypersensitivity coronary disorder. This happens in patients with history of previous allergy, hypertension, smoking, diabetes or hyperlipidemia. These are the patients who are more prone for Cownes syndrome. The pathophysiology here is coronary artery spasm or an atheromatous plaque erosion or rupture during an allergic reaction, which activates the mast cells and causes the angina or the hypersensitivity coronary disorder. So these are the various references which has been looked into. Epinephrine in cardiac arrest. There is no specific data which is available regarding the dose of adrenaline to be given in a cardiac arrest due to anaphylaxis. However, there are a few inputs like BLS modifications and ACLS modifications which also tell us that IV infusion of epinephrine is a reasonable alternative to IV boluses for treatment of anaphylaxis. So no random controlled trials have evaluated epinephrine versus the use of alternative vasoactive drugs for cardiac arrest due to anaphylaxis. So recently, vasopressin has been successfully used in patients with anaphylaxis who did not respond to the standard therapy of epinephrine. So how do we know that this is an anaphylactic reaction? So the most, these are the various tools which are available to us to detect anaphylaxis. One is the histamine, the other one is the tryptase. Tryptase is more specific of anaphylaxis. So serum levels of tryptase, they elevate within 15 minutes to 3 hours after onset of anaphylaxis. So this would be a very diagnostic tool to diagnose anaphylaxis. So EpiPen is a preloaded adrenaline auto injector which is available in 2 strengths. One is 0.3 mg and the other one is 0.15 mg. So however, this is not available right now in India. It may be available abroad, and the patients who are susceptible to recurrent anaphylactic or allergic reactions, hypersensitive reactions, they need to carry this, and the slide itself tells you how to use this. On the anterolateral aspect of the mid-thigh is the ideal IM injection of epinephrine. So this is the algorithm regarding refractory anaphylaxis. This is just the gist of all what I told you. This can be downloaded. The guidelines of 2021 of Resuscitation Council UK can be downloaded on from the Google. And this is the anaphylaxis protocol which need to be followed. And what are the take-home points after this? So anaphylaxis, epinephrine is the drug which can, give a good recovery. It has to be administered as early as possible once you think a suspicion of anaphylaxis comes. And the second line of drugs are glucocorticoids and antihistamines. Glucagon can be used. And the other alternative is vasopressin and methylene blue. Exercise-induced anaphylaxis is quite rare. Pregnancy and pediatrics, it is the same guidelines applied to them also. And Cownes syndrome is the other one. Thank you.
Thank you, ma'am, for that wonderful presentation on anaphylaxis. I think it was very extensive, and noteworthy was that you had touched upon every special population and their presentation in the emergency department. I just would request if there are any comments or questions from the audience. Yes, please.
Ma'am, I have one comment and one question.
Yeah.
Since we know adrenaline is a physiological antagonist of histamine, so we use ADR to treat anaphylaxis. In one of your slides, you said we use methylene blue. What is the mechanism of methylene blue in anaphylaxis? And one second comment I would like to make is, for residents, you should also anticipate where anaphylaxis can happen. Especially, there are 2 indications as ED physician. One is when you are administering ASV. That is the time when patients can get anaphylaxis, so you should keep your ADR ready. And second is when you send your patients for contrast CT. I have seen many times patient going for a contrast CT, and the moment you give him contrast, he totally crashes. Thank you.
Yes, yes. Yes, I agree with you, sir. Contrast media can produce, there are so many cases who go to the CT room and come back again with allergic reactions, and ASV, and most of the time 1 out of the 10 patients of ASV, they also cause anaphylaxis, and we have to be very prompt in diluting the ASV and taking care of the anaphylactic reactions or hypersensitive reactions as well. And methylene blue is another alternative where it is used. It is given in the literature. I don't have any clinical experience using methylene blue. It is only by the literature survey I could get this methylene blue.
Ma'am, I apologize. I came a little bit late for your lecture, so I'm not sure if this was covered or not. But if it is not, I have a question. What, in your opinion, ma'am, is the role for nebulized adrenaline in cases with severe angioedema, with swelling of the tongue?
Yeah, but going
I'm not
through
sure
the
if it was covered. Was it
yeah,
covered, ma'am?
literature,
Oh, yes.
literature survey has made a study, compared nebulization of adrenaline with IM adrenaline. The literature, the article says that a nebulization of adrenaline, the blood levels of adrenaline takes a longer time to come to the serum levels, take a longer time to achieve in a nebulized adrenaline situation compared to the IM. So they always recommend IM. Even in the pediatric age group, they recommend IM instead of aerolos or nebulized adrenaline.
Yes, ma'am. No, Mike, I get that, ma'am. Definitely IM is the way to go, especially when IV access is not there. But in my literature search for this, ma'am, and in my clinical experience as well, patients who don't present with circulatory shock per se, but those who come with very severe angioedema with a huge tongue, but with stable BP, I think even the Allergic Institute in America, they do say that if IM adrenaline has been given and the patient's angioedema has not yet settled, that still is a threatened airway, not a lost airway, but a threatened airway, you could still consider giving nebulized adrenaline. Two sources, say one source is 1 mg in 5 ampules of water, another source is 5 mg in 5 ampules of water, I'm not sure. But you can try nebulized adrenaline to bring down because it's a local reaction. So there'll be local vasoconstriction of the airway, and the patient will go from having a threatened airway to a patent airway at that point. Obviously, if there's hypotension and stuff, you would want to lay the patient flat, raise the legs, IM adrenaline, etc. But if it is an airway which is at risk, there is some role, but it should not be first line, as you correctly said, ma'am.
Yes.
First line is always IM adre, and if airway is a problem, which is assessed to be a problem by the treating physician, you could try nebulized adrenaline as well, as it's useful.
Yes, thank you.
Thank you, ma'am.
Ma'am, any role of test dose before giving antibiotic, and if there is role, and how long we have to wait for after giving test dose before giving antibiotic, and as a part of survival sepsis campaign, we need within 1 hour you have to give broad spectrum antibiotic, and if we need to give test dose and have to wait, then what is your take on this? Kindly enlighten us.
Yeah, you can give a test dose and see. First of all, some history if you can get regarding some allergic conditions, that would be very helpful. If the patient is an asthmatic also, that will give you some insight as to whether this patient can develop any anaphylactic reactions or hypersensitive reactions. That will give you a clue to go further. But of course, yes, most of the antibiotics need a test dose. You will have to watch in the 15 minutes to half an hour. You can see a wheal or erythema around the test dose injection. So that will give you an insight. Like you said, if it is sepsis, according to the sepsis guidelines, you need to give empirical antibiotic. Then you will have to weigh the pros and cons and go ahead and give it. That's the only way.
Okay, thank you.
After snake bite and ASV administration and in scorpion sting also, ma'am, do we thrombolyze in the case, or loading dose itself enough for MI due to allergy?
I have no idea. I think anybody in the audience can give an insight to me regarding this.
If you see an ST elevation MI, whether it is because of basic cardiac problem or it is a toxin induced, what the guidelines say is you have to treat the MI as per STEMI guidelines. There is no difference between either you are treating a primary MI or it's a secondary MI. The mechanism of blockade is same. So you treat the MI in similar lines. Thank you.
Thank you.
Thank you, ma'am. Thank you so much. So there are a round of applause for ma'am. Not only, also a fellow colleague, a good friend. Dr. Brinda has been a very good friend. And thank you, Dr. Geeta. I'm so sorry at the time when I had to go down for some work. So thank you so much. So we have Dr. Dhava. Oh, why did even I think that? Just a small announcement. I am handing over the CPC sheets. We have the clinico-pathological correlation. This is the first time in emergency medicine we would be trying it, and I'll be handing it over. And we're passing it. We'll do this, go this corner, this corner. Just keep it with you and read it later. First, we'll focus to what Dr. Dhava has to discuss.
Good afternoon. Thank you for inviting me over. I thank the organizers for giving me this opportunity to interact with all these young minds. Spinal cord trauma is an area fraught with lots of uncertainties and controversies. That's my disclaimer before I start my talk. And at the end of it, you are wondering, what is this guy trying to say? So, as the first bit, I just would like to start with a couple of quick run-through of cases which were seen within the last 2 weeks in our ED. This was a 54-year-old woman with some cardiac history in the past. She was in the back seat of a car, unrestrained passenger. She was thrown onto the front and she fell back to the back seat. She came in with complaints of pain in the neck. She was treated in a government hospital on the highway, and she came to us later because she couldn't move her limbs. As soon as she came in, she seemed okay. Her BP was holding at 160, but as we were thinking about moving it to MR, so she was hypotensive. After excluding any overt bleeds, doing a blood gas, etc., and clinical assessment, on top of all this focus, it's never, shock in trauma is never easily identified unless you use more than one modality: clinical, biochemical, and imaging, at least point of care imaging. So she had all of those to rule out a hypovolemic shock, and she was resuscitated with fluids and pressors, and she was shifted to CT and MR. So CT, even though showed fractures, it didn't show any retropulsion or narrowing of the canal. But the MR could clearly, MRI revealed that she had C4, C6 cord injury with cord edema. Yeah, so subtle fractures. If you are worried, if you want definition of the bones, you get a CT. If you want to specifically look at the cords, in other words, those with neurology will end up needing an MRI. Yeah, any neurodeficit with a suspected spine injury, they'll end up needing an MRI. So yeah, so this was this woman. So she underwent surgery the same day, within a few hours. This was a 75-year-old man. He was in a four-wheeler again, backseat passenger. The seat belt is really a big lifesaver. So we underestimate the relevance of seat belt, particularly those at the back seat. The Tata's Cyrus Mystery guy got killed because he wasn't wearing a seat belt, and this was in a Mercedes-Benz. Our Rishabh Pant was saved because he had the seat belt, even though the car was completely knackered. Yeah, so many instances where seat belt has saved lives. Okay, so coming to this gentleman, you can see that there are fractures. You can see there's extensive spondyloarthritis, and there is fractures involving the mid-spines, yeah, mid-C spines, and there is canal narrowing as well. And there was a C1 lateral mass fracture. The ring was gone, atlas ring was gone. So he had cervical cord injury with edema as well. So with this, we will get into just a quick couple of cases for you to think about. Worldwide, it's a very common problem. 500,000 people get affected every year. Most of them are young, most of them are men, yeah, under the age of, in fact, 30. Average age is 40, but in India, I'm sure it's a lot younger. Majority are from RTAs, but falls account for a significant number as well. Where health and safety is not big in the Indian construction trade and other, you keep hearing about metro sites and whatnot with these injuries. Yeah, 8% of sports injuries, it's not that common in India, but in the West where they have contact sports like American football and rugby, those two sports are specifically related to this. I'm not going to take you through the whole of the anatomy, but remember all the motor fibers are anterior, all the sensory are posterior, and your pain is the lateral spinothalamic tract. There you go, I've oversimplified the cord anatomy for you. And remember, much of the blood supply for the cords comes from the anterior spinal artery. Yeah, much of the supply, and you will have significant motor deficits if there is a anterior spinal artery injury. Okay, so the American Spinal Injury Association gives you the scale. When you're speaking to a neurosurgeon, he would like to know if there is a complete, incomplete B, incomplete C, incomplete D, or a normal ASIA impairment. So in other words, when they have motor and sensory loss with no sacral sparing, so you specifically have to document sacral anesthesia, perianal anesthesia. Yeah, so you always, when you suspect a spine injury, rectal examination is a must. You ask them to grip on your finger, and as you come out, you ask them to see if you can feel them around the perianal area. So those two are a must. You don't document those, you're going to be in trouble medico-legally. Incomplete C is motor preservation below the injury with muscle group strength less than 3. Incomplete D is when there is significant weakness, insignificant weakness, and normal is E. So there are different cord syndromes based on partial involvement of the cords. The central cord is pretty common. It happens in the elderly with low velocity falls, and they have more of upper limb weakness than lower limb. Their neurology is often quite variable. They may have bowel bladder dysfunction, but it's not a constant event. Anterior cord syndrome is a hyperflexion mechanism. Anterior segment of the cord controls motor function below the injury. You can see that there is a significant subluxation of 6/7 in that image. Yeah. Brown sequard is more from penetrating injuries, stab injuries, or we had a guy who had a iron girder from his truck. The truck rolled back and got his back right to the middle. So he had injury pattern similar to Brown sequard. So his neurology was very similar. So other less commonly seen one is the conus medullaris. The conus is the bulbous bit at the L1 fracture. Specifically L1 fracture will lead to conus medullaris injuries. Areflexic bowel and bladder, flaccid anal sphincter will be the neurology often seen. Cauda equina is a big entity on its own. Trauma is also one of the many causes. It's not the cause of, the only cause or the commonest cause. In fact, atraumatic causes of cauda equina are much more common. And it's one of the most easily missed problems in the ED. Those who come in with back pain get discharged with myospas or whatever you give them, and they come back to sue you with a full bladder, yeah, and incontinence. So if a guy comes to sue you with a nappy pad, so you've missed a cauda equina. So it's very common in the UK, these things getting missed. So quadriplegia and paraplegia, of course, suggests that there is a complete cord injury. So a quick word on the types of fractures. If the anterior segment alone is involved, it is a stable fracture. If one segment alone is involved, it's a stable fracture. Anterior mid or anterior mid and posterior, 2 or 3 columns are involved, then it becomes an unstable fracture. 2 or 3 columns involvement, unstable fracture. Chance fracture is what's shown in this picture. So it's a L2 burst fracture. So it happens from lap belt. The retroperitoneal structures you need to be wary about. The attachment of the mesenteric tears. So these patients go in for shock slightly delayed. So your EFAS is very likely to miss these injuries. You won't pick retroperitoneal bleeds. You won't pick slow oozes from the mesenteric tear. Yeah. So these are the guys with chance fracture. Pancreatic injuries, retroperitoneal bleeds, mesenteric tears, root of the mesenteric tears. All of those are from chance fractures, lap belt. Burst fracture is from a significant velocity that is obviously unstable. So the wedge compression you always see with the elderly is osteoporotic collapse. They are often stable because the mid and the posterior columns are not involved. It's just the anterior which is wedging. Yeah. So osteoporotic collapses are often incidental findings unless there is a recent trauma. Yeah. So they may be just to do with the bone density. So a word about Skivora. So this shouldn't really be called radiographic abnormality. Spinal cord injury without, radiographic makes more sense. People used to say radiological abnormality. It's not radiological abnormality. They will have abnormalities on CTs and MRs. Just that the plain films will look normal, particularly with young people, because the facet dislocation and such, they'll relocate. The facets aren't deep enough in the young. Yeah, so it will come back again, but there will be ligamentous injuries and soft tissue injuries. So that is how Skivora happens in children. Yeah, just like with your intracranial injuries, brain injury, so we use the term primary spinal cord injury and a secondary spinal cord injury. The initial insult is what is referred to as the primary spinal cord injury. Maximal neurological deficits are immediately after the injury. Secondary damage is more insidious. The two things that we can correct and we need to think about are hypotension and hypoxia. As in a brain injury, traumatic brain injury, we need to think about those two elements here as well. It results from the combination of other things, including inflammatory response, vascular changes, and ionic dysregulation, etc. So we need to limit secondary injury. This is in our hands. Okay, so this is much of the same. So if you think about it, in a patient with a blunt trauma, the C-spine injury prevalence is only 3.7%. However, if your patient is not fully conscious, he is intubated as well, then that jumps to 14%. That's a huge number. So if you have a tubed patient and you have to image the neck, C-spines, X-rays are not an option. Yeah, with a patient, ET tube and X-rays don't go together for the neck. Yeah, the upper, there are enough numbers, more studies to say C1, C2 and C3 fractures are easily missed if you have an intubated patient. And that is where much of the injuries happen. So don't ask for an X-ray. It has to be a CT. The other rule they say is, if you have to image for a CT head, they meet all the criteria, either the Canadian CT guidelines or your NICE guidelines for CT brain. So then you have to get a CT neck as well, CT head with CT neck. So one other group where you should be very wary about not getting a CT and clearing clinically is the elderly. Yeah, so that's because the elderly have rigid spines. So from their spondyloarthritis, some of them even have ankylosing spondylitis. Those are high risk. If you think carefully, if you look at all these algorithms which help you clear necks, CTC spines, the elderly are exempted from all those guidelines. Okay, so now the ATLS has moved to the term spine motion restriction than spine trauma. The spine boards are a no-no. Once they are in the department, you need to get them off the board. They cause pressure sores, they cause pain and a lot of discomfort. I don't know if any of you have lied in a spine board. It's extremely painful and uncomfortable. So it should be taken out. It's only a transport device. So don't keep it keep them in your ED. Yeah. So if you think immobilization is, we all know that C-spine immobilization is a priority, but C-spine clearance is not. But we shouldn't leave them too long with the immobilization or the spine motion restriction because it's quite uncomfortable for the patient, and there are other added elements of ICP, aspiration risks, etc. when they are strapped down to the trolley. So this is one of the decision-making rules. This is the nexus criteria, which I'm sure all of you are familiar with. So spine motion restriction, when indicated, should apply to the entire spine. So our ambulance trolley or the ED trolley is good enough, unless it's a with a thick bed. If you are in a posh hospital, it becomes a problem. We have thin mattresses in all our ED trolleys. One thing is to tell them, move them out of the ED sooner. That's a hidden message that we give to the management. The patients will complain if it is a thin mattress. Okay, spine clearance and imaging. So I've already told you who needs a CT. We won't go into that. These are some of the collars. All of them are available in the Indian market. The soft collar is nowhere to be used for any reason. Certainly not in the ED. There should be no reason why you should think about a soft collar ever. Is one collar better than the other? We use the Aspen type of collar in our ED, but the Philadelphia collar comes in two pieces. You need to detach and do an anterior and posterior piece. In children, lots of guidelines have moved away from asking you to apply the collar. So you need to think about innovative ways of immobilizing a child's neck. So in Australia, in Northern Europe, in lots of countries, they have done away with the C-collar immobilization for children. You need to worry about C-spine immobilization, but not with a spine motion restriction, but not with a collar in children. Okay, so we need to, if a patient with suspected spine trauma is hypotensive, you need to exclude bleeding. Whatever said and done, in trauma, the commonest cause of shock is hypovolemia. So you shouldn't get too clever and think about a neurogenic shock first. You should always think about hypovolemia. Where is he bleeding from? Should be the question that you need to ask. Yeah. So neurogenic shock is when you have a high cord injury, T6 and above, and they have hypotension and brady. Yeah. The peripheries are warm, they can have penile engorgement, etc. So you need to adequately fill the intravascular compartment before you start using pressors. Noradrenaline should do. Yeah, so this is the same thing in a pictorial way. So if you leave them to be hypotensive with neurogenic shock, that will obviously carry a poorer prognosis. Yeah. Do not mistake neurogenic shock for a spinal shock. Spinal shock is a neurological entity. It's really a misnomer. It's not a type of shock. Flaccid paralysis and absence of reflexes and autonomic function is called spinal shock. Okay, so this is a simplified way of telling you how to manage a spine injury. Yeah, so ATLS principles: maintain MAP above 85, that is important, that's in our hands. Full spine imaging. So if you have a fracture at one level, there's a 10% chance that there is a concomitant fracture at a different spinal level, which is why they're saying full spine imaging. Yeah, and you need to check for cord compression. We've already talked about maintaining the pressures. Steroids, the other contentious issue. So in the 90s, there were two huge randomized trials. They threw millions and millions for a fairly idiotic question, whether steroids make a huge difference. It doesn't. Those two, NASIS 2 and 3, said they have a role. But the problem is they both had different doses and different duration of infusions, yeah, of methylpred. It's very difficult to standardize. The problem with steroids is it increases the risk of infections. Lots of the spinal cord injury deaths are from pneumonia and other infections, UTIs and whatnot. Yeah? So we need to be careful giving them high dose steroids. They also worsen the risk of GI bleed. So it is actually a no. The ATLS, the current 10th edition of ATLS clearly says no role for steroids, methylpred in spine trauma. So you need to, but if you ask your neurosurgeons, some of them still ask for it. There are countries like Korea where they routinely use high dose steroids, so it's not something that's universal. Yeah. Okay, so this is that Korean paper which says they use it there. So early surgical treatment may have a role, but again, this is contentious. They say within 24 hours, not 72 hours. So that's my last slide. So spine motion restriction and not total spinal immobilization is what we need to do. Elderly, most clinical decision rules won't apply. And penetrating injuries, we don't have to think about a collar, and we need to think about preventing secondary spinal injury. Thank you.
Thank you, Dr. Dhava, and I'm sure there are so many other, all of us are managing spinal cord injuries in our ED, so do we have questions? Though he has told everything, he has told us when to use what and how, what are the things. So anyone would like to put some question to sir? No? So I'm sure this is not hypoglycemia happening? No, yeah? Yeah.
Since you already said that steroids are, controversial, but in your last slide you said if patient presents early, then you can consider. So my question is then, do you still prefer high dose methylprednisolone or? I don't prefer steroids at all, but surgeons being surgeons. Recently, I had an argument with one of my neurology colleagues, and he was adamant that yes, we still give steroids.
So there you go. So you don't have a choice because you're going to look after them for, say, anything between 3 and 7 hours. So they're going to look after them for 7 days and beyond.
And I'm not a surgeon, I'm a physician, but still he said, no, we still give steroids.
They usually give dexamethasone 8 milligrams BD or TDS, that is the normal, not the methylprednisolone. Higher dose, they don't give that, the neurosurgeons usually. The higher dose is for say hanging, somebody is coming with hanging and hypoxic changes. There is always an urge to give on the higher side in that segment. But mostly for those people who say, I don't want to give steroids, would you do it for your relative if he comes like this? Okay, so that's your take. But I think neurosurgeons are still on the same bandwagon of giving steroids. I've never seen a neurosurgeon not prescribing steroids. They write steroids even for ICH. They're writing it left and right.
So thank you. So there would be always controversy, and I think so it would be better we will follow the hospital-based policies. Thank you, Dr. Dhava. Thank you so much. And now we have Madam Dr. Lakshmi Narayani ma'am for her talk. So a lot of thermal burns come to the emergencies. We don't take in Nizams, so it's very important for me to sit in here.
Good morning, one and all. If I stand, it is very obvious I'm standing up. So okay. I thank Einstein for inviting this Aeme program. I am talking on thermal burns, which is most important thing because of his morbidity as well as lifelong disability. So definition of the burns, the systemic and local response of body to an energy transfer from a thermal or an electrical source. The burn wound is defined as a break in continuity of an integument layer of surface by exposure to thermal, electrical, chemical, radiational stimuli from external sources. So the thermal threshold, so 44 degree centigrade usually damage the skin when exposure time more than 6 hours. 44 to 51 degree, the damage doubles with each degree increase in temperature. If it is more than 70 degree, there will be total tissue destruction. So the pathophysiology, as already we would have learned in our MBBS and even during our post-graduation. So the Jackson's model shows there are 3 zones. So the zones of thermal damage, the zone 1 coagulation, where the damage is more and it is irreversible and it because of the coagulation necrosis. And zone of stasis, here there will be a reduced tissue perfusion. So our aim is to improve the tissue perfusion. And zone of hyperemia, where there will be increased tissue perfusion. And the systemic response, our body will respond as an acute inflammatory process. So generalized response in burns, even if it is more than 20 to 30% of total body surface area. The consequences are increased microvascular permeability and release of histamine and bradykinin. And there will be increased microvascular hydrostatic pressure and increased serotonin and increased prostaglandin E2 and prostaglandin I2. So what are the hemodynamic changes that will occur? So the patient presented with the burns, mostly if the degree is more or the surface area affected is more, the patient will be presented with the hypovolemic shock. So how the hypovolemic state occurs? So there will be increased capillary permeability, so loss of protein-rich fluid into interstitium, and it leads to burn edema, which in turn cause increased interstitial oncotic pressure, and this will cause loss of extracellular sodium, so cellular edema, as well as deranged cellular sodium-potassium pump, which leads to loss of extracellular, which will lead to cellular edema. Both together will cause plasma loss at 4 ml per kilogram per hour. So how we should approach the patient? So before they reach the hospital, so pre-hospital triage and care. We must not get injured ourselves. Firefighting is not the job of the person administrating the first aid. So first, stop the burning process. Stop and drop policy. Here, the flame should be doused with water and don't throw or apply mud or sand. Cover with heavy cotton cloth, blanket, rug, diary, coat or any other heavy fabric, not nylon. In pre-hospital triage and care, so bring the victim in the open and you see, assess the patient. So ABCDE and or CRP. And smoldering clothing should be removed and rings. Cool soaks aid in the cooling process only for the first 10 minutes following the burn injury. Don't break any blisters. Do not apply any medications locally. Prevent contamination. Providing pain relief and reassurance to the patient. And withhold oral intake. Then you have to make arrangement, transport the patient to a medical facility. What are the guidelines for hospitalization for the burns patient? So American Burn Association has given some guidelines. If there was second degree burn more than 10 to 20% of total body surface area, or third degree burn more than 5% total body surface area, if the burns involve the face, hands and genitalia, if it is due to electrical burns, chemical burns, inhalation injury, associated injury, and already if the patient is having pre-existing diseases and on medication, age if it is less than 10 years and more than 50 years. How to evaluate the patient? So history is important. As a surgeon, I used to tell my students, you have to get history first. From the history, we can arrive at least provisional diagnosis. It will hinge some points. So age, how it occurs, whether it is a flame, hot liquid, chemical, or it is an electrical burns. Whether it occurs in the closed space or in the open space. And it is important to know whether it is an accident burn, suicide burn, or it is a homicide. And associated injury to the abdomen, chest, head. And we should know about the pre-existing illness and medication already the patient taking, because sometimes in burns ward, we used to come across with patients who have seizure disorder and at the work spot they may be having burnt and time of burn. we have to estimate the burn extent. So it is expressed in percentage of total body surface area, because it is important to tell about the fluid requirement and the prognosis of the disease. And it's best done immediately after admission, and is more important than depth during initial management. So as rule of 9, so Wallace have given the rule of 9, how to estimate the extent of the burns area, and for the child as well as for adult. For child head and neck area, it's 18, whereas in adult it is 9, upper limb 9, anterior trunk 18, posterior trunk 18, lower limb 14 in children, whereas in adult, upper limb 9, anterior trunk 18, posterior trunk 18, lower limb 18. There are other methods also to know the extent of the burnt area, Lund and Browder chart or rule of palm. Classification of burn depending upon the depth. So we can assess whether it is the first degree, second degree, superficial or deep, or it is the third degree full thickness burn. So if it is a first degree burn, it is the sunburn, the appearance will be erythema, the patient will have the sensation, and the healing process occurs 3 to 5 days. And second degree superficial burn, the clinical feature will be pink, wet blister, and the capillary return will be present, and sensation is present. It will take 10 to 15 days for epithelialization. Second degree deep burn, so waxy, and it is white, and the sensation is positive, and it takes 3 to 5 weeks time, and healing will occur with the contraction. And third degree, it is full thickness burn, where the clinical feature will be dark brown, dry, and parchment like eschar will be present, and it is without any sensation, and the lesion will be needing skin grafting. So depth of the burn, first degree, usually the epidermis will be affected and red, hyperemic, and cause discomfort, heals without scarring, and it is the sunburn periphery of the second degree burn. Second degree superficial, here the epidermis and papillary dermis are affected, and the patient will present it with blisters, and it is moist pink in color, it blanches on pressure, and extremely painful because of the sensory nerves are exposed, and heals without scarring in 10 to 14 days. And second degree deep burns, here the epidermis, papillary dermis, and part of reticular dermis all affected, and blister is uncommon. It is dry, pale, hypoesthetic, and heals with hypertrophy in 3 to 6 weeks done. Third degree burn, epidermis and whole of the dermis is affected, and it is charred, black in color, dry, and thrombosed veins will be present. There will be no blisters, and it is painless. And sloughing of necrotic tissue forms, and raw area, patient may heal with contracture, or there may be non-healing ulcer or unstable scar will be present. How to manage the patient? So, immediate management, IV cannulation may not be successful because collapse of the peripheral veins, as well as if the burnt area is in the extremities. So, central venous line or venous cut down may be needed. And bladder has to be catheterized to know the kidney function, urine output. At least a sterile sheet to be covered to the patient before dressing is done. And warming blanket may be used. And the foremost thing is fluid management. So how to reassist the patient. So here the cornerstone in burn management is replacement of sequestrated fluid and extracellular fluid loss and plasma. So this increases the cardiac output, improves tissue perfusion, prevents renal shutdown, and it corrects acidosis. So the choice of the fluid is crystallized. So ringer lactate solution. It expands the intravascular volume, and it corrects sodium deficit. How to calculate? So the Parkland formula, 4 ml per kilogram per percentage of burn. And here the urine output assessed to be 0.5 to 1 ml per kilogram per hour. And now in Thai manual, they suggest the modified Parkland formula of 3 ml per kilogram per minute. And modified Brooks is 2 ml per kilogram per percentage plus 2000. What are the other registration fluids? So the colloids which have to be given First 24 hours leaks out of capillary, so the increased edema will be present. Later it is retained in the vessels, so draws in sequestrated fluid, so the edema will reduce. So given 24 hours after burns, less volume requirement, and it corrects plasma deficit. And the Evans formula is 1 ml per kilogram per percentage of total body surface area, normal saline, plus 1 ml per kilogram per colloid plus 2000 ml. And Brooks formula 1.5 ml per kilogram per percentage of ringers plus 0.5 ml per kilogram per percentage of colloid plus 2000 ml. So how we recommend, earlier we used to study, you have to divide into 8 hours, 8 hours, 8 hours. Now first 8 hours, half of the fluid calculated by Parkland formula. So ringer lactic solution, which contains the ringers 130 milliequivalent per liter plus sodium bicarbonate 50 milliequivalent and at 4 ml per kilogram and percentage of the total body surface area. Next 16 hours, remaining half of the fluid calculated by Parkland. The urine output should be maintained at 30 to 50 ml per hour in adults and 1 ml per kilogram per hour in children. The second day, half of the first day's ration, 5% dextrose and colloid, add ringer if resuscitation is incomplete, 0.3 to 0.5 ml per kilogram per percentage of total body surface area burnt. What are the effects on GI? So patient may present with paralytic ileus, hypoperfusion of the gut, and neuroendocrine changes occur. Sometimes it may lead to stress ulcer, curling ulcers, so GI bleeding may occur. First, nil orally for first 24 hours and nasogastric aspiration. Nutritional requirement for adults, 25 kilocalorie per kilogram body weight plus 40 kilocalorie per the total body surface area burned. For child, 60 kilocalorie per kilogram body weight plus 35 kilocalorie per the total body surface area burned. The fat, 20% of calories, and oral route is preferable if the patient is able to swallow, and dietary shortfalls supplemented through the parenteral route. How we will manage the burn wound? So cleaning of the burnt area with normal saline, and if it is the large blisters, debridement can be done. Dressing with soframycin, silver sulfadiazine, and betadine solution, and collagen or Acticoat newer products which can be used, and splinting of hand in functional position. If patient develops the compartment syndrome, so you have to immediately react an immediate fasciotomy to prevent further circulatory compromise. Minimize the chances of amputation of the extremity. Escharotomy or fasciotomy, so you have to assess the peripheral circulation, especially in electrical burn and a nail bed capillary refill, and you see the peripheral arterial pulsations. Systemic antibiotics, to tell no role of prophylactic antibiotics, but we usually start with an antibiotics if the patient is admitted with a more degree of burns. So these to start with the broad spectrum antibiotic. So indications, burn wound sepsis, septicemia, respiratory tract infection, urinary tract infection. And this antibiotic should be specific depending upon the culture and sensitivity. And it should be administered in full therapeutic dosage. And now I switch on to the special categories of burns. Inhalation injury. It increases the mortality by 20 to 40%. So intoxication may be due to carbon monoxide, carbon dioxide, hydrogen cyanide, and it can irritant damage to the respiratory tract and thermal damage to upper airway. So the signs, periorbital burns, intraoral burns, and the patient may be present with a stridor, and the shoot in mouth and nostril. Patient may have hoarseness, drooling. There may be pharyngeal and laryngeal edema, especially if face burns patients are coming. We should be very cautious. Anytime they may go for pharyngeal, laryngeal edema. Management of inhalation injury, airway, dyspnea, stridor, hoarseness, glottic edema. You can intubate the patient and connect to CPAP. If intubation fails, tracheostomy. And breathing, including the respiratory rate and shoot in mouth, bronchoscopy, and you can intubate the patient. Circulation, assess fluid requirement, and CBP monitoring. Electrical burns, visible on the skin. It is a tip of iceberg. Damage is beneath the skin and it is maybe extensive. Therefore, the actual injury can easily be underestimated. Electrical burn to muscle acts like a crush injury, so the patient may go for acute renal failure due to rhabdomyolysis. Myoglobinuria alkalize the urine, and cardiac monitoring, you have to ask the patient to undergo ECG and cardiac evaluation has to be done. Ophthalmic burn, blebrospasm, conjunctivitis, corneal ulcers. Treat with copious irrigation of water, topical antibiotics, lubricants. May require surgery. Thank you. Before I close, I want to tell வள்ளுவர் தீயினார் சுட்டப்பண்டு உள்ளாரம் ஆறாதே நாவினார் சுட்டவடுன்னு சொல்லியிருக்காரு. ஆனால் நம்ம சொல்கிற சொல் சமயத்தலத்தில் we can forget it or we can forgive the words. But once the patient, if they are coming with the burns, lifelong they will be having the scar or the morbidity will be more. So burns, when the patient is coming, we have to assess how much the surface area is injured. That will tell. If the percentage is less, definitely the patient will be get cured with the scar, but they can go on with the plastic surgery. Treatment, if there is any disability. Thank you.
Thank you so much, madam, for this comprehensive I'm looking for some questions and comments from the
You saw that very nice picture which Dr. Narani had put up regarding the child with the inhalational burns. What's the first thing that you will do when you see that child? Answer me. What's the first thing you will do when you see that child? Come on. Huh? Excellent. Open the mouth, not yours, but the child's. Okay. Why? Child is breathing. Child's eyes are open. Why should you look at the mouth? Yes. Trust me, when you have a patient like that, externally the patient may appear to be breathing, but there is a progressive laryngeal edema which is setting in. Progressive is the word. There is a progressive laryngeal edema which is setting in. So I had a look at this child. I've had a similar sort of experience not very long ago. So when I put the laryngoscope in and I opened up, what I saw, what normally we see is pink mucosa, right? How many of you have looked inside the oral cavity of a patient with inhalational burns? How many? Show of hands. Okay, 3, 4 of you. For the rest of you, I want to let you know, normally when we intubate a patient, all of you have intubated, right? Is there anybody who's not intubated so far? None. All of you have intubated. What we look for is the pink color in which you see 2 white curtains, in the middle of which you see a black color, right? That's what, like Arjun, we are trying to look for that white curtain with the hole, right? Burns patient, no. You will see a white wall with no hole. If you are happy, if you are lucky, you may see a thin slit, okay? So when you go in to handle a patient with inhalational burns, what do you carry in your hand? You carry a bougie. Very good. See, my boys know. You carry a bougie. Okay? Don't attempt, don't even go there unless there is a bougie in your hand. The minute you see that tiny slit, try to put it into it. And then run your laryngoscope, run your endotracheal tube on that, okay? And do this immediately. So the first thing that you will do is you'll open the mouth of the patient. If it's white, intubation, and I want the bougie. Okay, so please remember and do not forget. That's important. The next thing is, Dr. Narani also said that, you must put in a catheter, right? So you put in a catheter for this patient, and he has drained 250 ml. Now the question, what does it mean to you? A patient who's had burns, who comes into your department, you've had a look, 35% burns, mostly involving the head and face because the stuff burst, common thing which happens. And this patient, catheter was put in, 250 ml has been drained. The nurse comes and tells you 250 ml. What does it mean to you is my question. What does it mean to you? Anybody? It means one word, that's a clue. One word. What does it mean? Come on, think. I know you're all hungry, hypoglycemic. What does it mean to you? Somebody, one word, starts with the letter N. Huh? Who said that? What did you say? Nothing. It means nothing. That's the urine which was there before he got burnt. It means nothing. Remember that, okay? So these are 2 points which I thought I will highlight to you. All right? Okay.
So just touching on what Sir said before about the intubation part, I'm sure a lot of you have intubated patients before. Obviously, a burns patient is not an easy patient to intubate. I'm sure most of you would be using succinylcholine to intubate all your patients in general. But what's an important point to know is that succinylcholine can't really be used in patients with burns more than 24 hours. So the reflex action is to load up your relaxant and to give, but always be careful while giving succinylcholine to these patients, because this is already a difficult airway to begin with. It's not something which a resident of VM would be expected to know to intubate. It's very, very difficult. Never give choline to these patients, especially if the burns are more than 24 hours old. Second thing is, I think it's very difficult to touch on the entire pathophysiology and management of burns in 13 minutes. Ma'am did a fantastic job. One more thing I'd like to stress on is pain relief in these patients can be extremely challenging. If there's any subset of patients that needs a very high dose of opioids or ketamine, it would be these patients. So because if the pain is very high, again, that leads to the further pathophysiology of burns. So high dose of opioids, very careful intubation, avoid choline if at all possible. Just wanted to complete your last thing, ma'am, if that's okay. This is for the residents mainly. Thank you.
So thank you everyone. So we are just reaching 1 o'clock. So this is lunchtime, isn't it? So they are even smiling out. Yeah. So I'm also happy. I finally could book hotels for. I finished the work I was supposed to do. So I'm feeling so happy. And I'm so thankful to the young young colleagues out here who just took it from me. And, thank you so much, Dr. Rahul, Dr. Mario, Dr. Sandeep. Thank you so much that you just came forward and I could finish my work. Let's go for lunch. We are planning to meet back as early as possible. So should we say that can we meet around 1:40 back here? Yeah? So we'll meet back at 1:40 because we have to do this. So thank you so much. Thank you, ma'am. keep that. Okay, so we'll just have Mr. Shashank, who has come from, Mr. Shashank, is it okay for you now? Yes. So Mr. Shashank, who has come from all the way from Bangalore, this is Bactiguard, and they have been our official sponsors. He wants to talk to us for 5 minutes. Please, the stage is all yours. Your thing is low.
Because if I stand on this, I'll probably be cut off from the... Okay. Yeah. Very good afternoon to everyone. I know this is the post-lunch session. Most of us will be quite drowsy, but we'll try to make sure that, this is a topic that will make you think a little differently of what we have been discussing, because the conference, I've spoken to Aeme madam quite a few months back, and the planning that has gone into it, it has really been fantastic. So congratulations to the organizers for doing such a wonderful job of bringing this conference and all of you here. So the reason I'm here is to kind of give you a little different perspective of how we look at some of our patients that are critically admitted in our emergency wards. When they come to us, some of the interventions that we do, whether it is putting an ET tube, whether you're putting a Foley's catheter or putting a central line catheter, sometimes whether it's a burns patient, maybe a road traffic accident patient, you're trying to revive this patient. Many times we tend to forget what actually happens when we're doing some of these interventions. In the long run, some of these patients start developing hospital-acquired or healthcare-associated infections. I'll just start with a couple of facts that this is there, probably very relevant. This is 2019 statistic that says that about 1.3 million people died because of road traffic accidents. Any guess how many people died because of antimicrobial resistance and hospital-acquired infections? Any guess? Maybe 20 times? Hopefully not, sir. But we are very close to that. So the number of people actually that died because of road traffic accidents is pretty much the same number of people that have been dying who come to our hospitals, because the rampant misuse of antibiotics that has been happening around. Most of the patients who come to us already are on 2 to 3 different courses of antibiotics and develop a lot of resistance. So now how do we deal with the resistances? Either you try to find new antibiotics or you're trying to find a solution how you can prevent these infections from happening. And if you see studies that have clearly shown, not just in developed countries, even in developing countries like India, and even in developed places like Coimbatore or Delhi or Bangalore, we see a lot of infection rates that are happening. And if you see the same study that talks about it, a majority of these are patients who have been already intubated, who have been in the ICU on ventilator-associated infections, many of them because of bloodstream infections, because of the central lines that we have put, and intra-abdominal and urinary tract infections. Now, one of the most unfortunate things is that when you deal with such infections, not only the patient becomes sick, there is increased morbidity, increased mortality, but there is also an increased cost that is associated. And in a cost-sensitive market like India, it is very important that we try to save as much money as possible for the patients and for the system that is there. So the idea is that whenever you're looking to intervene into the patient, think about what is the indication. Is this patient going to need a longer intubation? Does he need a longer Foley's? Does it need to be handled more carefully in terms of aseptic? I know sometimes in emergency when we're handling patients, aseptic technique is not always possible, but we try our best to make it. Second is, how do we choose the final material? And today this is where I want to take you a little back into physics and chemistry and to tell you how the unique technology that was thought about more than 100 years back today has making wonders to a lot of people. Okay? Now this is called as a galvanic effect that is there. Now you may be wondering, a lot of ladies would be very happy to know that there is gold in what we are going to be using. So please do not take this out for making jewelry. You don't have to recycle any of this, a lot of them. But when you use two metals, when you put it together, there is something called as a galvanic corrosion that happens. That means they react with each other. There's electrostatic current and they start corroding. But that is not what we want. When you combine noble metals like gold and silver, especially if you've seen all of your mobile technology and other things, everything has gold because they don't corrode, but when they mix with each other and when there is a solution like a water or anything that is there, it generates a mild electrostatic current. And this electrostatic current is the one that repels any bacteria from
getting coated onto your catheters. Now, whether it's a Foley's catheter or centerline or ET tube, it does not allow them to be coated on that. And once they prevent the coating, there is no biofilm formation and there is no increase in the infection rate that happens. Okay. Now, as you may say this, Shashank, this is just lab technology. This is just physics and chemistry. What is the real effect on evidences that we have? Now, Bactiguard, as we say, is more than a 30, 40-year-old company, and it has been providing clinical evidence that has been extremely strong and extremely useful in terms that have been published in peer-reviewed journals. Over 200 million patients have used Bactiguard-coated catheters and have done very well. A lot of patients' data that has been there, a lot of reduction in infection rate. So the first choice when you intervene into a patient, when a patient comes into emergency, you need to decide whether this patient is going to be on a long-term therapy of any intervention and how we need to protect it. That is there. So if you see the data from COTI data, this is a 58% reduction in COTI rates. Now more longer-term data where patients have been on Foley's for more than 50 days to 80 to 90 days. Again, the catheter has been changed only once in 50 days. So that shows the length the catheter, a single catheter can be used without being changed and still reduces infection rates. Now, if you look at data from India, this is from about 1,000 patients, and here also we have shown that COTI rates have reduced by almost 70% even in resource-constrained setting like India. That's the reason why repeated Foley's catheter, when you change, you are actually adding cost to a lot of patients. But here, a single catheter is actually able to answer that solution, give you a cost-effective solution, and reduce infection rates. ET tube, again, we see about 53% reduction in VAP rates that are there. This is from Belgium. And if you see the central venous line from Germany, again, septicemia and bloodstream infections have reduced in terms of 52% and 40% respectively compared to standard coated catheters that are there. Now, one important thing that you have to remember between antiseptic or antibiotic coated catheters versus Bactiguard coated catheters is they actually release the antiseptic or antibiotic into the bloodstream or into this thing that is there, and they actually cause damage to other cells. But here, this actually just releases electrostatic energy, and that's how it's able to repel the bacteria and prevent biofilm formation. So that's the reason it's much safer. So we have options of Foley's, CVC, and ET tube. And in case if you're into surgery, yes, we have even special coated implants also, which are also available. Okay. So that's the end of my presentation. Any quick questions if we have a minute or two before the first speaker? Yes, sir.
Yes, sir, 2,500.
So your catheter will be 4,500 to 5,000.
Yes, sir. Yes, sir.
One catheter.
Yes, sir. Sir, this catheter can be used up to 30 days, sir.
But the patient will not stay in the ED for
30
days.
Yes, sir. Sir,
How
we.
will I decide which patient
Yes.
needs to be put this catheter? Ideally, the ED has to keep these patients for 3 hours.
Yeah.
But that window period is always broken and they stay for longish periods.
True, sir. I mean, as you very rightly said, at your department, at the emergency department, it may not be very easy to determine, but I'm sure with all of your experience, these are patients, obviously if you get a patient who's had a quadriplegic or a paraplegic injury, the spinal injury that's come, a patient with severe burns, like what madam showed us earlier, I think these are patients who would probably qualify, those who are going to be in the ICU for more than 6 to 7 days, definitely warrants a cost versus benefit ratio. I always say that because as a doctor and an infection prevention specialist, I say that whatever intervention that you do has to be something that prevents infection, but also keeps the cost less for the patient and the hospital.
So now let us talk about your Foley's catheter. A normal Foley's catheter versus your impregnated Foley's catheter cost.
My Foley's catheter cost, it is 1,300 rupees MRP.
Normal Foley's will cost how much?
600 rupees. 600 rupees, yes.
600 versus 1,000.
Yes, sir, but we have a studies, we can reduce CAR-T by 69% by changing this
I
simple.
got the idea
Yes.
that you can, HAPs, you can
Yes.
reduce the infections.
Yes, but we can.
But the cost is an important factor, and since the patient in the ED has to remain for a very short period, ideally.
Yes, sir.
So we are not talking of intensive care, we are talking of EDs.
EDs, yes.
Okay, so bringing these catheters into the EDs will be, I think,
I mean, that's a choice that you'll have to decide, sir, because if there's a choice that you've put a catheter, you've put an intervention for the patient in the ED and it's the same, it's going to continue in the ICU, then makes sense. Yeah.
because the ICP practices in the ED are at best pathetic. Okay, so bypassing all those practice elements like simple hand hygiene and going away straight into impregnated catheter is miles away. Okay, so the ICP protocols, if you really go into an ED and see them actually being followed, you'll be aghast at the way the ICP measures are being undertaken in the ED. So bringing in a catheter, which is meant more for, I think, intensive care, into the ED is a bit too early, I believe.
Sir, I absolutely agree. If you had asked me this question as from the IP point of view, I would have absolutely said that, first we need to correct the basics, then come to this. As I said, start with the basics and then all of this. Yeah. Very well said. Thank you so much. Thank you, ma'am.
Thank you so much. And, thank you for showing your appreciation for faculties and delegates. So all of us are carrying back the bag with Bactiguard. So thank you so much for that. Now, though I know that emergency medicine is those first 15 minutes or maybe 2 hours, 4 hours, but then we thought we will, in the recent times I've gone to NMC meetings, they have always questioned that there have been some people who have questioned that there is no continuum of care. That is what they always keep on asking. There is no continuum of care, madam, and your PGs don't go back and see what they diagnosed, was it that, and all that stuff. So we thought, why not do a CPC? Let us see that what we would have thought after reading the clay case with PGI Chandigarh has given, and all those who have not gone through the case, the pages were here, I had told in the morning also. And let us see how it happens. How the case unfolds, okay? So all over to Dr. Atul Saroj and also to Dr. Debashish, who has come, Debajyoti, who has come from PGI, he's from the Department of Pathology, to give his inputs on the case. Please, sir, the stage is all yours.
So, good afternoon. After heavy lunch, a brainstorming session for all of you. So I have already distributed clinical protocols to all of you. Hope you have already gone through it. Still, if someone has left, then I will just read out in short complete clinical protocol. So to start with, 38-year female, Mrs. GK, admitted on 23rd September. And date of demise is 24 September, so she has stay of less than 24 hours in our emergency. Patient chief complaint at the time of admissions are seizures and altered sensorium for 5 days, fever for 1 day. And then the background history on June 2021, she has a history of giddiness during walking and that evaluated at local healthcare facilities where neuroimaging shows right cerebellar infarct. Patient CT, MRI, angio was not available at that time. Patient was started on aspirin and she was discharged. Again, in 23rd September of 2021, she presented in emergency with history of 3 episodes of generalized tonic-clonic seizure over 5 days, and she had a last seizure episode 4 hours before admission, followed by altered sensorium with decreased responsiveness and low verbal output. Patient has history of fever for 1 day with no apparent localization, which relieved with antibiotics. There was history of passing cola-colored urine, no history of reduced urine output, dysuria, prothuriia, or anasarca. There is no history of pain abdomen, jaundice, or altered bowel habits, no history of symptomatology suggestive of any connective tissue disorder. No similar illnesses in the past and no bad obstructive history. No history of COVID vaccination as per the patient's relatives. General physical examination, her GCS at the time of admission are E4, B2, M5 with pulse rate of 90, respiratory rate of 20 per minute. Blood pressure is around 100 by 80 millimeter of mercury. She is febrile, oxygen saturation maintaining 97% on room air. On general physical examination, multiple ecchymotic patches were noted all over the body. In systemic examination, CNS ST of gaze preference to the left, non-nystagmus, bilateral pupils are reacting to light, but detailed CNS examination could not be done because the patient was not cooperative. CNS, normal heart sound, no murmur, respiratory system, bilateral air entry equal, no adventitious sound. Per abdomen soft, no tenderness and no organomegaly. In investigation part on biochemistry investigation suggestive of unconjugated hyperbilirubinemia with raised LDH level, and her creatinine is borderline around 1.1 to 1.6 milligram per deciliter. But in detailed coagulation profile are within normal limit, APTT and INR are within normal limit. Further microbiological investigations are negative for scrub typhus, Vidal, malaria parasites, and dengue NS1 antigen. With negative for COVID gene expert, blood culture and urine culture are sterile, and procalcitonin and C3, C4 are within normal limit. So, what further hemogram, one value of platelet count we have with us of June 2021, at that time patient has a history of cerebellar stroke. At that time her platelet is little bit lower, around 1.1 lakh, but in this recent admission patient has severe thrombocytopenia with reticulocytosis and severe anemia. Peripheral blood film done in emergency, suggestive of cystocytes around 3 to 4% with markedly reduced platelet count. Patient has raised BNP levels, troponin T is also elevated more than 3 times, her ECG suggestive of sinus tachycardia, and iron studies of suggestive of raised ferritin. Vitamin B12 or folic acid are relatively within normal limit. Urine routine has nil sugar, 1 plus protein, and blood is 3 plus. NCCT suggestive head suggestive of hyperdense areas in bilateral frontal lobe, and cerebellum suggestive of subacute to chronic infarct. So this is what the available investigations and history. In the course and management, this 38-year-old female with history of cerebellar infarct in June 2021, admitted with multiple episodes of seizure followed by altered sensorium. The patient was intubated for airway protection. On evaluation, she has hemolytic anemia with thrombocytopenia and 3 to 4% cystocytes on peripheral blood smears. With evidence of microangiopathic hemolytic anemia, thrombocytopenia, and cystocytes, a possibility of TMA or TTP has been kept, and she was started on plasmapheresis. During the first cycle of plasmapheresis, she developed acute shortness of breath and hypotension. The procedure was stopped, vasopressor and mechanical ventilation was started. However, the patient has cardiac arrest and CPR was done as per ACLS protocol, but she could not be revived and declared dead on 24 September 2021 at 9:46 p.m. Unit's final diagnosis are respiratory shock, the possibility of both obstructive plus hypovolemic, pulmonary thromboembolism, TTP in the setting of old history of CVA, likely cerebellar infarct. So this is what the clinical protocol and clinical presentation at the time of admission in emergency. The patient has very short stay in PGI emergency, and all the investigations and all the therapeutic intervention is done in emergency, and after his death, the relatives give consent, and we have performed the autopsy. So the point of discussion in this, what is the primary diagnosis? So what is the basic etiology, and what is the extent of organ involvement? And what is the terminal event that ultimately led to the death in this patient? So if we see the patient database, patient has indirect hyperbilirubinemia, raised LDH, she has a neurological symptoms in the form of seizures, altered sensorium, she has a peripheral blood film suggestive of reticulocytosis with thrombocytopenia with NCCT head suggestive of multiple infarct. So if we see the 2021 update of International Committee for Standardization in Hematology recommendations for importance of cystocytes for especially in diagnosis of TMA syndrome. So what is their algorithm? They suspect that if there is any suspicion of TMA, especially in emergency setting when patient is presenting with microangiopathic hemolytic anemia and thrombocytopenia. So these are two basic things. If patient is presenting with this picture to you, then you should suspect the TMA syndrome and send patient's peripheral blood film for cystocytes. So what is their algorithm? Their algorithm is that whenever there is clinical suspicion of TMA, we should look for FRC count. FRC means fragmented RBCs count. So it is just automated, and your machine will automatically tell that your fragmented red cell count are positive. Then we have to consider for cystocytes and look for the peripheral blood film. So if the presence of cystocytes are abundant, then we have to count around 1000 RBCs, and if there is percentage of more than 1%, then it is significant for diagnosing TMA. Initially, the limit of cystocyte percentage is around 2 to 4%, but now the threshold has been lowered down till 1% for diagnosing TMA syndrome. So this is just an algorithm for diagnosing of TMA with respect to the cystocyte with updated classification. So what are the main TMA syndrome that we have? So we have reached that patient is likely TMA. So but the primary TMA syndrome, because it is can be acquired, can be hereditary. Hereditary are especially seen in children or infant where there is genetic defect. And adult, and these patients are mostly have acquired TTPs. Other categories are drug-mediated. Some drugs like clopidogrel, chemotherapeutic drugs, even estrogen has been reported to be associated with TMA. Or cigatoxin-mediated TMA, that initially called as cigatoxin-related HUS, that can also be a part of primary microthrombus syndrome. So what is the approach? This is just a diagnostic algorithm, how you should approach a patient of TMA, especially in emergency situation. As per initially I have told that patient with microangiopathic hemolytic anemia and thrombocytopenia, we look for any underlying conditions. Because many underlying conditions, especially patient has DICs, patient has severe sepsis with infection, if any evidence of malignancies or preeclampsia, these are the conditions where peripheral blood film can have pictures of microangiopathic hemolytic anemia. But in present patient, there is no any underlying condition because patient has a short history of 2 to 3 days of illness and then suddenly deteriorate. And this part is out of picture. Then next is, if we look the age criteria of patient is an adult criteria, so condition resulting in infant and child with TMA like complement mediated metabolism, hereditary are out of picture. So last we have with kidney injury. Our patient creatinine is started from 1.3 and in the last at the time of demise is around 1.6. So it's likely she has a minimal or no clinical injury. So if we see, then acute kidney injuries are out of picture. So patient has a minimal or no kidney injury. So possibility of TTP we have kept a high on the cards. So if we see the algorithm, then in TTP, as I already said, there is two categories. One is hereditary and other one is acquired. Acquired means associated with some other illnesses, or it can be immune mediated, or it can be antibody induced, especially ADAM13 deficiencies or autoantibodies to the ADAM13 enzymes. So if we see the classical pentad in our patient, all the 5 pentads, she has a microangiopathic hemolytic anemia, she has a thrombocytopenia, fever, neurological involvement in the form of cerebral stroke, and seizure and altered sensorium at the time of her demise, and renal impairment is mild. So she is fulfilling all the 5 criteria. So she is a possibility of TTPs still we have kept on high on the card. Now I come to next slide is plasmic score. So for resident, I just want to highlight that plasmic score is not for diagnosis of TMA. Plasmic score just indicates that how severe ADAM13 enzyme deficiency is there in the patient. So, and if you see the variable of plasmic score, this has platelet count, hemolysis variable, no active cancer, no history of solid or organ transplant, MCV less than 90 fagoliter, or INR less than 1.5, or creatinine less than 2. So in our index patient, if we see, she has all the variables. Her platelet count are around 11,000. She has a hemolysis variable in the form of reticulocytosis. around 1%. She has no active cancer, no history of solid organ transplant. Her MCV is less than 90, INR is less than 1.5, and creatinine is less than 2 milligram per deciliter. So our patient has total score of around 7. So if we see that 7 scores indicated toward the severe deficiency, Adam 13 deficiency, so highly likely the patient has acquired TTP that resulted in her sudden deterioration. So is the TTP alone in this patient? Because she presented with background picture of TTP, or is there some secondary illnesses that is associated with TTP in this patient? So why I am saying this? Because this patient has a history of cerebral stroke in June 2021. And at that time, she is managed with only medication, no therapeutic plasma exchange. And if we see the literature, the TTP has mortality rate around 90%, especially who are not treated with therapeutic plasma exchange. So is that time it is only TTP episode, or there is some underlying illness that precipitated the TTP in this patient? So what are the underlying conditions that can be associated with TTP? Are these type of case series reported by different authors, where the most common they have found idiopathy to be associated with TTP, but other conditions are autoimmune disease, cancers, pregnancy, drugs. So if we see in our patient, drug is out of picture, she is not pregnant, she has not given any history of cancers, and HIV infections and others are negative. So we have kept the possibility of autoimmune disease, Curie antiphospholipid syndrome, or in this patient. So why antiphospholipid syndrome? Because if we see the clinical criteria, then patient has history of arterial stroke, likely cerebral stroke in the June 2021, but there is no history of pregnancy morbidity. So out of clinical criteria, only one criteria she is fulfilling, but there is absence of laboratory criteria. So if we see the revised SEPRO classification for TTP, antiphospholipid syndrome, then presence of cystocytes on peripheral blood film in APLA patient, then we have to stress that there is associated TMA also present in that condition. There is associated presence of thrombotic microangiopathy in setting of APLA syndrome. So other possibility, is there a PNH? Because patient has cytopenia, patient has thrombosis in the form of cerebral stroke. But if we see the literature on cystocytes in PNH, then cystocytes are absent, and any presence of cystocytes in PNH patients should indicate regarding thrombotic microangiopathic disorder that should be ruled out. So next is, what about other thrombotic thrombocytopenic disorders which can present with this type of picture? So in that category, catastrophic APLA, because patient has suddenly deteriorated, she has a multi-organ dysfunction, she has raised cardiac biomarker, she has a neurological involvement, and she has a large vessel involvement in the form of cerebral stroke. So is it possible? But the point against is that patient has no prolongation of APTTK, and she is not fulfilling the diagnostic criteria for catastrophic APLA. HELP, DIC are out of picture as history not suggestive of so. Heparin-induced thrombocytopenia and thrombosis syndrome can be one of the possibility, but there is no heparin exposure in this patient. Other possibility that can be considered in this setting is vaccine-induced thrombotic thrombocytopenia that is reported with ChAdOx1 COVID vaccination in recent after COVID pandemic, and there is also presence of small and large vessels, but the patient categorically denied that she has no history of any vaccination in the recent past. So this is what about the diagnosis. Now I will come to the organ injuries. So especially in context to our index patient, if we see the reported organ injuries on TTP, as per the literature from UK TTP registry, around 80% of the patient have neurological involvement. And as compared to other symptom involvement, neurological has significantly more percentage of patients who have neurological abnormalities. So is there a possibility of any recurrent or relapsed TTP? Because our patient has 2 episodes of TTP, one episode is in June and next episode is in September 2021. So there can be a possibility of transient or recurrent Adams 13 antibodies that can present with single or repeated episode of the TTP. So if we see the available literature, so they have reported some case report where the patient has either 2 or thrice relapse of TTP episode, and that time their baseline platelet count is around 2 lakhs. So similar to our patient, because when our patient has on a first episode of cerebral stroke, at that time her platelet count is around 1 lakh. So what extent of organ neurological involvement is there? If we see the case series of 78 patients with TTP at presentation and after plasmapheresis, then most common abnormality noted is stroke, seizures, and transient focal abnormalities. So our patient has both seizures episode as well as stroke. So our patient has severe neurological involvement in the form of TTP. And on comparative analysis between TTP and HUS, especially a typical HUS, then we can see that neurological symptoms are significantly reported more in TTP as compared to a typical HUS or other thrombotic microangiopathic syndromes. And the other organ that is involved in this patient are renal. As I initially told, that patient with TTP has either minimal or no renal impairment. And this is corroborated with the largest registry as reported in Aeme-Con, where they said that severe AKI is very unlikely in patient who presented with TTP. If there is raised creatinine, then it is likely due to hypotension, cardiac, myocardial infarction, stroke, or sepsis. Per se, TTP does not cause acute kidney injury or severe derangement of renal parameter. And corroborating this, the baseline creatinine around 78 patients who consecutively present with acquired TTP around 1.3, similar to our patient. And on comparative analysis of need for renal replacement therapy between Aeme-Con registry and 92 patients from St. Louis, there is increased percentage of patients who require RRT in this St. Louis group of patients. But these patients are mostly ICU patients who has hypotension episodes, who are superadded infection. So therefore they are more in the need for renal replacement therapy. Last, that organ involvement is cardiac, because if you see the investigation, patient has raised pro-BNP level, her troponin is elevated more than 3 times. So is there any cardiac involvement is also reported in TTP? So if we come to literature, especially from French Thrombotic Microangiopathy Reference Center, there they have analyzed patient of acquired TTP, and around 380 patients they found that 330 patients have survived and 47 patients have died. They have available sera of all these patients, and they have studied the troponin I value among these patients. They made 2 groups. One group has troponin I less than 0.25 microgram per liter, and another group has troponin I more than 0.25 microgram per liter. So they specially noted that patient who has raised troponin I had more chances of ischemic stroke and ischemic heart disease. So similar to our patient who has a troponin is more than 3 times, they have increased chances for stroke and ischemic heart disease. And troponin I is not related with morbidity only, it is reported with mortality also. The patient who has a raised troponin at the time of admission in emergency has more chances for mortality, and the odds ratio is around 2.86, that is significantly high. So what is the terminal event? We come the diagnosis, we are sure that it is a case of TTP, but why the patient has demised? Because we have started on therapeutic plasma exchange, and in the first cycle, patient has deteriorated during the plasma pheresis. So we kept the possibility of obstructive shock in the form of pulmonary thromboembolism, tension pneumothorax, cardiogenic shock, acute coronary syndrome, acute heart failure, or maybe a possibility of internal organ bleed, catheter site bleed, or there is another new infarct or any IC bleed resulting into the raised intracranial tension. So if I see one by one, patient has a possibility of pulmonary thromboembolism. Points favor in PT is acute onset breathlessness and hypotension. Patient has already thrombophilic state. She has a raised cardiac biomarkers. Her Bell score is around 6. And other possibility kept as tension hemothorax because patient has intervention in the form of CVP line and catheter for plasmapheresis. But there is and chest X-ray are not available at that time. So likely possibility we have kept as PT for terminal illness, or other can be there is a possibility of cardiogenic shock in the form of acute coronary syndrome or cardiac arrhythmia because patient has suddenly deteriorated on plasmapheresis. She has already thrombophilic state. She has a raised cardiac engine. So cardiac etiology for his terminal illness or demise cannot be ruled out. So final diagnosis we have kept as thrombotic microangiopathy, and likely it is acquired curie related to antiphospholipid syndrome, and the system involvement is neurological involvement, that is sure because patient has cerebrovascular accident. She has seizures. Renal is mild acute kidney injury, and cardiovascular involvement in the form of either acute coronary syndrome, coronary artery disease, or pulmonary thromboembolism. So this is from my side. If any query or any other possibility someone has on the basis of history and whatever the investigation.
I must congratulate you for the very elusive case presentation. And though the time limit was skipped, but it was very interesting. You took the case right to all the organs, and TMA was lying in the underlying. So congratulations for the nice presentation from my side. Thank you.
So how does it go? It goes like now it is your turn to just prove him right or wrong. Yeah? It goes like this, isn't it? Yeah. So let us hear. So this is for 1 hour session. So please make sure that you do.
Yeah, so I won't take much time because I am the odd man out in this hall. So, but I will show this is a complete autopsy was performed. So complete autopsy means in addition to the organs where the brain is also examined. And the prosectors noted multiple purpuric lesions on both sides of upper arm and forearm. And they also noted that there are no excess fluid in any cavity, like there are no pleural effusion or pericardial effusion or any ascites. So I'll start with the organ of primary interest, that is the brain. So if you see, this is the cross photograph of the brain. So this is the from upper side, so there are the convexities, this is the base of the brain. There is no exudate, we can see here. So this is a circle of Willis, these are the two vertebral arteries, this is a basilar artery here, this is the posterior cerebral arteries, the MCA, ACA, so the branching here. So they are essentially normal. So there is no atherosclerosis or any thrombus occluding these major arteries at the circle of Willis. And this is the right side of the brain, we can see from here. So the supratentorial compartment is fine, but if we see here the cerebellum, there is a depressed area in the right cerebellar convexity. So on the right side of the cerebellum, there is a depression. So this is again a photograph of the brainstem. We can see here, this is the right side of the cerebellum compared to the left side. This area is grossly depressed and atrophic, which could be because of an old infarct. So the same can be seen here on the sectioning. So this is the lower part of the pons, this is the vermis and both sides of the cerebellum. So compared to this left, this right is grossly depressed and shrunken. Now we cut the brain in coronal plane. So this is from the frontal, this is at the level of basal ganglia, at the level of thalamus, then coming to the occipital lobe. So gross, so on coronal slicing, I will show you the close-up. So this is at the level of basal ganglia. So we can see here on both sides, although they grossly appear unremarkable, but on a close look, if we see here, in the left side central white matter, there are multiple small infarcts. They are ranging in size from 3 to 5 millimeter. In addition to that, we can see here, these are the globus pallidus, internal, external, and putamen. In left-sided putamen also, you have some small infarcts. Now, in addition to this deep gray matter and the white matter, if we come to the cortex here, we can see some small pinpoint hemorrhages on the cortex, on bilateral actually. So you can see some in the inferior frontal, superior frontal. On the other side is this inferior frontal gyrus. This is a coronal section at the level of thalamus. We can again see the small, soft, cystic infarcts in this region. In addition, we can, if we look at the cortex, they appear slightly discolored, including this here bilateral hippocampus slightly discolored, and the cortical ribbons are also slightly discolored. So we have gross evidence of some infarcts. So, and let's see what is there on the microscopic examination. So these are the low power photomicrograph scanner view. So these areas are the gray matter, and these pink areas are the white matter. So these are from the relatively preserved area, but if we see here, in the depth of this is a sulcus, these are the two adjacent gyri, and the depth of the sulcus we can see little pale areas. Let's see what are these. Again another photograph. So those pale areas we, in the last photograph we saw on the gray matter, and this is another photograph. We can see this is the gray matter, the cortical ribbons, this is the white matter, and normally white matter should be on microscopy quite pink looking, but here you can see large areas of this pale areas. Closer view of those cortical areas, we can see this area, the gray matter is here. There is complete loss of gray matter. You can see a lot of vascular prominence here. These are the vessels, and there is a cellular infiltrate. Another photograph at the depth of the sulcus in this part of the cortex. It is again showing a cystic kind of area with loss of the brain matter, and there is some reactive gliosis in the adjacent area. And another photograph here in this underlying area, you can see here these vessels are quite prominent. What I was saying in the previous photograph, there is very prominence of this small capillary chain or arteriole type of vessels. Now, if we have a closer look at those pale areas, we can see again there is a lot of cellular infiltrate, which is predominantly composed of histiocytes along with some vascular proliferation. This is a section from the cerebellum on this side. So if we see here, this is the micro photograph from the same area. These are the normal cerebellar folia. Here there is loss of those folia, and this is all replaced by some these pale areas, which on high magnification we can see there's a lot of macrophages. Actually, you can see these are all macrophages along with this small vascular proliferation here, indicating some gliomesodermal reaction, and adjacent areas are showing some gliosis. But to note here, there is no neutrophil, so indicating these are all infarcts which are of quite long duration, which are showing cystic changes, and macrophages are there to remove the dead areas. And we saw that there are both in supra and infratentorial distribution multiple old cystic infarcts of variable size, and they are involving all territorial distribution. They are not in a particular territory. So in anterior cerebral artery, middle cerebral artery, PCA, as well as basilar artery territory. Now, these were the grossly areas which were looking cystic and all. Now, from the other areas of the brain, if we see, this is another section where there is no obvious infarct, but we can see there are some vessels which there is some perivascular hemorrhage, and again we can see these capillaries are very prominent. We should not be seeing the capillaries in a low power like this. Another photograph from different areas of the brain, both gray as well as white matter. You can see this engorged and enlarged capillaries which are filled with this pink material. So on a higher magnification, you can see these are from different areas, gray and white matter, and if you see, these are all basically thrombus. So all the capillaries are containing thrombus and they are distended. Important thing to note here is there is no inflammation around these capillaries, and the endothelial cells appear quite normal. So there is no evidence of any endothelitis or any perivascular inflammation, because this is a young patient. Possibility of underlying lupus could be there, but we can see there is no vasculitis. There is only a presence of thrombi. Again, some vessels showing thrombi. And if we see here, adjacent gray matter, these neurons are quite pycnotic, and there is hypereosinophilia of the cytoplasm indicating marked hypoxic changes. So in this brain, we have, in addition to the old infarcts, where there is acute ischemic or hypoxic changes because of this vascular thrombi. Now, when we look at this, the composition of this thrombi, this is CD61 stain, which is a marker for platelets. So these thrombi are quite rich in platelet, and PT, which is a marker of fibrin, which is should be brown, but this is not showing much positivity. So this is not a fibrin-rich thrombi. Possibly this is a platelet-rich thrombi. So now coming to the other organs, this is the gross photograph of bilateral kidneys, ureters, abdominal aorta, and inferior vena cava, and this is the urinary bladder. The kidneys were normal in size. The capsule could be stripped off. There is no hemorrhages on the cortex, and the cut surface also shows normal corticomedullary junction. The bladder was showing congested mucosa, and this is the micro photograph from the urinary bladder. This is the normal lining epithelium, but you can see this thrombi in the submucosal vessels. Now, kidney showed a lot of findings, so this is a low power photograph. We can see this is the cortex and this is the medulla, and they appear quite busy. So these are the glomeruli, these are the tubules, and these are the arteries. So on a close view, we can see this is an arteriole. These are the capillaries within the glomeruli. They are all occluded and they are distended with this thrombi. So a panel of photograph we can see here. This is a relatively unaffected glomeruli. There is no excess of cells, no endocapillary proliferation. The basement membrane are okay, so there is no underlying glomerulonephritis here. But the capillaries within the glomeruli, as well as this afferent and efferent arterioles, they are all occluded by this thrombi. Another photograph to show you the same. This is a photo showing this afferent arteriole, which is hugely distended and occluded by this thrombus. Similarly here, all these. There is mild evidence of interstitial nephritis with presence of lymphocytes and presence of plasma cells. And if we look at the tubules here, there is almost complete loss of nuclei in these tubular epithelial cells with shading of this tubular epithelial cells. So these are indicating acute tubular injury. And they were, again, these thrombi were all platelet rich, and so these are the smaller arteries and arteries which are platelet rich thrombi. However, the larger vessels did not show any CD61 positivity, so this is immunofluorescence technique. They were also focally positive for fibrin, like some of these thrombi are positive for fibrin. However, the glomerular thrombi, they were not lighting up for fibrin. So this again indicates that this thrombi in all the organs were platelet rich and not fibrin rich. In addition, if we see these tubules, they contain this kind of reddish granular cast, which is nothing but hemoglobin, so which indicates that there is hemoglobinuria going on in this patient. Next, coming to heart, so this was a gross photograph of heart, which weighed 360 gram. This is it is opened by modified inflow-outflow technique. This is left inflow track, left outflow track, right outflow track. There was the chambers and the valves are essentially normal, so there was no thrombi or any vegetation within the heart. This is the scanner view, which is showing part of left atrium and left ventricle, and this is the mitral valve. A low part photomicrograph from the heart again shows quite prominence of these vessels. We can see these multiple photographs that these variable size vessels within the myocardium. So intramyocardial vessels, they all showed this presence of thrombi. They are all distended and contain this fibrin, this thrombi, and you can see again these arterioles. These are muscular arterioles, and they all contain this thrombi. And if we look at the underlying myocardium, we can see there is loss of striations and there is fibrillation, and these myofibrils are kind of disrupted. Otherwise, you can see them as a nice, thick, continuous layer of cardiac myocytes, indicating that there is damage to the cardiac myocyte by ischemic injury. Again, here we can see this CD61 is highlighting this thrombi as platelet-rich thrombi, which is again depicted here. We also dissected the coronaries, but there were no evidence of any thrombus in either of the coronaries, and again CD61 on immunofluorescence, highlighting them. Coming to the other organs, this is the gross photo of esophagus and stomach, small and large intestine. We can see here and few mucosal hemorrhages in the stomach. Esophagus was otherwise unremarkable. Small and large intestine mucosa were essentially unremarkable except for some congestion here. There was mild submucosal inflammation in the esophageal mucosa. However, this is the gross microscopic photograph of stomach in scanner view. We can see here these are the lamina propria and these are the arterioles and capillaries here, which are again showing this kind of thrombi, closer magnification to show the presence of this thrombi here. Gross photograph showing this organ complex. This is the slice of liver, gallbladder, sea loop of duodenum, pancreas, and part of spleen. Spleen was little soft. The liver, the capsular or cut surface did not reveal any focal pathology. There was no nodularity or any infarct. This is the portal vein and superior the splenic vein. So they were essentially normal. So there was no thrombi in these. Microscopic photograph from liver shows maintained lobular architecture. There was no excess of fibrosis. The portal tracts, the central vein, they were all essentially normal. There was no fibrosis involving this. Reticulin stain also highlighted maintained reticulin framework. This is indicating that there is no acute hepatocytic loss. However, there is evidence of this steatosis, which was kind of azonal. Another close photograph, we can see this macrovesicular steatosis, and this sinusoids here we can see are slightly busy. So within the hepatic sinusoids, we can see there are presence of this nucleated RBCs and some myeloid precursors. So we can see this is myeloperoxide immunohistochemistry, which will stain the myeloid precursor cells. So there is evidence of extramedullary hematopoiesis. Lungs together with 715 grams. This is the tracheobronchial tree, bilateral lungs. The pleura was essentially normal looking and they were shiny except a few fibrinous tags here on the right side. There was no aspirated material in the major bronchus. There was no thrombi in the major pulmonary arteries. These are the branches of the pulmonary arteries at the hilum. A closer look in the right lower lobe, we can see this, the lungs were otherwise subcrepitant to fill. And the lower lobe you can see here compared to this side, it is quite dark, and it felt quite solid and consolidated, and indicating, and this is a brownish discoloration. So section from this brownish area showed that there's evidence of fresh hemorrhage. It's quite extensive here. You can see all the alveolar spaces are filled with this fresh blood, so there's evidence of fresh alveolar hemorrhage. And in other areas, the alveolar spaces were relatively unremarkable, except for there is presence of this pink material within the alveolar spaces, indicating that there is pulmonary edema. Another thing that we can see, this is one bronchiole, this is a respiratory lining epithelium, this is a terminal bronchiole. We can see these are all filled with nucleated cells. These are essentially neutrophils, which are, and the inflammation is spilling into adjacent alveolar spaces. So a closer view, we can see these are all neutrophils, and this is all going into the adjacent alveolar spaces, indicating that there is pneumonia, which is patient is acquired terminally. Gram stain showed the presence of some gram-positive cocci. In addition, there are presence of this fungal spores and hyphae. This is PA stain. We can see this fungal spores and this pseudo hyphae. So this is where there are evidence of candidal infection within this case, as in the bronchioles as well as in the alveolar spaces. So this indicate that there could be terminal aspiration also in this patient. Now coming to the endocrine organs, this is adrenal. We can see this presence of hemorrhage in the adrenal cortex, and this capillaries within the adrenal cortex as well as in the medulla, they are all again distended and occluded by this thrombi. This is again showing the same. This is CD51 showing the platelet-rich thrombi in the adrenals. Similar thrombi were also seen in pituitary. This is the pancreas. We can see this pancreatic acini. These are the islets, and these are the thrombi within the capillaries of the pancreas. And even the thyroid was also involved. So you can see this is thyroid follicles, and we can see this thrombi within the capillaries. The bilateral ovaries showed presence of hemorrhagic corpus luteum. Uterus and cervix were essentially normal. So this corpus luteum is confirmed on microscopic examination. Bone marrow was cellular for age, and we can see trilineage hematopoiesis. There was no immature forms. There's no excess of or depletion of any particular cell line. You also try to look for presence of any underlying myeloid neoplasia or any other hematological abnormality, but no, we can see these are the megakaryocytes, which are normal in size and shape, because some of the myeloproliferative disorders can be associated with this increased risk of thrombosis, but there was no such evidence. So in this female, based on this platelet-rich thrombi and not fibrin-rich, these are quite features are very much suggestive of a thrombotic thrombocytopenic purpura, which involved multiple organs and which predominantly presented with as CNS manifestation, but also predominant with common involvement of kidney as well as heart, and pulmonary edema and bronchopneumonia, which can be terminal and may be related to aspiration in this case. There was fatty liver and acute tubular injury in kidney. Thank you. Now this entire case is open for any further comments and questions.
So, thank you so much. Isn't it a taste a little much different for what we do always, isn't it? So it tastes so much different, but I'm look forward to comments and all.
I would like to know if, like, say, a patient died of, like, say, tension pneumothorax, and so what will be the findings?
Sir, tension pneumothorax, as per the prosector's note, there was no fluid or any excess air in the chest, because when they cut the thoracic cavity, if there is excess air,
it will come out as
it will come out, yes.
And pressure?
Yes, and the lungs will be quite collapsed, where it is not like this.
Okay.
So it is unlikely.
I don't think you'll will be able to make a diagnosis, histopathological diagnosis of tension pneumothorax.
No, sir, not at all.
That's,
This is not histological diagnosis.
No, that's a functional diagnosis. So it cannot happen. In fact, rather than the lungs being expanded, they will all be absolutely collapsed because of the tension of the air. So I don't think pathologists can make a diagnosis of tension pneumothorax.
No, sir, pneumothorax can be diagnosed during autopsy. There are techniques to
No, he's
detect.
specifically asking about tension pneumothorax, whether that's the cause, because patient also has been in the ICU, has been on the ventilator. So there's a possibility of an iatrogenic cause towards formation of a tension pneumothorax.
Right.
So that was,
I
know that
I
was
can't
his concern.
dogmatically exclude it. Yes,
No,
I can't.
He can't do that. That's, he needs histological evidence. Yes. True. But it was really interesting because I felt I went through the whole pathology lecture all over again. So in that way, it was actually in many ways continuing medical education. So.
Thank you so much.
Thank you.
Thank you. So now, it's my pleasure to take you to an EM debate, which we'll be doing virtual. And this year, it has been done by Nizam Institute of Medical Sciences, my institute, and my two very favorite students. Now they are the senior residents in my department, Dr. Sharath and Dr. Arvind Ranjan. They will be taking us. The topic is which one to prefer, mannitol or hypertonic saline as an osmotic diuretic. The topic would be open for discussion after we hear from them. Let them fight it out first. So can we connect, please?
it got worse because she tried to jump out of window after a quarrel with the mother. So this was clearly a relapse of her schizophrenia because we have the background history, we have the poor adherence to medications, and the relapse symptoms were there. But again, we just don't just assume that this is a relapse of schizophrenia. So we need to quickly review the notes, look through the person's physical state. A very good examination is always essential. Physical examination. We don't assume that every person who comes to hospital, especially to a psychiatric hospital, is presenting with a psychotic illness or a mental illness. So a good examination is very, very important. And then try to de-escalate as much as possible. But then it's usually best done in a place where she is familiar with, so we have like an assignment of zones in Singapore. We have 4 different zones, and so the person will go to the ward that is familiar to her, and the team is also familiar to her. So at least there is some rapport there, there is some understanding there, and so they know the patterns of these patients, and then they will say, oh, this person, okay, we know how to manage her. So they take her into their charge, and that helps the person. So before we jump into giving any medications or we try to use restraints and other forms of containing a person, I think we have to just establish that the person is kept in a safe place, and what we need to do for them is very, very important. And again, tranquilization, rapid tranquilization is only used if it is really, really absolutely necessary. We would start her medications, but depending on whether she has been compliant, and we know that there is non-compliance, non-adherence to medications, we would go with slow and low doses. Again, psychoeducation to family, because you would have like an anxious mother and maybe other siblings who have come along and they are really quite worried about the mother's safety. So I think a quick explanation and psychoeducation. So communication becomes key here. Our assessment is by talking, our de-escalation is by talking, and education is done by talking also. A reliance on lab tests and other things is only to rule out a possible physical cause which could be leading the person to having a problem like this. Which brings me to the next person, who was a 64-year-old man. Again, this gentleman had a history of schizoaffective disorder, and interestingly, he also had a history of polysubstance use in the past. But the family was very sure he was not taking any drugs or alcohol in the recent weeks or months, because he was mostly at home. But he was brought to the hospital looking quite dazed and disoriented, and we were not able to get much history from him. He had a fever, running a temperature of 39.2. His throat was injected, and he had bilateral crepitations. And I have to tell you, in the Institute of Mental Health, our labs function only during office hours. So we have to send persons out if they come after office hours. So if you're in a setting where you have all the labs and other settings available, you can quickly run the basic bloods. You can do a urine drug screen. You can do the UFIN, the urine for the general examination. And then a very, very good physical examination is important in this. And this person had to be sent for medical help because of his fever. And it turned out that he had a delirium from pneumonia as well as from UTI. In fact, he was not in a relapse of his schizophrenia. So the combativeness and other restlessness which we noted in him was from the delirium itself. So I think that's important. What I'm trying to emphasize is physical examination, and if necessary, running through like the basic investigations will be really, really very important. So some of the factors which may be the cause of aggression or agitation, be it a psychotic illness or any other form of mental illness, will be like there is the fear, the unknown fear of the unknown, and the mistrust towards people. The barriers may be because of language and communication, because I'm talking about a mixed population here, and there may be people who do not understand what we are talking to them. The physical health conditions may be causing a lot of distress for them, just example, for example, pain itself, constipation. We have seen that happening in patients with intellectual disabilities. They have constipation, so they have like this discomfort around the tummy, and they can't really express that. And they may present with restlessness also. and so that needs to be ruled out. If there is a history of fighting in the past, if there is a history of aggression in the past, and definitely if there is history of drug or alcohol use, because usually when they come in an inebriated or intoxicated state, they can be quite disturbed and restless also. Again, not in a psychotic state, but they can be disturbed. And there may be other factors which can contribute or worsen aggression, which like they have this habit of being controlling over others. They want attention, they want respect, they feel like others don't respect them, neglect in childhood, and if they had grown up witnessing violence at home, then being bullied, and then it may be a way of retaliation. Easy access to weapons, fortunately, not much in Singapore, but they have access to knives and choppers here, so that should be worrying. History of mental illness definitely has to be taken into consideration, though fortunately evidence shows that not all mental illness, especially schizophrenia and other psychotic illnesses, are not always a harbinger of aggression or agitated behavior. Okay, so how do we recognize these? How, like, as a quick look at these patients. So sometimes when we are sitting in the consultation room, we hear a lot of shouting. Somebody is like very disturbed. Somebody is very restless, and we would know that there is something going on there. And we go out to see. You see a very angry, irritable person challenging the staff, telling them not to tell them what to do, and there can be like usually the aggression is verbal, but sometimes it can get physical. Like we have had people who go and punch a staff, punch the security officer, and make threats and say that if you don't stop doing this, I will do this, and they go and bang the doors. And we have glass doors, and one person recently broke the glass door to the emergency. So replacing that is going to be another big issue in the hospital. And there may be like the physical violence which we talked about already. So the approach and the principles of management will be like to be using a stepwise approach. So you have to always think of how to make it safe and effective, and in the least distressing way to the person. So if there'll be the assessment by the initial, it may be the resident or whoever is seeing the person for the first time. Try and see if you can get an early assessment by a psychiatrist on call or a psych on call, the resident on call. Then a quick clinical assessment, physical assessment. Use pharmacological interventions. I'm not saying don't use them. Use them only when it is really absolutely essential. Manage agitation doesn't mean you have to always jump on the person, tie them to the bed. You can actually talk to them, and you can actually try to bring on good qualities. Like the other day I saw one of our nurses going and talking to a person who was very angry, saying, I know you're a very reasonable person, I know you're a very responsible person, and I'm sure you won't do this. So the person actually calmed down, backed out, and then he quietly went and sat in the chair. Again, all determining where to send the person, whether you're going to admit them to the hospital or whether you're going to send them home. But if you're going to send them home, whether it is safe to send them home alone, or do we have to find an accompanying person to go home with? So in the event of an aggression, what you need to do is like first evaluate the cause of distress. So like I said, it can be pain, it can be fear, sometimes it's just hunger. The person has not eaten for the whole day. They had been brought in by the police because they were creating a commotion in a shopping mall, and they had been brought in. It has been like at least 5 to 6 hours, and it's a basic human need, right? The person has not had any water, has not had any food to eat. Sometimes we tell them, okay, do you want some food to eat? Do you want to sit by the corner, have like a cup of coffee or something? And then we can talk after that. And then you can actually see the look of gratitude on their faces. Try to decrease the waiting time for such people. Try to jump queue if really required. Try to distract them. Like sometimes we get our community staff or mental health helpline staff to come and talk to people. Remove potentially dangerous items. So in the hospital, we are not going to have things like knives, but we have other potential weapons like computers, wires, and things like that. So there was a person who actually threw a computer tried to throw a computer at a doctor, and doctor dodged and did not get seriously injured, they can yank off the wires and they can use it as a weapon or, a strangulation material on themselves. Then you try to calm them down by talking to them. But again, don't be confrontational. Try to be try to go along with the person. Do it as a, what we call as mirroring. You say, I am angry. So I say, oh, it looks like you are very angry. So you go with that tone. You don't raise your voice. You stay calm. You maybe use some relaxation technique. Do you want to breathe along with me? I feel like breathing now. So shall we take 2 deep breaths together? Maybe try to get one person to sit along with them. In a manpower situation, I think it will be quite a challenge. If there is a seclusion room or a quiet room, try to put them there and manage crowds, because you don't want like people coming and hovering over them and looking at what is happening, and that can be quite daunting for a person, and they'll feel more challenged and they'll feel more scared about it. So try to keep the crowd as limited as possible. But in a small emergency setting, if you have limited space, people will definitely come and they want to see what's happening because they are curious to know. And so you try to ward off as much as possible. Try to keep it in as dignified as limited number of people as possible. Because I think once you give them some respect, once you try talking to them, talking and de-escalating to them, usually you can get things done without having to use force on them, like using a restraint or rapid tranquilization. So it's better to prevent an aggression than to manage an aggression after it happens, reduce the distress, and so this is what we have already talked about. So the medications we use in our setting will be the oral and intramuscular only. We don't use the IV medications. The oral medications we use are lorazepam, which is pretty fast acting. We have the olanzapine, the orodispersible version, which is very easily dissolvable in the mouth. You put it in the mouth, it dissolves in the saliva. Promethazine, not as fast acting, but it is also quite calming. Then for intramuscular, we have lorazepam up to 4 milligram, but usually we stop at about 2 milligram because of possibilities of respiratory depression and having limited resources in the hospital to manage that. Haloperidol, we are using the intramuscular version, which comes in a 5 milligram vial. And we use, depending on the age and body weight and the extent of distress the person is in. So it can range from 2.5 to 5 or 10 milligrams. Promethazine, again, we use for children or elderly when we do not know whether there is a psychotic illness. We use promethazine. We use probably the doses of 12.5 for very young people or elderly who may be on other medication. We now have olanzapine injection, which again comes in a 10 milligram vial. And this has shown good results also in the emergency as well as in our psychiatric ICU. We have a psychiatric ICU and it has shown very good results there. Ziprasidone is now coming in injection form. We are yet to get it in Singapore. So these are the common medications which we use here in our hospital setting. If you happen to be in a hospital setting where you can get immediate medical help also, I think IV use is quite fast and effective. So I think you can use either IV lorazepam or haloperidol. I think IV diazepam is not really advocated for non-delirium or non-epileptic situations. I think it's preferable to use lorazepam, the short-acting one. And if you have a person who is drug-naive, totally drug-naive, never been on any antipsychotics, prefer to use the benzodiazepines, the short-acting benzodiazepines. If you have a cooperative person, you try to use the oral, or if you have limited cooperation, you try to use the IM format. When do you decide to transfer or refer a person to a psychiatric services when the violence is really bad or when there is a known history, when you cannot really get immediate help, you don't have adequate security help, or you don't have staff who are well trained in managing such patients, when there may be risk to vulnerable patients, the weaker people like children or elderly, and there is a history of abuse. I mean, the caregiver is not able to really like contain the person. Yeah, so in all, it will be the safety of others is compromised. And so the resources of help will be like, even if they can be managed in the community if possible, like if you have like case workers in the community, social workers, case managers, counselors who know the person well, being familiar with the person really, really helps. If all that doesn't work, bring them to a safe place, keep them in a safe place, and then bring them to the hospital or to the emergency, like in this case. Then invoke the help of doctors, nurses, because some of the nurses are really, really, like they are very familiar with the patients and they can tell you what to do with these patients or a similar patient. Bring in the security and the police as and when necessary. Yeah, so I think this probably is like my last slide. These are my references. And so why I put this is because this is a novelist, Louisa May Alcott. I think we are all like managing storms, and we have been learning to sail our ships, like, gaining knowledge, gaining our experience. And I think in the last 2 days, I think I've gained a lot of knowledge, lot of information. And so I think we continue to manage storms and continue to sail our ships as best as we can. And yeah, so sanity is not outside of us. It is actually part of us, just like our shadow. So I think look for sanity within ourselves. That is really most helpful. That's my last slide. Any questions from the audience?
That was a very nice presentation, Nigila, and your classmate who is sitting next to me has passed the phone, the microphone to me. My name is Suresh David. I'm an emergency physician.
Hello, Dr. David. Yeah.
Hi, I'm quite familiar with the SGH, the Singapore General Hospital, and I don't know whether you know my friend Anantharaman, who's there. Professor Anantharaman, who was the head of the Department of Emergency Medicine at SGH. I have come there a couple of times to talk to the students also as a visiting professor. I have a couple of questions for you.
Sure.
I'll set the ball rolling, and I'm sure most of the delegates would be burning to ask you questions. First question is, I know you very smartly avoided the ethnicity of the patients that you talked about. What I wanted to ask you is there any predilection for the three major ethnic groups that we have in Singapore? Is there a predilection for acute psychoaffective disorders in them?
No.
No, not at all.
No, because schizophrenia is like, it's like very, very fair. It's very equal in its distribution. Okay. Both genders equally distributed. So there is no differences in the way they present. But I would say substance use induced conditions, maybe like, there may be some racial differences.
Yes,
in
exactly. Because
yeah.
the social environment is different for all three. The Malays are different to the Indians, who are different to the Chinese, as far as their home and their domestic milieu is concerned. Yeah. So therefore, disease conditions which are precipitated by environment, both social and mental, so to speak, or professional for that matter, have you noticed in your experience any predilection for ethnicity?
I would say for substance use, alcohol use disorder seems to be slightly more prevalent in the Indian population.
Yes, among the tablets.
And the other drug use, like, illicit drug use, slightly more in the Malay population.
Malay.
We do have it in all races for all practical purposes, but I think I would say a little bit higher prevalence in these two groups. We have seen that. Yeah, gambling addiction may be slightly more in the Chinese population.
Yes.
Yes.
I'm familiar with the EMS system in Australia, but I don't know about how it is in Singapore. When we have an agitated patient, usually the EMS group do not pick them up because there is a risk of violence which happens within the cabin while the patient is being transported, and usually it's the police who bring in the agitated patients in Australia. I'm not sure how it is in Singapore. Who brings in the agitated patient?
not necessarily always the police, though police is activated by most families, and in the three scenarios I presented, I think at least 2 of them the police were involved because they had used weapons or they had gone to the extreme, like one of them tried to jump. But very often what happens is by the time the police reach home, they come very fast, I would say. By the time the police goes, or when the person knows that the police is coming, they quieten down and they sit quietly on the sofa. So the police may just go and advise them and then advise the family to take action accordingly. But what happens is there are ambulances which bring patients. They don't really require police escort. They will bring the persons by ambulance to the hospital. So what the family will do is they'll call the ambulance. They'll somehow get the ambulance staff to bring the patient. They'll give the information to the ambulance staff. The family will come later, or they will just leave their phone number to be contacted. Because if they come along, the patient gets very angry with them, and that can lead to another bout of aggression and shouting.
Yes, it's good to take them away from the patient. The EMS staff, do they use verbal restraint or chemical restraint, pharmaceutical restraint or pharmacological restraint, or do they use physical restraint to bring in an agitated patient?
They usually use only verbal and physical. They don't use pharmacological because pharmacological is only allowed in hospitals or when it is like a community staff who have been authorized to use. So they must have prescribing rights, and they don't have prescribing rights. They have like dispensing rights.
Even with online consultation, they do not have the right to administer any drugs, especially
they cannot
psychoactive
administer
drugs.
drugs.
No,
They can only bring the person to the hospital. So they will call us for advice in the emergency, and they'll say, I'm seeing this person and I'm having this difficulty. I'm activating police. I'm going to bring this person to the hospital. Is that okay? So those of us who are on duty at the emergency will approve it. So we will have access to the notes by then.
Right.
And then we will have, no, pharmacological is not given in the community as much as possible. Yeah.
One last question I have for you.
Sure, sure.
All the 3 patients that you talked about were basically patients with major affective disorders. I want to know what's the prevalence of BPD, borderline personality disorder, which requires patients to be brought in, because that was a major problem that we had in Australia and also in the UK. Because I have worked as a consultant in both these places. We have had BPD as a major problem, and one of the commonest reasons why ambulances were being called and brought in will be some borderline personality patient who, it's amazing how manipulative they can be. We used to have a patient when I was a trainee like you guys. Her name was Veronica, and that was her 4th name, by the way. She had changed her name 4 times officially. So, and she was everything. She was a juvenile diabetic, she was a polydrug user, and she had borderline personality disorder, and she was on multiple illicit drug use. And usually the call that on the radio would be, Doc, Veronica is back. I said, okay, bring her in. So, I mean, as you mentioned, most of these patients are known to both the psychiatric team as well as to the emergency team. So what I wanted to ask you is, do you have borderline personality disorder as a major issue in Singapore?
Yeah, they do. I deliberately did not bring it in. Personality disorders can present with psychotic episodes. You know, they have what is known as the micropsychotic episodes. They can present with very significant affective features, meaning the manic features or depressive features. So they come in like, you know, labile mood, crying, or they'll be like, you know, over-familiar and talking to you. They do come, but it's not always in a very psychotic presentation. Usually they come in crisis.
Yes.
The crisis can be because of some kind of disappointment, some kind of difficulty they are facing in the community. So it can be relational. Usually it's the interpersonal relationships. And they come in either after having self-harmed. So they will come with like long cuts on their arms and, you know, like bleeding and refusing for you to like examine them. Or they would have had these thoughts, wanted to jump, but they would have called somebody. What they do is they usually try to ask for help.
Yes, and they call
And
the ambulance.
They come to,
sometimes they call the ambulance and tell them, Veronica used to do that. I've taken 10 tablets of paracetamol, come and get me.
Yeah, it's very classic. Very
you know,
classic, very, very common. They do that. And they come to the hospital, they'll refuse to be like examined for like the drug overdose. And then you have to convince them. And what they expect is for you to give them that attention, that extra attention, that extra TLC you have to do. And you have to convince them to like, be treated for the overdose or at least be examined for that. And then once that is done, usually by then the crisis is averted and they would be calm. And if they see somebody familiar, they're really very happy. And
not necessarily, because she used to refer to me by one particular name, which is Black and another B, which goes with it. I don't want to say it in this modest group that is here. So, not you again, you Black. Complete the sentence. So yes, it's me. So
yeah.
that's, but sometimes they have very unfortunate ends. And I'm talking about Veronica. I'll never forget her because I also had to certify her dead. She was found in her house. She had been dead for 3 days. So the smell actually aroused the neighbors to call the police, who came and broke in and found that she had been dead for 3 days, and I had to certify her. So they do have sad lives and sad ends.
Accidental self-harm is very, very common in them. And intentional can sometimes go really very wrong, and that can lead to death in them. Yeah.
Thank you very much, Nikhila. Very glad to see you. I thought you
Thank
will
you.
be coming here and I could meet you in person.
I wanted to, but because of leave, I could not make it. I'm actually looking at it now, thinking I'm missing all the activities and all the fun there. But I'm glad that I could be part of it. Thank you.
Thank you, ma'am.
Thank you.
There is no doubt it was such an informative and interactive lecture. Thank you so much.
Thank you. Thank you so much. Thank you.
Yeah, please stay with us.
Sure. Thank you.
Yeah. So we welcome Dr. Chirag now. Sir is on NMC duty, but still he's been being with us. So Dr. Chirag, kindly please.
Good afternoon. My topic is acute gastrointestinal bleed. Myself, Dr. ligation can give you the better result. When there is a source by the CT angiography is a fundal varices, it is generally venous source. They are managed by the variceal ligation or glue. Second is able to diagnose the underlying pathology that may be the cause of bleeding to direct the future management. CT angiography can diagnose the bleeding from the jejunum, and the CT findings of the tissue can give you the impression this is might be the because of diverticular disease. So jejunal diverticulosis, you can find by the angiography the source of culprit vessels, but the tissue pathology can be also, you can know by the CT angiography. You can diagnose the cause of bleeding not within the GI tract. If there is a common bile duct pathology, give rise to the hemobilia, that can also diagnose by this investigation. It delineates the vascular anatomy prior to embolization. It has a less sensitivity relative to radionuclide scanning. CT angiography can detect around 30 to 40 ml of blood loss per hour, and radionuclide scanning can detect around 10 ml per hour blood loss too. So in Macus diverticulum, very less amount of blood leaking, the radionuclide scanning is used. CT required the high radiation dose. It needs IV contrast. And here I have mentioned previously, if the patient bleeding is stopped, you cannot get the result by CT angiography. This is a plain film of the CT angiography of abdomen. You can see there is no dye in any vessels, but there is because of blood in GI tract, it gives you the hyper intense image. So this is a fresh blood in GI tract, suggested by this non-contrast film. Here on the left-hand side, there is a aorta is with the dye, and you can see there is a leak in the stomach. This is arterial phase, means it is suggested by the blue arrow. Venous phase is mentioned in a yellow arrow in a same patient. And digital subtraction angiography by white arrow seeing the tributaries leaking in a same patient. Another arterial phase study of the CT angiography of abdomen showing the collected blood in the GI tract by the yellow arrow, and there is a fresh bleeding by the blue arrow. Same patient, digital subtraction angiography, you can see the loss of dye in tributaries, leaking tributaries, can be managed by the CT angiography intervention. By the digital subtraction angiography intervention. Risk stratification done in the emergency department. High-risk patients are the patient with the advanced age, with the comorbidity, having a prior history of endoscopy or TIPS procedure, history suggestive of red hematemesis, hematochezia or melena, positive nasogastric aspirate, hemodynamically unstable patient, and having abnormal laboratory studies. Initial management is stabilization, and in selected cases, early airway management. Even intubation is needed. Blood transfusion, if there is a hemoglobin levels is equal to or less than 7 gram per deciliter. In older age patient and patient with comorbidity, even transfusion needed when the blood hemoglobin level is 9 gram or less than 9 grams. Correct the coagulopathy. In a peptic ulcer bleeding patient, omeprazole or pantoprazole use. In a variceal bleeding patient, octreotide is used. Nowadays, the newer spleno vasoconstrictor drugs, talipressine is used. Antibiotics are preferred in a cirrhotic patient because of they have an altered immune system. Ciprofloxacin and ceftriaxone is used. Endoscopy is generally used. Most of the cases managed by the upper GI endoscopy, visualization of the source of bleeding, and administration of the hemostatic therapy. In variceal bleeding, the variceal ligation and sclerotherapy is used by the endoscopy. In a peptic ulcer using patient, the clips, thermocoagulation, and sclerosing agent along with the injection of the epinephrines are commonly used. Effective short-term solution for life-threatening variceal bleeding is balloon tamponade. It reserved for the temporary stabilization of patients for transfer to an appropriate institution or until endoscopy can be done. Patients who don't respond to pharmacological treatment or endoscopic treatment may require emergent surgery. So emergent surgery for the variceal bleeding, you require the shunt operation, that is a transjugular intrahepatic portosystemic shunt procedure tips, and some non-shunt operation like a esophageal transection or gastroesophageal junction devascularization can be done in emergent surgery. In non-variceal bleeding, generally the percutaneous embolization or even subtotal or total gastrectomy is done. We'll discuss about the lower gastrointestinal bleeding. Loss of blood from the GI tract distal to the ligament of Treitz. So bleeding from the colon, rectum or the small bowel. Lower GI source bleeding is more common than upper GI source bleeding, but has lower mortality. Reason 80 to 90% of the lower GI source bleeding may resolve spontaneously. Most commonly present as a hematochezia. You can also see the melena if there is a malignancy in ascending colon or some trickling from the ascending colon. Most common causes are diverticulosis. Diverticulosis is basically painless condition where there is a penetrations and the erosion of the artery which is at the bottom of the diverticulum. Vascular ectasia, that is a arteriovenous malformation or angiodysplasia. These both entities, part of vascular ectasia, is very common in a lower GI source bleeding. Ischemic colitis is one cause. Also the mesenteric ischemia present as a gangrenous bowel loops. Meckel's diverticulum, hemorrhoids, ulcerative colitis, lots of other causes like rectal polyps, rectal ulcer, trauma, maybe the vaginal bleeding can be present like a lower GI source bleeding. Diagnosis by the history, patient present as a hematochezia, bright red rectal bleedings or maroon color rectal bleeding, melena, dark or black color stool. In physical examination, patients of diverticulosis having a soft abdomen, painless, non-tender. When there is a, along with the mesenteric vascular ischemia, you will find the tenderness guarding. You will find the tachycardia, hypotensions in the patients of the significantly lower GI source bleeding. You have to see for the vaginal examination for the vaginal source of bleeding or the urinary tract blood leakage can, because the orifice is nearby, so it can present like a lower GI source bleeding. In laboratory testing, the blood urea creatinine ratio is generally 10 within a normal limits, around 10 to 20. Colonoscopy is an investigation of choice. It can diagnose the source of lower GI tract bleeding. When the patient is not prepared, that time the CT angiography of abdomen and pelvis, red blood cell radionuclide scanning, otherwise a digital substantial angiography with intervention can be done. Treatment, resuscitate unstable and actively bleeding patients. General guidelines for initiation of blood transfusion. Consider the placement of nasogastric tube if lower GI bleeding is significant. There are lots of upper GI source bleeding can be present as severe hematochezia. So putting the nasogastric tube in, if you find out the source of bleeding there, so you can manage the upper GI. This is the because of upper GI source reason. So endoscopy treatment of the upper GI tract can manage this source of bleeding. Surgical consultation along with gastroenterologist for lower GI tract bleeding. Colonoscopic hemostasis methods are used. Angiography guided therapeutic options can be used or emergency surgery. Thank you for your attention.
Thank you, Dr. Chirag. And once again, sorry, it was going slow, steady, but we were able to finish many lectures today. And this is one of the condition where sometimes we are, we are challenged in our, with our blood bank giving us the required amount of transfusion, blood, or the acute need of intervention radiologist, which may help us in much better way. So I have one question, sir, that
Yes.
which are the cases where you feel it is better to call an IR specialist, intervention radiologist, rather than calling a surgeon?
Generally, first of all, in our setup, the patients having a post-operative leak from the anastomosis, the leak are minimal leaks are there. Where generally these are when the leaks are not from the peptic ulcer disease or erosive gastritis. These are the patient not in succumbing. They have maintained their vitals. So generally in a post-operative patients leaks and the less leaking patient, generally Macus diverticulum, these are the patients which generally goes to the super specialty sites, but after the gastroenterosurgeon or from the general surgery. The patients which are hemodynamically unstable, these are the patients if goes straightway to the endoscopist and they are fail, then it is a multi-speciality approach along with the interventional radiologist for the patient which are not managed by the gastroenterologist.
So thank you so much. So do the students have any query, question, comment of our faculties? No? Thank you, Dr. Chirag. Thank you once again. And we move to our next. Yeah, thank you. See you soon.
Okay.
Yeah.
And congratulations for this wonderful conference, madam.
Thank you, Dr. Chirag.
You are a real backbone, you and Einstein sir, and we have a great legend there, David sir. I have seen the wonderful faculties. I have with the online, with the YouTube, the Dr. Chandni, Dav, Geeta, Harsha, Kalpana. I think seen lots of faces, and it is. They all are there. Suchita, I think Brinda was there, but
Yes.
few faculty. The CPC was excellent.
Ah, yes, yes.
So it is really the hybrid because of assessment. As an assessor and being an assessment at my institute, I couldn't attend, but lovely conference. Thank you, ma'am.
So that is why I'm saying that see you soon.
Bye.
Yeah, okay. So we invite our next speaker. Sir is there, Dr. Ashok Panu, sir, kindly.
Good evening, everyone, and thank you, ma'am. My topic will be the crashing toxicology patient, which is a common clinical scenario in our setup. So patients with acute poisoning are the sickest in the first few hours. So it is the responsibility of ED physicians to make the quick diagnosis and to initiate the immediate management of the crashing toxicology patients. So the core of the management will remain the immediate resuscitation and stabilization targeting ABC of such patients who are having severe or multi-organ dysfunction. So any organ failure can occur in patients with acute poisoning. Our main priority is to stabilize the vital organs like heart, brain, and respiratory system. So there are varied toxicological presentation of acute poisoning. There are varied toxidromes. Like patient with neurotoxicity usually present with seizure or altered sensorium. Patients with cardiotoxicity usually have shock or arrhythmia at the time of presentation, and patient with respiratory failure have dyspnea, cyanosis, or desaturation at presentation. So before going to the organ involvement one by one, we should need to know the spectrum of acute poisoning in India. These are the 5 major categories of acute poisoning, and pesticide will remain the commonest cause of acute poisoning in India. And among the pesticide, insecticide and fumigant are the 2 category which account for the more than half of the cases. and among them also OPC and aluminum phosphides topped the list. However, in the recent years, drug overdose and herbicide like paraquat poisoning are also emerging as a real threat to our emergencies. So, coming to the circulatory shock, the various etiopathogenesis of circulatory shock in patients with acute poisoning remains the toxic-induced cardiotoxicity, vasodilation or hypovolemia. The commonest agent encountered for toxin-induced cardiotoxicity in our setup is aluminum phosphide poisoning. Calcium channel blocker and beta blocker toxicity is mainly through the cardiotoxicity and circulatory shock. Even organophosphate poisoning can cause circulatory shock at the time of admission. Calcium channel blocker toxicity may have vasodilation, which can also contribute to the circulatory shock. In case of many pesticide ingestion, there may be significant amount of vomiting or diarrhea that can also lead to hypovolemia, which can also contribute to the circulatory shock in these patients. So this is the simplified management protocol for aluminum phosphide toxicity at our center. After the initial stabilization of the patient, gastric lavage is done if the patient is presenting in the first few hours, especially in the first 2 hours of the ingestion, and first few hours will be intensive monitoring and basic investigations will be done, and after the clinical and laboratory assessment, there will be organ-directed approach to these patients. So, coming to the vasopressor therapy in circulatory shock, it is important to maintain mean arterial pressure above 65 mm of Hg. Vasopressor therapy is required in these patients. Norepinephrine will remain the preferred vasopressor agent of choice, and second line being epinephrine and vasopressin. Dobutamine should be avoided as a single agent because it can, especially in the profound shock, because it can cause worsening of shock because of its vasodilatory activity through the beta-2 agonist activity. Dopamine is usually not recommended in patients with circulatory shock because of high risk of arrhythmia, so it has shifted to 5th or 6th vasopressor of choice. In recent year, there is an increasing evidence of glucose, insulin, potassium infusion in patients with circulatory shock related to the acute poisoning, because the mechanism of toxin-related cardiotoxicity is mainly altered metabolism of myocardial cells, and GIK has a positive inotropic effect in improving myocardial contractility. So the role of GIK is well established in patients with calcium channel blocker and beta blocker toxicity, and there is an increasing evidence of GIK seen in patients with acute aluminum phosphide toxicity. So in this study, in this open label pilot randomized control trial, we found that the addition of glucose, insulin, potassium infusion to the standard care in patients with acute aluminum phosphide poisoning was associated with significant lower in-patient mortality. The mortality was 47% versus 73% in patients with usual care without GIK infusion. Mechanical circulatory support, yes, temporary hemodynamic support with IABP or veno-arterial ECMO has been found to improve survival in patients with acute poisoning with circulatory shock. However, availability is an issue, and it also requires multidisciplinary team management. Furthermore, the indication and timing of their use is also not well defined. Cardiac arrhythmia in our setup, aluminum phosphide is the commonest poison which is associated with cardiac arrhythmia. The commonest arrhythmias are tachyarrhythmias, and especially the ventricular tachyarrhythmias are usually seen in patients with aluminum phosphide. However, narrow complex tachycardia can also be seen. There are other agents also which are associated with the cardiac dysarrhythmia. Especially, I would like to mention tricyclic antidepressant which can cause QT prolongation, wide complex tachycardia or ventricular tachyarrhythmia. Organophosphate compound poisoning usually relates to the bradycardia or bradyarrhythmias, heart blocks, and however, in some cases it can also cause supraventricular tachycardia and atrial fibrillation also. So management, the first line management is to correct the associated metabolic abnormality. This is the important factor, contributing factor to the cardiac arrhythmia. Patients with aluminum phosphide may have hypo or hyperkalemia, hypocalcemia or hypomagnesemia, and if there is a significant severe metabolic acidosis, so in those cases soda bicarbonate may be helpful. Usually we indicate soda bicarbonate in patients with severe metabolic acidosis with pH of less than 7. Antiarrhythmic agents like amiodarone or calcium channel blocker may worsen underlying circulatory shock, so they should be used with caution. Digoxin is a good agent in these scenario. IV magnesium sulfate has been used for decades as a membrane stabilizing agent in acute aluminum phosphide poisoning. It reduces the risk of arrhythmia. However, meta-analysis and systemic reviews have been found it to be useful only with low normal serum magnesium. So it is always important to check serum magnesium levels before giving IV magnesium sulfate, because iatrogenic hypermagnesemia can cause ventricular tachyarrhythmia, especially in the face of renal failure, which is common in patients with acute aluminum phosphide poisoning. There are several agents which can cause respiratory failure at the ED presentation. Organophosphate compound and opioid overdose are common cause of respiratory failure. Agents which can cause methemoglobinemia can also present with respiratory failure. Paraquat is a common poison which has lung toxicity, and significant amount of inhalation of toxic gases like nitric oxide, carbon monoxide, or even severe gases can also cause ARDS-like picture. Ingestion of petroleum products can cause lung aspiration, and it can present as respiratory failure. So the mechanism of respiratory failure in organophosphate phosphate poisoning may be because of muscarinic receptor overstimulation, which causes bronchoria or bronchospasm, or it may also be because of nicotine receptor overstimulation, which cause respiratory depression and shallow breathing. So one of these can be a mechanism of respiratory failure in patients with organophosphate poisoning. Dumbbells Monday to Sunday is a good mnemonic to remember the all features of cholinergic crisis in organophosphate compound poisoning. So the treatment will remain the airway management and of course the antidote atropine. Atropine we used to give as doubling dose method. Initially we give 2 to 3 milligram bolus, and it can be repeated every 5 minutes with the doubling of the previous dose. Still atropinization. The definition of atropinization includes the resolution of the muscarinic cardiorespiratory features, that it adequate cardiovascular stability with systolic blood pressure more than 80 and pulse rate more than 80 per minute, and dried up respiratory secretions with no lung crackles on auscultation. Usually we do not consider pupillary size or other secretions like siluria or sweating in the definition of atropinization. After the atropinization has achieved, there should be a maintenance infusion of 10 to 20% of total bolus doses of atropine for at least 24 to 48 hours. So opioid toxicity related respiratory failure is usually mediated by hypoventilation. So first thing to do is to ensure the adequate ventilation and oxygenation. Naloxone remains the antidote, which can be given bolus as a 0.4 to 2 milligram. and it can be given IV, IM through endotracheal tube or even through nebulization. The dose can be repeated every 1 to 2 minutes until the ventilation is adequate. If there is no response after a total dose of 5 to 10 milligram of naloxone, then infusion of half or 2/3 of the total dose can also be initiated until the ventilation is adequate in these patients. Methemoglobinemia, the agents causing methemoglobinemia cause toxicity through the reduction of the intracellular glutathione store, which further causes generation of the reactive oxygen species, which causes oxidation of the RBC hemoglobin, and the RBC hemoglobin further oxidized to methemoglobin or can cause hemolysis. So patients with methemoglobinemia usually present with the hypoxia, cyanosis, or cerebral ischemia. So usually it is doubted in these patients with a discrepancy between the oxygen saturation detected by the pulse oximetry and PaO2 measured on ABG, which is also called as O2 saturation gap. Methylene blue will remain the antidote of choice. The indication of methylene blue in patients with methemoglobinemia is serum hemoglobin level more than 20 to 30%. Below this level, usually methemoglobinemia spontaneously clears out. It can cause hemolysis in patients with severe G6PD deficiency. So G6PD screening is mandatory before the administration of methylene blue. In such cases, or when the methylene blue is not available, intravenous vitamin C can be useful. However, the onset of action is slow of vitamin C. Neurotoxicity in patients with acute poisoning can manifest as altered sensorium or seizures. Seizures are paramount importance. The causes may be drug withdrawal like alcohol, benzodiazepine, or barbiturate drug withdrawal. Pharmaceutical drugs, isoniazid is the commonest cause in our setup. Our fluoroquinolones and metronidazole can also cause seizures in rare scenarios. Among insecticides, organophosphate compound and amitraz can also cause seizure in about 10% of cases. The management of seizure is important because complications may include hypoxia, brain injury, rhabdomyolysis or acute kidney injury, hyperlactatemia, and severe metabolic acidosis may occur. Treatment will remain the benzodiazepine as first-line agent, lorazepam or midazolam. Midazolam can also be given as intramuscular in patients when the intravenous access has not yet established. For refractory seizures, IV phenobarb or infusion of midazolam or propofol can be started. Conventional anti-epileptics are like phenytoin or carbamazepines are usually not effective in patients with toxin-related seizures because the mechanism of these drugs are different and the toxin-related seizures are occurred through the different mechanism. In patients with super-refractory status epilepticus, intravenous ketamine is increasingly being used as an effective agent. Drug-induced liver failure, the commonest cause is anti-tuberculosis treatment. Acetaminophen is a non-cause, and among other poisons, zinc phosphide or yellow phosphorus can also cause acute liver failure or acute liver injury. Treatment will remain the same. N-acetylcysteine is the treatment of choice, and prognostic criteria like in college criteria or MELD should also be applied to these patients for the indication of emergency liver transplant. Enhanced elimination is important in patients with acute poisoning. It can be done through two forms, alkaline diuresis or urinary alkalization, or through extracorporeal removal. Alkaline diuresis is usually indicated in patients with barbiturate, salicylates, or 2,4-D herbicide poisoning. The method will be intravenous soda bicarbonate boluses or infusion with targeting urine pH of 8. Extracorporeal removal can be done with hemodialysis, continuous renal replacement therapy, or plasmapheresis. Hemodialysis is usually indicated in patients with barbiturates, lithium, methyl alcohol, salicylate, theophylline, or 2,4-D amine. BLAST is a widely used mnemonic to remember the indication of hemodialysis in patients with acute poisoning. So these are few cases when the timely enhanced elimination has saved our patients. In one patient with 2,4-D herbicide poisoning was not improving and rapidly developing systemic toxicity even after the alkaline diuresis. Hemodialysis was timely initiated and the patient was saved. Similarly, this is a recent case we encountered with severe copper sulfate poisoning, who was having hemolysis, methemoglobinemia, acute liver injury and rhabdomyolysis, and he did not improve with chelation therapy with D-penicillamine. However, when therapeutic plasma exchange was started, he showed a clinical recovery. So the take-home message is acute poisoning requires unique ED care challenge. Immediate stabilization targeting ABC will remain the first-line treatment. We need to make the rapid diagnosis to start the effective antidote, and of course the ICU transfer will remain the important among the management strategies. Thank you.
The best part was, everyone noticed it or not, I noticed that all his slides had his own name as references. So feeling so proud that you are here part with us.
Thank you.
So thank you so much. And all of us have seen crashing toxicology patient and managed in our own ways. So I'm sure now we would be having a more better algorithmic way of managing them after your talk.
Thank you.
Any questions? We are all tired, even I can get it. Thank you so much. I invite Dr. Kalpana. So there is something in, which doesn't leave me, it's still there somewhere. It's that regional anesthesia. When I was doing anesthesia, and I remember, it's years, there was orthopedics OT, and I would
Good evening, one and all. The outset, I would like to thank Ashima ma'am and the organizers for giving me this opportunity. I know we are running out of time, so I'll just keep it short and simple. My topic is going to cover more about the peripheral nerve blocks, where the conservative methods fail or the conservative medications have their own systemic side effects, which we want to avoid in certain sick patients. Pain is one of the most common complaint the patient visits the ER, and we triage them accordingly to mild, moderate and severe, and we treat them with the NSAIDs, tramadol, or if severe, we put them on a fentanyl infusion or give them a bolus injection of morphine. So with the aging population, increasing aging population and geriatric population coming to 30% of trauma admissions, we have to have more than this. We have to be equipped with certain other techniques to manage pain, because the systemic side effects, these aging population have also a lot of comorbid conditions. They have a triple vessel disease, they have a double vessel disease, they have decompensated heart failures, respiratory failure, dementia, obstructive sleep apnea, cancer patients, where we want where we don't want and where these patients are more prone to the systemic side effects of opioids. So what next? We have peripheral nerve blocks, which are fast, which provide fast and effective analgesia, which are highly specific, and these are without the side effects of systemic side effects. And studies, data has suggested that this particular article, the data has suggested that regional anesthesia, when employed at the earlier stages, in the ER especially, has reduced the morbidity and mortality in patients with presenting with the trauma like rib fracture, hip and femur fractures. This article also goes on to tell that in hip fracture patients, the regional anesthesia is the most effective analgesic technique when compared to the others. And this also decreases the length of stay and has a higher degree of patient satisfaction and attenuates the stress response. Now I think Ashima ma'am has gone out. This is during my, this slide represents me during my residency, 15 years back. We would give peripheral nerve block that was a blind technique. We did not have ultrasound or a peripheral nerve stimulator then, back then. So this was a routine thing. And now I don't have to tell that. Now I have ultrasound, bedside ultrasound with me. And POCUS has revolutionized emergency practices. So we can, this is also an extension of ultrasound usage. Like this increases accuracy of local anesthetic placement and precise location. We can deposit the drug, and we are actually visualizing the structures, the blood vessel or the nerve bundle. So there are very less and very fewer complications, if any. And there are higher rates of successful blockade, and these do eliminate the need for procedural sedation and analgesia and the side effects associated with that. Not a strange concept. On-arrival blocks where a continuous peripheral nerve catheter is placed, which again provides site-specific and immediate pain relief. And these continuous peripheral nerve catheters can also be utilized for serial procedures following the initial stabilization, or it can be continued for post-op management as well. Coming to the indications, right from lacerations, all kinds of fractures, dislocations, abscess drainage, and ICD placements or removal ICDs, everywhere we can use this. And for residents in particular, this beautiful article from POCUS journal has all the indications summarized, and the article also gives the dermatomal distribution, the indications, contraindications, and complications associated with each block. You want me to wait? Thank you, sir. And when I pulled out the article for references, where ultrasound guided nerve blocks are highly performed in emergency practices, it's more for a forearm nerve blocks, and the common indications being fracture pain management, 73% of the times. Contraindications, nothing apart from patient refusal, allergy to local anesthetic drugs, soft tissue infection, neurological deficit. We don't want to induce a double crush syndrome here. When the patient is already having a nervepraxia or neuropraxia, we don't want to traumatize the nerve by performing a block. So we better avoid it there. And altered level of consciousness and potential development of compartment syndrome. It's a day situation. We don't have enough, evidence is very thin, but the compartment syndrome, a lot of case reports have been reported, not a study or a trial on that. So better avoid it if you given a choice. And coagulopathy is also a contraindication. Preparation, informed written consent, identify the site, keep your equipment, ultrasound ready, and most of us are privileged to have a procedural or a block room to perform this. But otherwise, even otherwise, you have your, put on the AAC standard monitors at least, and your equipment, your drugs, card should be ready. Then coming to the choice of the drug, lignocaine, bupivacaine, and ropivacaine are the most common things we routinely use. And bupivacaine comes in 0.25% and 0.5% concentration. If you want only analgesia, go for a lower volume, lower concentration of bupivacaine. And if the patient wants a motor blockade as well, go for a higher strength of the drug. Coming to the individual extremity blocks, coming to upper extremity, we have interscalene brachial plexus block. Which when you place the ultrasound probe in the interscalene groove at the level of cricoid cartilage, you target the nerve roots, that is C5 and C6. What do we see? This is the traffic signal sign, we call this as C5, C6, C7 amidst anterior scalene muscle and the middle scalene muscle. And we are going to deposit 15 ml for analgesia only and 30 ml for a surgical anesthesia. You have to be very careful here. Any higher volumes of the drug can easily go on to reach the phrenic nerve. The other two dots represent the phrenic nerve there, so which can cause a phrenic nerve palsy or a Horner's syndrome, and better to avoid if there is a contralateral diaphragmatic palsy as well. Supraclavicular brachial plexus block, you have to image it by placing the probe. The probe selection is important here. These are all high frequency linear transducer probes. Anywhere the depth is more than the 4 centimeter, use a curvilinear probe. Okay, in the supraclavicular fossa at the midpoint when we place, we see subclavian pulsation, and next to subclavian pulsation we have this bunch of grapes appearance, that is the brachial plexus. So coming from the lateral to medial approach, we can deposit a 15 ml drug for analgesia only, and the local anesthetic spread around the brachial plexus, just posterior and superficial to the subclavian artery. We should aim to lift up the artery for the more successful block. Axillary brachial plexus block, again, imaging of the axillary area perpendicular to the arm, and as the transducer is proximally slit, you are going to see axillary vessels and the bunch of the cords, that is medial, upper and median nerve, ulnar nerve and radial nerve can be traced. And most of the times here musculocutaneous nerve can be spared, which is hid in the coracobrachialis muscle. So we have to block it individually. Apart from this, digital nerve blocks, and at the wrist we can block these individual nerves. For median nerve we are going to, these don't need ultrasound guidance, actually can be performed with the landmark technique. Palmar wrist tendon we are going to ask the patient to, we are going to locate it and place a drug just lateral to it. And for radial, just lateral to the radial artery pulsation, where our wrist watch, that's the area we infiltrate superficially. Chest wall blocks. Chest wall blocks are mainly paravertebral blocks, erector spinae blocks, and serratus anterior and pex blocks. These are routinely employed for rib fractures or ICD placements, and we can see one of the patients where we put a paravertebral block with continuous infusion. And this is one good article which I found where multiple rib fracture patients, around 313 patients were included in the study, and this where they emphasize the role of analgesia, effective analgesia and reduction of respiratory complications in rib fractures. So paravertebral block, patient can be in a prone position, or if you cannot make the patient prone, you can have them sitting, and you can, we are going to place the probe in the midline, scan the spinous process, just slide the probe laterally 2 centimeter, where you will locate the paravertebral space, transverse process, and paravertebral space will appear as a wedge-like space. And for erector spinae block, you are going to deposit the drug just at the transverse process. Intercostal nerve block, again one of the favorites, where you have less than 3 rib fractures, this can be easily employed. And here we are going to say the technique is same as the paravertebral block, but you're just going to slide the probe a little more lateral, that is 7 centimeter from the midline, so that we are going to place the probe. Now the probe is going to be on the ribs and the interrib area, where you can see the musculature and the costal groove which holds the neurovascular bundle. We are going to target there and deposit our drug 10 to 15 ml. Serratus anterior plane block, where you have more of anterior chest wall injuries, and where you want analgesia of the anterior chest wall, this can be employed. And here we are going to place the drug between the serratus anterior and the latissimus dorsi muscle, which is superficial serratus plane block, or we can go deeper, where we can place the drug between the serratus anterior muscle and the intercostal muscles. Lower extremity blocks, I think this most of you have also been performing. And this picture I put because this is the ergonomically, this is the correct way of doing this block. How happy ER physician is to have the ultrasound machine right in front of him, and he's using his dominant hand to hold the needle, and the non-dominant hand is helping him hold the transducer and visualize the structure. So as we place the transducer on just below the inguinal crease, we are going to see the femoral vessels, and just lateral to the femoral vessels, VAN we are going to see the femoral nerve, and the femoral nerve is going to be looking like a hyperechoic structure where we are lateral to medial. If we place a drug 10 to 20 ml, we are going to achieve analgesia. And now if you want a lateral and the more medial branches also to be involved, we can go for a compartment block, that is fascia iliaca block, where we are the technique is same, but we are not going to target the femoral nerve. We are going to deposit the drug just below the fascia iliaca. So it will cover lateral cutaneous nerve of thigh, femoral nerve, and if the volume is more than 30 ml, it's going to seep through, and it's also going to cover the obturator nerve. A popliteal nerve block where a sciatic nerve is targeted before it divides into common peroneal and tibial. As we place the probe in the popliteal crease and just 7 centimeter proximally we take the probe, we are going to target this nerve, and this can be performed in prone, supine, or wherever, whichever patient is position is comfortable, we can easily perform this block. We are going to deposit 10 to 20 ml here. Ankle block, again we don't need an ultrasound. We are going to target the 5 nerves: superficial, deep peroneal, sural nerve, saphenous nerve, and the posterior tibial nerve here. Complications apart from block failure, bleeding, infection, pneumothorax like certain intercostal block or paravertebral nerve block or supraclavicular brachial plexus block, you have to be very careful not to plunge to the pleura. How do you avoid these complications? Infections, you always practice the sterile aseptic conditions, and nerve injury, if your patient is having severe excruciating pain when you are injecting, just abort don't inject the drug. A note on multimodal analgesia. Always consider multimodal analgesia when treating pain, because this where different modalities of techniques are employed here, and different drugs are chosen with different mechanisms of action, so that the individual doses can be reduced, which has a synergistic effect and with the lesser side effects. Lot of evidence, especially I collected these for your references. So all are in favor of performing ultrasound guided nerve blocks in the ER department. I understand that in ER USG guided nerve blocks are not, it's not considered as a core competency, but the society can decide on giving fellowships or training like focus. We have workshops, and I believe here also we have ultrasound guided peripheral nerve blocks, separate workshop, and delegates should make use of this. And as we are moving towards opioid crisis, I think utilization of alternative pain control strategies remains paramount importance, and peripheral nerve blocks as an alternative to opioids decreases the healthcare costs. Thank you.
Thank you, madam, for the excellent lecture. As emergency physicians, we used to hail up the pain management. So we are very much tired with hiking up from NSAIDs, paracetamol, then going to the opioids. So this gives us a very excellent opportunity, mostly to the postgraduates. So initially we used to take help from the anesthesia guys.
Correct.
Now actually we used to train in the, what I was trained is I was in the cadaver. We went to the dissection lab, so we used to train in the cadaver, and we used to practice. So it's an excellent method. Thank you, madam. So it's open for the discussion. Any doubts? Awesome.
That was a very nice presentation. What I wanted to ask you is, you having come from an anesthesia background, you're very well versed with peripheral nerve blocks.
Yes, sir.
So in your department, in the emergency department, which of these that you have mentioned have you or your colleagues been performing?
Intercostal nerve block is the most common performed, sir, and femoral nerve block is the most common. Yes. Intercostal nerve block happens to be one of our postgraduate students' thesis topic as well, sir.
Very good. The reason I asked you this question is that the procedures that we do, you should take photographs where you're performing it or your colleagues are performing it in your ambience, and you can describe, see, this is the way you need to be seated, this is the way you need to do. So then the people that you're teaching will know that you are not taking it from a textbook, because all these things what you have shown us is all white skin. Okay, thank you very much for telling me to shut up. But what you have shown me so far are all white skins. I like brown skin. So therefore, I would like to see some brown skin when you're doing, because it adds credibility to your talk.
Yes,
because
sir.
then you are talking what you are doing, rather than, transplanting it from a textbook onto a slide and then speaking about it. So my suggestion to you is that you will be speaking a lot more in many more conferences about peripheral nerve blocks. Take pictures and let them see that, this is what I do, this is how I do it, in my experience, this is how it should be done. Then you speak with authority.
Thank you, sir.
Okay.
Will be incorporated in next presentations. Thank you so much. Thank you for the opportunity.
Congratulations for your wonderful presentation. I would like to ask you one question. Have you ever encountered the systemic toxicity with local anesthetics? Because see how many of you? Not. Okay. It is the preparation which is required for that also. It's intralipid, which is 20%, should be available.
Please go ahead, comment on that.
No, even I have not also encountered with this.
Give it to a person who's had the problems.
Okay.
Ladies and gentlemen, I want to introduce you to a good friend of mine who has come just to be here to meet me, basically. So this is Dr. Sendil Kumaran. He, in my opinion, is the best clinical toxicologist in India. So Sendil actually runs his own hospital. He's an emergency physician of many, many years, and he's had lots and lots of experience, and he suddenly said, no, there are problems. So I thought, Anna, I'll let him say a few words. Sendil.
I have encountered, ma'am. This mainly occurs with the bupivacaine when it enters into the intra-arterial. Most of the time, the patient go for resistant cardiac arrest, or the patient will go for hypotension. Intralipid works very well. Actually, I had an opportunity to meet a person. It's called David Uncle, who is a person who came across the LATS, local anesthetic systemic toxicity. They had a seizure. Patient was given intravenously the bupivacaine. Patient had a seizure, following which cardiac arrest happened. Unfortunately, at the time, there was no fluids were there in the room. It was not exactly in the operating room. It was in the emergency room they were giving. So no fluids were there. So they want to resuscitate the patient. They saw only intralipid was there. They gave. Immediately the patient's blood pressure improved. Return of spontaneous circulation occurs within 3 minutes. And patient didn't have any neurological toxicity. So then he thought this works, and he tried in experimental with various animals, mouse studies, and then they found that it works very well. As a special interest in toxicology, we regularly use in most of the drug overdose which has a lipid solubility. So this works mainly on the lipid sink theory. So when we are giving the intralipid, this reduces the toxicity, and the cardiac stability and hemodynamic stability is attained very fast. And no need to worry about fat embolism and other things and all. Just like that, 20% intralipid, you have to give a bolus, and you see the patient's circulation is not there, still in cardiac arrest, second bolus can be given, and you have to continue this infusion for 6 to 8 hours. And you have to watch for rebound toxicity, otherwise nothing will happen. Thank you.
Thank you, Sendil sir. Now I invite Dr. Suchitra Vaya.
Actually, you cannot give for a prolonged period of time, citing the reason that there is a cutoff point for giving intralipids. Intralipid maximum dose that you can actually infuse is 10 ml per kg.
That is bolus.
No, sir. It is total cumulative dose.
No, sir. Bolus.
Okay, we will check, sir.
That is for nutrition you can give. Okay. That is for nutrition, what you say it is right. This is for resuscitation.
Suchitra ma'am will speak on intubation strategies in emergency department. Over to you, ma'am.
So, hello everyone. A very good afternoon. Lovely to meet you all, especially my esteemed seniors and colleagues from premier institutes. And I would like to be thankful to the organizers for giving me the opportunity to speak in this wonderful academic feast. So my topic is intubation strategies in ED. You want me to stand up? Oh, perfect. So my topic is intubation strategies in ED. Every day, around 5 to 10% of the patients land up in ED which require invasive ventilation. All of us are doing this day in out. And what we are being trained for this is we are only dealing with the anatomically difficult airways. We are not trained to deal with the physiological difficulties which patients land up. They have very severe physiological derangements like hypoxia, hypotension, metabolic acidosis, and which we unnoticed very many times is the right ventricle, which is not seen frequently. So I would mainly focus my talk on these physiological derangements because we have different algorithms related to the anatomical difficulty airways, like given by the difficult airways algorithm by the DAS Society and all. So my objectives will be to understand and assess the physiological as well as the anatomical difficulty airways and to learn the strategies to deal with the physiological difficult airway. So we begin with the case scenario. A young male adult of around 52 years landed up in the emergency department with a history of 5 days of shortness of breath, and that aggravated on for the last 1 day with his on and off chest pain. So vitals which were reported to us were that he is tachypneic, tachycardic, his respiratory rate, heart rate is around 106, blood pressures is 70/40, the temperature is almost normal by 98.6, but its saturations were around 48% on room air. A quick examination gives us that respiratory system is having diminished air breath sounds on both the sides with bilateral coarse rhonchi and crackles. X-ray at bedside with AP view shows diffuse airspace disease bilaterally. A POCUS done shows that moderate B lines are there and moderately large RA and RB with flattened interventricular septum. All of us will agree over here that we plan for rapid sequence intubation, isn't it? So how to proceed with this? So there has to be a plan, there has to be a strategy with well-defined techniques, which I'll be leading in the succeeding slides, and the tools for that. So first of all, we'll think of that we will have to assess the anatomical difficult airway when we are seeing the patients. There are very many algorithms and there will be methods being given to us for the difficult airway assessment, which is one of them is the Lemon score, which every one of us know it very well, and the other one is the Makocha score, which takes into account the patient relation to the patient, which only Lemon score is taking. Apart from that, it takes the pathology related to the patient, and here the operator who is intubating. See, anesthesia people are very much trained to do that, but the emergency physicians are not that trained, so that takes the account also. The Makocha score, and it's coded from 0 to 12, and 0 is very easy and 12 is very difficult. Now, accordingly, we'll proceed. If the patient is unconscious or unreactive, then we go with the crash airway algorithm. If he has difficult airway, we go with the difficult airway algorithms, which we all know. It has been updated recently in 2021 also. And if we land up with this failed airway algorithm is also there. But our patient landed on, was having rapid sequence. So he was not having any difficult or failed, fine. So we are going to start with the 7 Ps of rapid sequence intubation, which all of us are being learning. First thing is required is the plan and preparation. Then you have to pre-oxygenate the patient. Previously, it used to be like pre-treatment. Nowadays, peri-intubation optimization, which is very much important. Then paralytic with induction drugs, positioning of the patient, then placement with proof, and post-intubation management of that patient. So this is one of the studies recently done. It's an in-tube study, which is done in 29 countries with over 3,000 patients. And one of our colleagues at Tata Memorial Hospital, Dr. Sheila Mehta, she was also involved in this study. And what they found that in the peri-intubation period, around 45.6% of the patients, they land up with one of the major catastrophic events, like cardiovascular collapse or cardiac dysarrhythmias or hypotension, even death also. And this study showed that cardiovascular instability was seen in about 42.6%, with severe hypoxemia around 9.3%, and cardiac arrest around 2 to 4%. There they had study of around 2.3% having cardiac death arrest in these patients. So this is very important to know that these patients will end up with the higher mortality in the ICUs also. Overall ICU mortality for these kinds of patients was around 32.8%. So there is a very good article in West Journal of Emergency Medicine which tells you about the physiology of difficult airways given by Dr. Gerard Mossier and this John Seckles. And he has defined that physiologically difficult airway is one in which severe physiological derangements, they place your patient at higher risk of cardiovascular collapse and death during your procedure as tracheal intubation and transition from that intubation to the positive pressure ventilation. So we have to see that. What are the 4 factors, important physiological difficult airway factors, which can lead to this catastrophic collapse are the hypoxemia, the hypotension, the metabolic acidosis, right ventricular failure. Now recently, this is a review article by our Indian authors, Dr. Sheila Mehta and Bhavya Vakil. They have also written that physiologically difficult airway can be seen in critically ill patients and non-critically ill patients also. The critically ill patients like hypoxemia, hypotension, right ventricular failure, metabolic acidosis, and they have also included the neurological injuries. But non-critically ill patients like extremes of age, obesity, pregnancy, pediatrics, and patients at risk of aspiration, especially the diabetic patients who have frequently vomitings and the GI obstruction also. Okay, so we have to deal with these patients accordingly. So one by one, I'll take this. Hypoxemia is the first one. So all of us know that oxygen is very essential, it is critical. It keeps the flame of the life burning also. So if any kind of hypoxia at any time during your procedures can lead up to the desaturation with cardiac bradyarrhythmias, tachyarrhythmias, and cardiovascular collapse or death. Any saturation less than 70 will lead to this catastrophic complications. So we have to optimize these patients before directly going for the rapid sequence intubation. How do we do that? First is the positioning of the patient. You have to increase the head of the patient by 25 degrees, elevate the head, and you get the patient in the rammed up position with sniffing. So keep that ear to sternal notch at same angle. What will this help you? This positioning will help you in better visualization. It will decrease the aspiration chances, and very more important is that functional residual capacity will also be increased in this positioning. Second comes the pre-oxygenation. Why are we doing the pre-oxygenation to the patient? Because we want to increase the reserves of the patient, increase the oxygen reserves. And this has been done with the increase in the functional residual capacity. We are denitrogenating the patient. And this is done for 3 to 5 minutes with normal breaths or 8 vital capacity breaths. Continuously, we have to pre-oxygenate these patients. Previously, it used to be done by a non-rebreather mask, but now we are not doing with the non-breather mask because we see that with the non-rebreather mask, it's not like it is giving you 60 to 100% of FiO2. What is happening is the patients are tachypneic and they are taking the oxygen, this air also from the surroundings, ambient, with your oxygen. So that is being diluted. It is not going in the form of 60 or 80% or 100% with NRBMs. Okay. So pre-oxygenation is very important to denitrogenate and to increase the functional residual capacity. Now there is a very important term is called apneic oxygenation. Most of you, if you have done that during the COVID periods, you must have used that high flow nasal oxygen or high flow nasal cannulas to give that apneic oxygen. What does this term means is you have to continuously give the patients oxygen during your apnea time. What is the apnea time? When you have given the drug to the patient and you are prepared with the laryngoscopy and you put in the laryngoscope. That duration till your tube is inside, that time is very important for these patients. So for this, you need that apneic oxygenation because you have to achieve that maximum hemoglobin saturation at that time. So this apneic oxygenation can be given by either, because we are dealing with a resource-limited country, we do not have high-flow nasal oxygen sources in the emergencies, though they are in the ICUs. So we are very friendly with the high-flow nasal cannulas, which we have in the emergencies. And we can easily give that with 15 liters of oxygen continuously to the patient during your procedures. What will this help? It's basically working on the diffusion. So what is happening is whatever oxygen is going to the alveoli, with the diffusion, it will go to the capillaries, and there will be a pressure gradient in the atmosphere and the alveoli that will be taken care if you are continuously flushing it. And it keeps a peep of around 5 centimeters of water, which high flow cannulas are keeping around 50 15 centimeters, and they can give about 40 to 60 liters per minute of this oxygen flows. If you have that facility, then it is well and good. If you can use that high flow nasal oxygen cannulas or this. Then we come with the non-invasive positive pressure ventilation, which is very frequently used in the emergencies also. So depending on the risk, if the patient comes into moderate risk of this desaturation, you can add on with the NIVs, and you can keep the IPEPs and the EPEPs of IPEP of around 15 centimeters of water and EPEP of around 5 centimeters, and keep that mean airway pressure of around 10-15 centimeters, so that there is recruitment of alveoli going on. Right. Then high flows in cannula, I've already taken. Rapid sequence intubation, all of us know it is the induction dose followed by the paralytic dose, which is we are doing it very frequently. And then Megan mask ventilation during your induction and laryngoscopy. So few of the patients will not be given that, especially the pregnant females or full stomach. We are not doing that mask ventilation in between the laryngoscopy and induction, but all of the patients can be given that. This is a very good once again, very good graph being given by Gerard Mossier in his article, which shows that there is, on the x-axis, there is risk of desaturation. On the y-axis, there are percentage of patients. And he has given that accordingly you can judge that which patient will need the techniques, higher techniques of the oxygenation during your procedure. So low-risk patients, they can be easily dealt with the flush rate, denitrogenation, upright position, apneic oxygenation. And low-risk are the ones who have high of the functional residual capacity and low of the shunts. But the moderate risk patients, they are more in number, and they have higher shunts and low functional residual capacity. And the higher risk to refractory hypoxemia, they are very difficult to all of us to manage them. We want to intubate, but we can't do that because they crash very fast. And this has been very frequently seen during the COVID times. We have seen that refractory hypoxemia was very dangerous, and we were not able to manage those patients. They crashed as soon as we intubated. So this is a very important to decide, judge which patients are on the low risk or which are in the higher risk. And this is the important curve which has been shown in this one of the articles by Dr. Shaila Mehta, and she has very well depicted that time of oxygenation desaturation, this one, and this the percentage of oxygen saturation in a normal healthy person. If you have given this drug and you have around 8 to 10 minutes of apnea, but in a critically ill patient it's around 5 minutes, and if they are in severe ARDS with hypoxemia, severe hypoxemia, it is around only 30 or 40 seconds or 70 seconds. So it is very dangerous for all of us to deal with these patients. Next is the hypotension. We are all very much aware with this. Hypotension, as we all say, it's systolic blood pressure that less than 90 or MAP of less than 65. But it is not very necessary that each and every patient will have that systolic pressure of less than 90. And the most important at that time is to see that shock index, which we are all well versed with this. The shock index is basically the heart rate divided by the systolic blood pressure. It's normally 0.7, and if your patient is having that shock index of more than 0.8, then you should be cautious about that. So this is hypotension, which if you have this 60 minutes post-intubation period, this is defined at 90, less than 90, or mean heart pressure less than 65, systolic pressure going. So how to manage? If you have hypovolemic patient because of the hemorrhage, then you give blood products. If you have fluid defluted, then you give isotonic or crystalloids. Then there is one term called push dose vasopressors, especially epinephrine, which we are using is 10 microgram per ml. And this gives you time to bridge to continuous infusions of noradrenaline and saves the patient's life during that intubation period also. And later on, you switch off to the vasopressor infusion. And vasoplasic patients, you give noradrenaline as an infusion. Induction agents, which we are using, are frequently, most of it might be using fentanyl or propofol, midazolam or ketamine or etomidate. But I would like to say that etomidate is the safest cardiostable drug, because ketamine, though it is sympathomimetic, but it has also caused cardiac arrest in the patient who are catecholamine depleted. It causes a cardiac depression. So that is also to be used very judiciously. And so I would request you all to have a reduced dose of induction agents because hypotensive patients require reduced dose. So go by 50 or 70% dose and give a high to normal dose for the paralytic agents because of the slope of circulation. So right ventricular failure, all of us know that it's a very highly compliant and low pressure system, and it all depends on the preload. So, but most of the patients are hypoxic, hypercarbic, hypotensive, and all of these factors lead up to the right ventricular failure. So we have to acknowledge them at that moment, especially when you are switching these patients to positive pressure ventilation. If the patient is in right ventricular dysfunction or right ventricular failure, you have to see that when you are switching them to the positive pressure ventilation, the pulmonary vasculature pressures are increased, and then it will all go, the pressures will go to the right ventricle, and there will be right ventricular end diastolic pressures increase, right ventricular end diastolic volume increase, the septal shift which will be seen by the interdependence the septum shows. Fine. So focused bedside cardiac ultrasound, which is very important. All of us have to learn this. Very judicious use of fluids in the right ventricular failure with diuresis, oxygenation to be continued, vasoactive drugs as and when required to be administered. Induction agents, again, etomitate is the drug of choice. If you have this inhaled nitric oxide facility, then you can use them because pulmonary vasculature will be dilated with these. Avoid the invasive ventilation if possible. If not avoidable, then go with the low mean air pressures and avoid hypoxia, hypercarbia, and atelectasis. Severe metabolic acidosis, they are, because all of these patients, they are landing up with the high ventilatory rates. And once you switch on to the ventilation part, what you forget is that patient was keeping around 40-50 liters of the demands, and we switch on to 8 liters around. So it is very important to switch to that mode which can keep the patient on the safer side, go on to the pressure support modes or pressure targeted modes to keep the patient on the spontaneous ventilations so that he can easily compensate for that metabolic acidosis. Optimizations, this I have taken. Now, neurological injuries, everyone, blunt the laryngoscopy response with your lignocaine, fentanyl, or esmolol. Go with the etomidate. Don't use propofol because there is precipitous fall of the blood pressure and the cerebral perfusion pressures are not maintained. Think of that hypoxia and hypercarbia should be avoided to maintain the cerebral perfusion pressures and to restrict the increase in the intracranial pressures also. Non-critically ill patients, the pediatrics, they pose with both anatomical and physiological difficulties. Same with the obese patients, same with the pregnancy and patients at risk of the aspiration. So all of them have to be dealt very judiciously. So this is a very important Society for Emergency Airway Management. They have given 10 recommendations. I would say there are 10 commandments which one should do while we are evaluating and managing the physiological difficult airways, especially the hypoxemia and hypotension, which you can go and see in this Society of Airway Management. It's very well given for there. What I have seen, told you this there. And this is the strategy been given by the article, which I told you it in the Airways article by Dr. Sheila Mehta and all. They have very well, step by step, they have given the strategies to prevent the complications during the tracheal intubations in the emergency department with the airway assessment, preparation, position, pre-oxygenation, RSI, and one term which is called delayed sequence intubation. The agitated combative patients, they require delayed sequence intubation. You can give on short doses of ketamine around 10-20 milligrams of this drug in the increments, and later on switch on to the invasive ventilation. This is a very small crash mnemonic given in the ASAP, which tells you about whom to be dealt. That's consumption increased in R stands for right ventricular acidosis, A, saturation S, and hypotensive volume. To summarize, plan for your tracheal intubation, focus and address both anatomical and physiological airways simultaneously. Have a strategic, systematic approach to deal with these 4 important physiologically deranged airways: hypoxemia, hypotension, right heart failure, severe metabolic acidosis. So these are my references. Any questions?
Thank you, madam, for letting us know the drastic change from of RSI. Now we don't practice rapid sequence intubation. What we practice is resuscitation sequence intubation. Yes, we need to tackle all the physiological killers. Hypoxemia, you need to start on apneic oxygenation, hypotension, and H+. Then only you go and intubate your patient. Thank you, ma'am, for the excellent lecture. Any questions? Okay.
Moving on to the next topic, I am honored to invite Dr. Karthik Reddy for the next talk. And the presentation is on vasoplegic shock.
Okay. Good evening, everyone. I thank the organization for giving me the platform for this presentation. So in the next few minutes, I will be discussing regarding the vasoplegic shock. So today morning, discussion has happened regarding the septic shock and anaphylactic shock. So I will keep it simple. So this topic will be discussed under the following headings: introduction, definition and cause of the vasoplegic shock, its pathophysiology, and the different management strategies, and followed by the summary. So vasoplegia is nothing but a form of vasodilatory shock, even though it is a well-recognized phenomenon. Like, it is seen in almost all the advanced stages of shock, but there is no uniform clinical-based definition. So incidence varies between 5% to 35%. It is associated with high mortality and morbidity. So pathophysiology is multifactorial. There is activation of several intrinsic vasodilatory pathways, and there is vascular responsiveness to vasopressors. So management part, catecholamines are the first choice for hypotension, followed by the vasopressin. So what exactly is this vasoplegia? So under normal physiological state, there is some amount of resistance in the blood vessels that we'll call it as vasomotor tone. So we have some amount of blood pressure. But in the pathological conditions where there is a normal cardiac output, so there is a loss of this vasomotor tone because of several inflammatory responses. So there is an hypotension. So this vasomotor tone is difficult to measure, but it is represented by systemic vascular resistance. The systemic vascular resistance is nothing but mean arterial pressure minus central venous pressure divided by cardiac output. So in the definition, there is no clear description available. It is highly variable, and there is a lot of heterogeneity in the literature. There are many definitions in use based on the cause, but components that are included in the definition are low mean arterial pressure, that is less than 50 to 60 mm of Hg, normal or elevated cardiac index, that is more than 2.2 liters per minute per meter square, low systemic vascular resistance, less than 800 dynes per second per centimeter square, and refractory to fluid resuscitation and administration of at least one high-dose vasopressor. But whatever this mentioned, the criteria in the literature is non-specific. It can be seen in the sepsis, adrenal insufficiency, hepatic failure, or burns. So coming to the causes, so the most common cause in the intensive care units which we see is sepsis or septic shock, followed by the post-cardiac surgeries. Mainly it is the valvular surgeries or post-cardiac pulmonary bypass, followed by the trauma, burns, ischemic reperfusion injuries, drugs, it may be CCB toxicity or beta blocker toxicity, and it may be general or neuroaxial anesthesia. So cardiac surgeries, it is associated with high mortality and morbidity. So definition is absence of low cardiac output. So once we ruled out impaired cardiac output, bleeding, or the cardiac tamponade, and once we ruled out the infection, and if the patient is exposed to extracorporeal circuit, so then vasoplegic shock is suspected. So there are certain predictors in whom we can predict the post-operative vasoplegia. So most common is the renal failure. If the patient has undergone previous cardiac surgeries, so duration of the cardiac pulmonary bypass time, combined surgeries, and amount of RBC transfusion. So isolated CABG is not associated with risk of post-operative vasoplegia. So other non-cardiac surgeries, the risk is very less. It depends upon the prolonged duration of surgery and the need for blood transfusion. So other causes like burns, pancreatitis, or trauma, it mainly significant amount of tissue injury, that excessive amount of activation of systemic inflammation, hypermetabolism, followed by organ dysfunction. One of them is vasoplegia. So little discussion about pathophysiology. So normal physiology is the vascular tone. It depends upon the rate of calcium influx versus removal from the cell. So there are certain regulators for this, intrinsic regulators such as endothelial secretions, which are nitric oxide, prostacyclin, and endothelin, vasoactive metabolites like acidosis, hypoxia, hydrogen sulfide, autocoids, serotonin, prostaglandins, and thromboxane A2. And extrinsic regulators are adrenaline, angiotensin 2, and vasopressin. So cellular mechanism of vasodilatory shock. So normally when norepinephrine or angiotensin 2 combines to the receptors, there is release of calcium from the sarcoplasmic reticulum. So this combines with calcium carbamidolin complex. So this will cause myosin activation. So the actin combines with myosin, so there is a vasoconstriction. So in the pathological state, so whenever there is increased amount of nitric oxide production or atrial natriuretic peptide, the cyclic GMPs gets activated, there will be dephosphorylation of myosin. So this causes vasodilation. So pathophysiology is very complex. It involves various mechanisms in the vascular smooth muscle cells. So number one is G protein coupled receptor desensitization. So alteration of second messenger pathways, critical illness related corticosteroid insufficiency, and there is increased production of nitric oxide. So this is the image that's showing pathophysiological mechanisms involved in the vascular responsiveness to vasopressors. So in the top one, you can see that whenever there is an hypotension, that is, there is an activation of baroreceptors. So it will cause activation of the sympathetic system and hypothalamic pituitary adrenal axis. So followed by there is release of norepinephrine, epinephrine, cortisol, vasopressin, and angiotensin 2 to maintain the normal blood pressure. But if there is excessive activation of the sympathetic system, it causes dysautonomia. There you can see there inappropriate tachycardia, adrenoreceptor desensitization, and pro-inflammatory state, and this will lead to poor outcome. So next, these angiotensin receptors and vasopressin and adrenaline receptors or G protein coupled receptors, if there is an overactivity of sympathetic system followed by sustained agonistic stimulation, it causes phosphorylation of G protein coupled receptors followed by the desensitization and downregulation of these receptors. So that is the main reason for vascular hyporesponsiveness to vasopressors. So nitric oxide is the most important regulator of vascular function in both health and the disease. So the overproduction of nitric oxide is seen whenever the blood vessel is exposed to endotoxins, inflammatory cytokines like tumor necrosis factor, lipopolysaccharides, or autocoids. So this inducible nitric oxide synthase will produce excess amount of nitric oxide, and this causes excessive vasodilation, platelet activation, and leukocyte adhesion. Followed by, there will be dysfunction of mitochondria, apoptosis, and multi-organ failure. So one more mechanism which causes vasodilation and hyporesponsiveness to vasopressors, that is potassium channel hyperpolarization. So to maintain the vascular smooth muscle membrane potential, this efflux of potassium through the ATP sensitive potassium channel is very important. But overactivation of potassium channels seen in conditions like hypoxia, acidosis, high lactate, or endothelial mediators like ANP or nitric oxide, it causes hyperpolarization of the cell followed by inactivation of these calcium channels. So next, critical illness related steroid insufficiency. We all know that in 30 to 40% of patients with septic shock, there is some amount of steroid insufficiency. It may be because of HPA axis suppression by the inflammatory markers, adrenal failure or adrenal necrosis, or it may be peripheral resistance to steroids. These all downregulate ACTH and cortisol production. So whenever you give exogenous steroids to this patient, they inhibit the synthesis of inducible nitric oxide synthase, thereby decrease production of nitric oxide and COX-2, and this will potentiate the vascular response to circulating catecholamines and angiotensin 2. So in the approach study that is published in NEGM 2018, where the patients were given hydrocortisone and fludrocortisone, it was found that there was a beneficial effect on 90-day mortality and shock reversal. So next, coming to the treatment. So whatever the treatment that has been in the literature for the vasoplegic shock is data that is taken from the septic shock. As such, vasoplagia due to other causes, data is lacking. So from the surviving sepsis guidelines, norepinephrine is the first drug that should be given to patient with hypotension, followed by early vasopressin. So there is no exact dosage cutoff or at norepinephrine when to start vasopressin. But it looks beneficial. Like vasopressin, it limits the adrenoreceptor desensitization and sympathetic overactivation. So the choice of the best adrenergic vasopressor should take into account not only its just vasopressor effect, but also its cardiac, metabolic, microcirculatory, and these immune functions. So norepinephrine, first line, it's very potent drug. It increases the mean arterial pressure and cardiac index without any increase in the heart rate. But it is associated with some sort of side effects like increased oxidative stress, interaction with the cellular energy metabolism, and modulation of the inflammatory response. So there is a newer concept called decatecholamine, that is use of non-catecholamine vasopressors in order to decrease the catecholamine exposure. So vasopressin, so there are two different types of receptors. V1, it causes vasoconstriction, and V2 is vasodilation. So rationale for its use. So in early stages of shock, in late levels increase, but after 24 hours it falls to subnormal levels. But it may be associated with reduction in the peripheral receptor numbers. So whenever you give supply an exogenous vasopressin, it restores the tone, it increases the blood pressure, and it may reduce the need for norepinephrine requirements. So this is Wang's trial. It is a randomized controlled trial. It's a Brazilian trial which is published in 2017. So they compared norepinephrine to vasopressin in treating vasoplegic syndrome after cardiac surgery. So they found that is event-free survival, that is the primary outcome, was superior in the group treated with vasopressin. 32% of vasopressin group compared to 49% in the norepinephrine group. The 30-day mortality was comparable. It's almost 15%. But the incidence of renal failure and atrial fibrillation were low in patients with vasopressin. So post-cardiac syndrome followed by cardiac surgeries, you can start with vasopressin. So terlipressin, long-acting vasopressin analog with predominant V1 activity. Main side effects is pulmonary vasoconstriction, and it may affect the coagulation system. It has no advantage to compare to vasopressin, and the clinical evidence for use is very less. So phenylephrine, it's a pure alpha-1 adrenergic agonist. Complication, again, it is splanchnic vasoconstriction. And in many studies, it was found that higher in-hospital mortality, so we cannot use. So there is a newer drug called celipressin. It is a selective V1A agonist. So in the Sepsis Act randomized control trial, which was published in 2019, so they compared the effect of celipressin versus placebo on ventilator and vasopressin-free days in patients with septic shock. They found that there was no improvement in vasopressor and ventilatory-free days within 30 days. So next, coming to the salvage therapies. So most important one, angiotensin II. It is an endogenous vasopressor. It has an norepinephrine sparing effect. Few case reports has been published where they've found that there is a reduced need for norepinephrine and higher MAP in patients with post-cardiotomy vasoplegia. So the dose 10 to 40 nanogram per kg per minute. So this is a randomized controlled trial. So where angiotensin II was compared with placebo in patients with septic shock on norepinephrine, they found that the primary efficacy endpoint, that is mean arterial pressure response at the end of 3 hours, that is either 10 mm increase in MAP or MAP of 75 mm of Hg, was found in 70% of the patients with angiotensin II compared to the placebo 23%. And also mean change in the norepinephrine equivalent dose from baseline to 3 hours was superior in angiotensin II group. So methylene blue, it is an inhibitor of nitric oxide synthase. There are small RCTs which shows improvement in systemic vascular resistance, MAP, and a lower norepinephrine requirement. Dosage is 2 to 3 milligrams per kg over 10 minutes, but there are some amount of contraindications, that is serotonin syndrome, G6PD deficiency, and methemoglobinemia. And since it's a non-selective nitric oxide synthase blocker, we can see the decrease in the cardiac output and increased mortality. Data is old and it is insufficient. The role of methylene blue is currently evaluated in ongoing trials. Last drug, hydroxycobalamin. Again, it inhibits the nitric oxide synthase. It increases the elimination of endogenous vasodilator hydrogen sulfide. There are some case series which have shown improvement in the MAP and reduction in vasopressor requirement. It interferes with the lab markers. So the dosage, 5 grams infused over 15 minutes. So this is just the summary of the medications and the evidence for the drugs. And vitamin C, recently it was tried in some septic shock patients. So there is some 2022 June published in NEJM. They found that the vitamin C given to patient with septic shock on norepinephrine, there is an increased risk of mortality. So there is no role of vitamin C. So I suggest this is the algorithm that should be followed in patient treating with vasoplegic shock. IV fluid resus followed by the norepinephrine, simultaneously correction of acidosis either with soda bicarb or renal replacement therapy, and correction of hypocalcemia with calcium. Second line, start with vasopressin, simultaneously steroids, both mineralocorticoids and fludrocortisone, followed by the salvage therapies. Either angiotensin 2 is the most preferred compared to methylene blue and hydroxycobalamin. Along with that, the POCUS, that is Rush and HIMAP protocol approach to find out the cause for shock and to diagnose the vasoplegic shock, that is cardiac index should be normal. And if it is sepsis, simultaneously you are treated with antibiotics, cultures, and the lactate. And we should not forget drugs or toxins. Example, CCB toxicity, the patient should be treated with IV lipid emulsion, calcium, high dose insulin, or glucagon therapy. So coming to the summary, the vasoplegia is hard to predict and it is devastating in its impact. It's a complex phenomenon which is centered around vascular reactivity with multiple contributing potential mechanisms. So adequate resuscitation with catecholamine and non-catecholamine medications can reduce the mortality and morbidity. Thank you.
Thank you so much, sir, for the enlightening answers on vasoplegic shock. Now the floor is open for questions.
Vivek, you are an assistant professor in St. John's.
Karthik, sir.
Karthik.
Associate professor.
Associate professor. Oh, so soon I'm going to see you as professor of emergency medicine at St. John's Medical College.
Yes, sir.
Very happy to do that. I'm afraid I have to make a few comments regarding your presentation. Okay. I'm not going to be coloring it. I'm going to give it to you plain and simple and blunt. Okay. See, in life, we need to progress from one stage to the next to the next. Okay. So when we start our careers, we start presenting. And we present mostly from slides. And we are basically reading at that time. Okay. But then we move on and then we start teaching. And we teach. I'm afraid you did not teach today. All you did was read aloud from the script that you had prepared. This is what I see in medical students or in junior residents. Okay, I'm surprised that, Shakuntala and whoever else is there, who's there, Girish and all have not really pointed out this to you when you were a senior resident or even because you have now become an associate professor. I'm sorry I have to do this because, I want you to be a very good teacher and that's why on a constructive note I'm telling you this, okay? You should not be reading from slides.
No problem.
You should be speaking, which means your slides should have only 3 or 4 lines.
Yes.
Rest will be talk. Whereas your slides mostly had copy and paste and the font size was only around 18 to 24. Okay, your font size was 18 to 24. Your font size should be 36. Then only the people who are sitting at the end of the classroom or at the conference hall will be able to see. I'm sitting right in the front and most of the copy and paste you have done of tables, of figures, all I can see is just a blur. None of them are useful because none of them can be read or seen. You don't need to put those up. You put the text, write it down, put the salient features. That is what needs to be done. Okay. These are all slides which I'm afraid in my department will not be accepted. Okay. So I'm telling you this because I want you to be really good and when you come back for the next conference, I want you to be speaking with authority. I want you to show the slides which people will remember. Okay, you take, for example, you put up a summary slide. Okay, the summary slide does not give me a take-home message. At the end of it, at the end of Karthik's lecture, I want to know, what did I learn? Your algorithm, on the other hand, that was your take-home. Okay, and secondly, the algorithm I'm not willing to accept because I don't know where the reference is. You gave a reference for many things in many places, but for the algorithm, you didn't give the reference. That is where I want to see, so that I will go back and read. I'm telling you from a student's point of view, because I believe I'm learning every day.
Yes.
I learn from my students, I learn from my peers, and I hope you don't mind learning from me. Okay?
Yes.
So I wish you all the very best, but I'm sure you will make a change and it'll be really, really good next time.
Sure.
Okay?
Thank you. Thank you.
Moving on to the next topic on procedural sedation in ED. This will happen in the Zoom platform. We have Dr. Hassan Siddiq for the next talk. Welcome, sir.
Hello, good morning. I'm Dr. Hassan Siddiqui, Additional Professor, Department of Emergency Medicine, KGMU, Lucknow, UP. And I'm very thankful to Aeme-Con 2023 for inviting me for this lecture. And my lecture is procedural sedation in emergency department. What is the definition of procedural sedation? Administration of sedative or dissociative anesthetics with or without analgesic to induce a depressed level of consciousness that allows patients to tolerate unpleasant procedure while maintaining cardiorespiratory function. This was given by the American College of Emergency Medicine. The other definition given by Australian and New Zealand organizations, the patient in a state of drug-induced tolerance of uncomfortable or painful diagnostic or intervention, medical, surgical, or dental procedure. The main aim is to provide little or no patient reaction or memory. The procedural sedation and analgesia, there is another definition given, published in Annals of Emergency Medicine 2002, use of hypnotic and analgesic medications for effective performance of diagnostic and therapeutic procedure while the patient is closely monitored for potential adverse effect. Then in 2018, European Journal of Anesthesia guidelines for the PCA was published. PCA was previously termed as conscious sedation. Indeed, the association of two terms is contradictory because effective sedation reduces consciousness. Level of sedations are defined by the level of patient responsiveness to cardiopulmonary functions. Here, the agent is not important. There, the level of sedation is important. Always prepare for the deeper sedation. What is the goal for us? To provide analgesia, amnesia, sedation, protection of airway and adequate spontaneous ventilation, and keep CVS within normal range. Doctors involved in PCA must have following training: perform appropriate patient selection, acquire advanced airway management skill, that is mandatory, understand and manage medications administered, perform patient monitoring, manage all potential complications. Best practice beforehand is a simulation environment. Always practice yourself and do courses like sedation providing courses. What we are doing in our institution, we started skill-based training for the airway management, where we are teaching our student trainees how to open up the airway and how to use gadgets for the airway, and oropharyngeal and nasopharyngeal airway use, and how to use LMA, how you can suction the oral airway or clear the airway. Then other skill stations were very for oxygen therapy. Here, the key teaching objective by the end of this session is how to use nasal cannula, Hodgson oxygen face mask, Venturi oxygen mask, a mask with reservoir bag, and use of self-inflating bags through a face mask, single-handed or two-handed, and use of LMA. Then the third station is how to deal with the complication of sedations. Key teaching objective here is by the end of this session, the candidate will show competency and confidence in dealing with the complication during procedural sedation or training SIM-SAP simulation mankind. Instruction for the instructor is candidate must demonstrate competency in dealing with complication during procedural sedation. Then in the end of the course, we are filling this form. What is the name of the patient, title, institution, email, specialty, years of experience. Then in session first, pre-sedation assessment, airway assessment, pre-sedation phase informed consent, level of sedation, getting started, equipment, what equipment is used. And the session 2, we are dealing with the sedation, post-phase sedation. When to discharge, how to discharge, what are the complications, how to manage them, then how you will prepare the patient. Medical history is very important. Any past problem with sedation or anesthesia, any recent symptoms such as fever, any medication patient taking, and any type of allergy. Then investigation, what you will do, we are doing basic investigation like basic blood works, and if patient is elderly, X-ray chest or ECG you can do. Then equipment, what we are using, medications and equipment for the cardiac resuscitation, oxygen administration equipment, ranging from nasal cannula to high flow oxygen mask is important. Then suction device is also very important. Then airway equipment include oro or nasopharyngeal airway, bag, wall mask, laryngeal airway, bougie, direct or video laryngoscopes, appropriate blade, appropriate size oral endotracheal tube, and surgical and needle airway. Adverse reversal drugs, what we are using, when you are using benzodiazepine or opioid, always one should have naloxone and flumazenil, and how to use it one should know. The pre-procedural fasting is very important. There are various papers published. According to them, infant or breast milk, one has to stop it before procedure up to 4 hours. Formula milk up to 6 hours. Clear fluid 2 to 3 hours. And adult up to 6 hours. Then monitoring is very important. During the procedure, post-procedure, one has to monitor the patient. Procedural sedation is a fairly safe practice. The level of sedation can vary. It can be ranged from minimal to fairly deep sedation. Full monitoring is very important, like ECG, blood pressure, pulse oximeter, and respiratory rate. EtCO2 monitor is very highly desirable. It is very good monitor. I prefer it. Then standard operative checklists. Always check the patient what you have and it is functioning or not. The World Health Organization template is useful. Verily identify procedure and content. Check, always check the needed medication, what is available, what you have, what you don't have. Then check the monitor. ECG is working or not, SpO2 is working, EtCO2 is available, working or not. Then assess the airway and anomalies. Contact lens should be removed. Individually confirm team members' role and their preparations. Agent required, we are using midazolam, propofol, fentanyl, chloralhydride for oral, low-dose ketamine, ketofol, and dexmedetomidine. Then techniques, how you will give. Medications, the ideal agent should possess sedative, analgesic, and amnesic properties. Rapid onset and short acting. Drugs we are preferring. Most of the time, the combination of short-acting benzodiazepines such as midazolam, which we are adding with opioid, fentanyl and midazolam combination is very good combination. Then fentanyl and midazolam combination, the most adopted one. Most of the people are using this one. Several drugs are also used alone or in combination. Combination drugs like propofol, fentanyl, propofol, ketamine, we are using it. A lot of publications are there. The sedation level is important. Depth of sedation cannot be always predicted. It is therefore important to prepare for the deeper sedation. Give particular attention to the dosing and to the patient response to the medications. Always given a small incremental dose. Titration to desired endpoint of sedation and analgesia is also important. Don't give much more drugs. Always give in incremental dose. Then three types of sedation we are dividing it: minimal sedation or anxiolysis, moderate sedation, or we can say conscious sedation, then deep sedation. In minimal sedation, responsiveness, normal but slow response to the verbal stimulus. Airway unaffected, breathing unaffected, and circulation is unaffected. Moderate sedation, responsiveness, peripheral response to verbal command is there. Usually airway is adequate, breathing is adequate, and circulation is maintained. Deep sedation of pain causes trouble. Here, the airway may be impaired, breathing may be impaired, responsiveness, patient may be deep and responding only to the painful stimulus, and circulation, usually the patient is maintaining. Some word regarding the minimal sedation. When cooperation is required, we can use minimal sedation. Used with nerve block, ventilatory function is maintained. Low risk for hypoxia and hyperventilation is there. Example where we are using this one for insertion and drainage of the wound, abscess drainage, lumbar puncture, simple orthopedic fracture, laceration repair, where we can minimal sedation. Then moderate sedation or concentration, controlled level of depressed consciousness there. Response is slow to verbal commands. Used when patient's good cooperation is required. Able to maintain airway and oxygenation. Example where we are using this one. Thoracotomy tube insertion, joint reduction, synchronized cardioversion. Then deep sedation. Most of the time we avoid deep sedation. But when painful procedure is there, we can use deep sedation, or when there is muscle relaxant requirement is there. Profoundly depressed level of consciousness is there. Then the post-sedation phase is also important. How to discharge the patient, monitoring, documentation, recovery, and discharge. Then post-procedural sedation may extend beyond the conclusion of procedure. We know that one. Monitoring and observation should be continued until there is no risk for cardiorespiratory depression. Monitoring the level of consciousness until patient return to pre-procedural level. Always monitor the patient post-op. Vital sign, BP, ECG, respiratory rate, oxygen saturation, airway, pain score, level of consciousness should be monitored every 5 minutes for first 15 minutes after the procedure. Then every 10 minutes to 1 hour, one has to monitor the patient. Then IV line, maintain IV line until the patient is fully recovered. Free muscle and rubber should be there. If you are using this one in hospital patient, one has to keep the patient inside hospital for 1 hour. If you are discharging the patient to home, then keep it there for 2 hours. No longer is for respiration or CNS depression is there, and you should not leave the patient if there is any chance of respiratory or CNS depression. Post-operative documentation is very important. At the completion of procedure, a procedure note should be written with the following heading: procedural performance, perform, medication administered, dose, time, route, and effect, intravenous fluid administered. All these things should be written completely. Then documentation is also, write down documentation every 5 to 10 minutes for the blood pressure, heart rate, respiratory rate, oxygen saturation, level of consciousness, and ET-C2 monitoring, complication if there is any status of patient at conclusion. Then post-operative recovery and discharge. One has to use modified rate recovery score, evaluate readiness for transfer to inpatient unit or to home. If LDATE score is 10 out of 10, then one can discharge the patient to home. For inpatient patient, when you are transferring the patient to the ward, up to 9, modified LDAT score is sufficient. Then what is LDAT score? We are taking 5 things in it: activity able to move voluntary or on command, respiration, circulation, then consciousness and oxygen saturation. This is 1 to 3, total score is 10. Outpatient discharge criteria, recovery score of 10 or pre-procedural baseline should be there. If the patient is recovered up to pre-procedural baseline, one can discharge the patient. Then there should be adequate hydration. Then voiding, patient voided or not, he is comfortable or not, one has to know. Patient's family written discharge instruction should be there, which will include explanation of anticipated limitation of activity. Patient should not allow for the driving the car, refrain for operating heavy machinery. Diet, one has to take bland diet. Discharge order written or in printed form. A 24-hour emergency contact number should be given. Ambulatory patient may not leave the hospital unless accompanied by a competent adult with him. The discharge criteria checklist should be there. Criteria: activity able to move extremities at baseline, respiration able to respire or able to cough, circulation, blood pressure should be within 20% up and down of the baseline, consciousness, fully alert or able to answer questions or at a baseline. Oxygen saturation, SpO2 more than 92% or room air should be there. Pain, no pain or pain at acceptable level should be there. Nausea, no nausea or nausea as acceptable level. Disposition, or then you can discharge the patient. Possible side effect of procedural sedation: change in heart rate or blood pressure, it is rare. Decrease rate of breathing, headache, nausea, vomiting, unpleasant memory or experience, regurgitation or aspiration, it is also rare. Side effects usually not very serious. They tend to go away shortly after the procedure. Close monitoring is important during the procedure, is the important thing. One has to close monitor the patient. What are the signs and symptoms of airway obstruction? Increased respiratory effort, external retraction, inspiratory stridor, hypoxemia, hypercarbia, absence or diminished breath sound. Then there is a lot of paper one has to go through. When we are using sedation procedures or using sedations, then there is a study published in the European Journal of Anesthesia 2016 by Malviya et al. They found that 2 children develop apnea when they are using pleural hydrate. So one has to be careful, identify an early change of respiratory cardiac fraction is very important. Then a lot of papers are there one has to go through. Several scientific studies organization have promoted the use of rapid-acting hypnotic drug. Always use rapid-acting, and such as propofol. And it is very important for those people who are not anesthetists or not trained. So always it is safe to use rapid-acting hypnotic drugs. Guidelines are there, given, which is published in 2003 in January in European Journal of Anesthesiology, European Society of Anesthesia and European Board of Anesthesiology guideline for procedural sedation and analgesia. Then another paper is there, procedural sedation, a review of sedation agents, monitoring and management of complications of the Journal of Anesthesia. It's a good article. Then in the last, summary and conclusion. An adequate evaluation of patients is mandatory to screen out the difficult patients. Need a specific training and advanced skill in managing the airway and administering emergency drugs. The role of anesthesiologist is very important to coordinate and supervise procedural sedation and analgesia activities and training to maintain highest level of safety. Thanks.
Thank you, sir. Thank you for the informative content and sharing your time with us. Now the floor is open for discussion. Any questions?
So good evening, Dr. Ehsan. So thank you so much. Thank you so much, and thank you for keeping with us whole day.
Yes.
So
Yes, ma'am.
yes, but then when it comes to KGMC, I always feel proud of it. Thank you so much. Being my alma mater, I always feel proud of it. So, sir, I just wanted, what is present consensus of giving this atropine and glycopyrrolate for if you are doing procedural sedation in emergency department?
Atropine, glycopyrrolate is a better choice. If you are giving analgesia, be towards the safer side. Always give it in incremental dose. And glycopyrrolate, if you are giving near about 10 minutes earlier, IM or IV is there, it is a better choice than atropine.
Yes. Thank you so much. I think so you are driving, we shouldn't. Safe driving, sir. Thank you so much for connecting with us on the Zoom platform. Thank you.
Thank you.
I'm happy to invite our next speaker. That is Dr. Devendra Richaria, and he'll be speaking on red swell and painful knee joint.
Thank you so much. Myself, Dr. Devendra, and since we are working and talking over the theme, the fundamental of emergency medicine, so this is one of the basic topic and one of the most seen pathology in this emergency department. So the introduction, the acutely swollen knee is a common presentation of the knee pathology in both the primary care and the emergency department. We often see the person and the patient comes with the swollen knee, and always there is a diagnostic dilemma. A painful swollen knee is a common diagnostic dilemma for the providers in the emergency room and urgent care and primary or the specialty setting. So there are a lot of things. Differential diagnosis comes in our mind. The presence of knee swelling or effusion requires a extensive differential diagnosis and systematic diagnostic approach as well. The knee swelling with redness, it can be traumatic or it can be atraumatic. So special attention is required in the atraumatic effusion to distinguish feature of infectious, post-infectious, rheumatological, hematological, vasculitis, and malignant disease. The significant diagnosis of these potential diagnoses are septic arthritis, which is a surgical urgency and requiring the prompt diagnosis and treatment to avoid the permanent damage in the form of chondrolysis, epiphyseal damage, ankylosis, and growth disturbances. So in the knee swelling, one of the most important is we need to differential diagnose and treat the septic arthritis. So why this is septic arthritis is so important? The septic arthritis is a disabling and possibly the life-threatening disease that required early diagnosis and optimal management right in the emergency department. It is important that the clinical and imaging feature of septic arthritis be promptly identified and should be differentiated from the characteristic of the similar disease. The key to diagnosis and management is, of course, the history and examination, which is the fundamental of the emergency medicine, and to determine the primary pathology, inflammation, infection, and structural abnormalities in the knee. The location of the pain, tenderness can be helpful for localization of structural pathology even before the radiological test. So it is very, very important for the emergency physician to diagnose at least figure out the septic arthritis. The management of swollen knee depends upon the underlying pathology and can range from anti-inflammatory medication, inflammation or the operative intervention for a structural abnormality. The aspiration, which is the fundamental of the emergency in the cases of swollen knee is a acutely swollen knee can be helpful for diagnosis and help the relieve the pain. So how the arthrocentesis, which is the sinofluid aspiration of the knee, can be performed either diagnostically for identification of etiology in the acute arthritis or therapeutically. So by taking out the fluid, it can relieve the pain also and drainage of the effusion, or we can give some inject the medication as well. So diagnostically, arthrocentesis is indicated to rule out the septic arthritis in individual presenting with the single or several inflamed joints, and it can also be used to differentiate between crustal arthropathies such as gout, pseudo-gout, inflammatory, non-inflammatory fusion, and hemarthrosis. It should be emphasized that the single inflamed joint should be almost undergo at least one diagnostic aspiration, that is in the emergency department. And therapeutically also, it is helpful for the drainage the large effusion, hemarthrosis, which gives the pain relief, or to inject the steroid, anesthetic, antibiotic, or the chemotherapy. As such, there are no absolute contraindication for the arthrocentesis, but it should be avoided in patient with cellulitis, which is overlying the skin, site of the needle entry, out of the concern of seeding the joint activity with the bacteria, adjacent osteomyelitis, and uncontrolled coagulopathy and joint prosthesis. So just look at the applied anatomy. To avoid the puncture of the tendon, blood vessels, nerves, the clinician performing the procedure should be familiar with the anatomy of the specific joint. So this is all we have learned in the anatomy classes. The risk of such injury can be minimized by using the extensor surface of the joint for the needle insertion while keeping the joint in the minimal flexion. So you can see we can go with the lateral approach or the medial approach, synovial cavity, patella, and so this is the traditional approach is the parapatellar approach, whether we go it the medially part or the lateral part. The most common we use it parapatellar approach. The other approach is suprapatellar or the infrapatellar approach also. And once we take out the fluid, we have to collect it in the three tubes, one for the culture, chemistry, and the microscopy. So with the help of the that fluid, we can categorize to the various normal, that is viscous, clear, or the colorless, that is the normal synovial fluid. Group 1 is clear, but it is pale yellow, that is the non-inflammatory fluid. Group 2, that is turbid, yellow, tends to clot on standing, and poor viscosity, that is the inflammatory fluids. Group 3, purulent fluid, that is the septic arthritis. So for the emergency physician point of view, we are much more focused on the septic arthritis. And group B, blood, that is the recent or the old trauma coagulation defect as well. So on the basis of once we collect the lab report or the biochemistry, you can see there is a WBC count which is septic arthritis is more than 50,000. So that is the most important. So that is the value of aspirating the fluid in the in the emergency department. So this is the one paper also which is the diagnostic criteria for the swollen pediatric knee. That is also shows the child with painful swollen knee must be worked up with possible septic arthritis. The classical clinical prediction algorithm, that paper is also showing and suggesting that the painful swollen knee, it should be aspirated. It is going to be helpful. So in this book also, this is my book, that is the textbook of emergency medicine, and also include the intensive care or the trauma. And you can see it is also written in the septic arthritis that usually a small joint fluid is, joint aspiration is essential, and synovial fluid should be submitted for the cell count and the differential diagnosis. So summary is, the arthrocentesis, which is used to diagnose and make the treatment of decision regarding the joint, it is easy, safe, and simple procedure, relatively painless, extremely beneficial to the patient, diagnostic and therapeutic both purpose we can do it in the emergency room, and analysis of the synovial fluid, which provide the unique and valuable information in the emergency, and definitely the diagnose or rule out the septic arthritis. So all patient presenting with red swollen knee and especially the painful or acute non-traumatic effusion should undergo the arthrocentesis where diagnosis is not clear after history and physical examination. Thank you so much.
Thank you for sharing your insights with us. Any questions? Thank you.
Okay, thank you so much.
have gathered here for the inaugural function of the Aeme-Con 2023, the first ever conference of the Association of Emergency Medical Educators. So you have been enjoying the feast, academic feast for the past 2 days, and it will continue tomorrow also. Just a little bit brief about the organizing, the entity that organizes this conference. AEME, Association of Emergency Medical Educators, is a non-profit organization having 3 directors, Dr. Einstein, Dr. Ashima Sharma, and Dr. Selvarajan. So this is, as I mentioned, it's a non-profit organization. It aims to empower and train everyone in emergency medicine, medical, paramedical, and to make the public aware and get trained in the first aid, COLS. And all money coming in into this organization is spent back to the society. And the association has been doing teaching and training of medical and paramedical students, and also has done first aid training to students and public. So as I mentioned, this is the first ever conference and workshops conducted by AEME, and it's a great success, as we all can vouch. AEME has given free registration to medical students and nurses and paramedicals, and a significant number of more than 50 medical and 50 paramedical staff. So that's the background of the organization. So with this, let us get ready for the inaugural function. So let us start this inaugural function with a prayer. Let's all stand up for prayer, please.
திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. We can be seated again. And I request Dr. Einstein, Director of AEME, to share his welcome address. Yeah, I would like to first call all the dignitaries to the dais. So after the dignitaries come to the dais, we will be introducing them one by one. So first, Dr. Einstein, Director AEME, please, sir, please come to the dais. And next, next I invite our respected Dean of Coimbatore Medical College, Dr. Nirmala ma'am, to come to the dais. Then I would like to invite Dr. Siddha S.C. Chakra Rao to come to the dais. Dr. Suresh David, sir, please come to the dais. And Dr. Ashima Sharma, please on the dais. Dr. Selvaraj, sir, please.
I want Dr. Selvaraj sir to please come to the dais. Please, sir. No, no. Okay, sir. That is fine.
So now, before inviting Dr. Einstein to share his welcome address, I'm pleased to speak a little bit about him. Dr. Einstein is our very own son of the soil. He's a student of Coimbatore Medical College, and he is now a pioneer in emergency medicine and is based in Seattle, USA. And he has a lot of interest on his roots in India, and he has done a lot of contribution during COVID times. And he has served in the past as American Tamil Medical Association president. And proud to state that he has advised, guided, and brought emergency medicine PG course in Tamil Nadu. And now it is in more than 30 medical colleges, the course is there. So we are proud to have you here, sir. Please come on to the dais.
I am very much honored and thrilled to welcome everyone to this first emergency medicine conference of Association of Emergency Medicine Educators. And I welcome our guest of honor, Professor Dr. Nirmala. She had done a tremendous job during the COVID times, and I had interacted with her many times from US, and she was doing a phenomenal job, and she was very, very supportive of this Association of Emergency Medicine Educators Conference, and she actively sent a circular to all the postgraduate departments to actively participate in this conference. I thank you very much for that, madam. Next, our chief guest, Dr. Chakar Rao, is the president of, is the chairman of the Indian Resuscitative Council Federation, IRCF, which was founded in 2017. And how I came to know him was like in Seattle, the witnessed out of hospital cardiac arrest due to ventricular fibrillation, the survival rate is 62%, which is highest in the world. And I practice in Seattle. So there, 95% of the population are trained in CPR. And whenever there is a witness cardiac arrest, 75% of the people, the bystanders start the CPR before the EMS arrives. So I was thinking, what is the statistics in India? In India, there is less than 2% of the people who are trained in CPR. And every minute delay in resuscitation decreases the survival by 7 to 10%. And so most important thing is immediate CPR by a bystander. So I was thinking how to improve the rate of CPR by the bystanders in India. So I was searching, and then I came across Dr. Lokesh Edra, and he introduced me to Dr. Chakar Rao, and me and Dr. Chakar Rao, I met him in 2020, and we had been working together towards that. And his vision is to make every citizen of India a lifesaver. That is his thing. I welcome you, sir. I'm very much, thank you. And Dr. Selvaraj sir is my teacher, and he taught me how to suture, and his technique is what I am even continuing to practice. And he used to draw flow charts and algorithms whenever he was teaching. And, I remember that, and that was, he makes every complex problems very clear. And I am very, very glad to get reconnected to him. And he doesn't want any recognition for his effort. He does put a tremendous amount of effort for this conference. He arranged this, he arranged that, he arranged everything for all the workshops. I am there, he is doing everything, but he doesn't want even his name in the brochure. That is the kind of person. He is a workaholic without any recognition. I welcome you, sir, for this. And Dr. Ashima Sharma, who is the organizing secretary and co-director, and she had been working tirelessly for organizing this conference, calling all the postgraduates, calling all the speakers everywhere. And I know every night, we used to talk like 2 hours, and we will get updates, who is joined and who is not, and all these things. And she was working during the daytime, and night we were discussing, calling everybody, doing everything. And a lot of postgraduates from outside Tamil Nadu and everybody came because of her tremendous efforts. I welcome you, madam. And Professor Dr. Suresh David, he is the first emergency physician in India. He is the first trained emergency physician in India. He started I think in 1993. 94, he started a first emergency department in CMC Vellore. There at that time everything was casualty, and nobody was resuscitating anybody, nobody was intubating anybody. Casualty patient was there, and the concept of golden hour and all those things was brought, and he started the first emergency department. I am very, very glad to meet him, and I welcome you, sir, for this conference. Thank you very much. Thank you. So I once again welcome you all to this conference, and I am very thankful to you. Without your participation, this conference cannot become a success. So I welcome all the faculties who had put tremendous effort in doing their presentation and contributing to the advancement of knowledge and sharing their expertise in this conference. And this AEME is a platform where all the experts in emergency medicine, to share their experience, and we will work together and will help in the progress and sharing the knowledge of emergency medicine to everybody. And there were about 90 paper presentations, and I welcome all the presenters, all the postgraduate students, the faculty, and I thank them all, and to make this conference a great success. Thank you.
Thank you for your kind welcome note, sir. And I now request all the dignitaries to join for the lighting of the lamp. We extend our heartfelt thanks to the dignitaries for lighting the lamp, and we shall proceed with the agenda for today. So next, before inviting our respected Dean of Coimbatore Medical College, whom has kindly accepted to preside over the function, may I request Dr. Ashima to kindly honor our So, speaking about our respected Dean ma'am, she is an able administrator. She developed Coimbatore Medical College to a great deal during her tenure as the Dean. She showed captaincy during COVID in administration and has several achievements in her tenure. And she has the honor of being the Dean of the institution in which she graduated from. And the institution also is very much proud of her, a proud alumnus of Coimbatore Medical College. And she has recently received a state level appreciation from the Chief Minister for COVID management. We are very proud to have you with us, ma'am, today. We request you to kindly give the presidential address.
Very good evening to one and all present here. Respected dignitaries on the dais and off the dais, and dear students. It gives me immense pleasure in participating this emergency medicine program that is organized by the Association of Emergency Medicine Educators. That is my teacher also, Sir, Dr. Selvaraj sir, comprising, and also Einstein and Madam, and the other dignitaries who have come for to grace the occasion. And as far as the emergency medicine is concerned, I am very, very interested in emergency medicine. I want every people of the society should learn about the basic life support and other emergency care, because we are seeing in our own hospital the emergency department, because one thing is they come late, or there is no effective delay in the transport or delay in managing the patient. All these are the major causes for the death. So in order to inculcate the habit of resuscitation, we have to go forward and we have to propagate actually the need of the emergency medicine. In that way, I am very much proud to say that this is the first batch of PGs are coming for the emergency department. We have 3 seats in our own college of the emergency department. And also, as far as the Tamil Nadu is concerned, our government is very much keen on giving care to the emergency, because we have got a program called as the TAI, that is TAEI, that is Tamil Nadu Accident and Emergency Initiation, that comprises of 6 pillars, that is the road traffic accident, poison and burns, and the stroke, STEMI, and one more pediatric emergency, PREM, they call it as a pediatric emergency. This is the thing we are having. And also, as far as today also, I attended a function in the Ganga hospital regarding the burns care. And also the burns care is also coming under the section of emergency medicine nowadays, because previously what happens is burns patients are directly admitted into the ward. There is no proper resuscitation. But nowadays they say that the burns, we have to, after attending the conference for a few sessions in the morning today, I thought that has to be attended very scrupulously in the emergency department, because and also the RTA, as far as the RTA is concerned, many people come with the head injuries, and the proper resuscitation if we are doing, we can save many lives, because many of the younger postgraduates and the other people are not aware of how effectively the resuscitation should be done. We are doing the resuscitation. Are we doing it in a correct way? That is the thing, the question arises. So what I mean to say is everybody should, the youngsters, especially to the youngsters I am telling, that not only the learning, but you have to have the habit of doing it in your day-to-day practice. That is the main thing. And also abreast the knowledge that what you have gained in these conferences, you have to every day think it over and apply in your field, because what happens is, as of now, many of our postgraduates are attending many of the conferences and also the emergency skills, but while they go to the ward, they are not, their thirst towards the emergency comes down, and also they are forgetting the things. While in the emergency department they are posted, they are forgetting the things. So emergency medicine as such is a specialty. Those who are, if the person who is posted newly to the emergency medicine, are he doing the justification to the patient? That is the question arises. So what I mean to say is, the youngsters should, everybody should learn how an emergency patient comes and how he is going to tackle that patient, because in the emergency, not only the acute emergency is coming, but sometimes what we get is acute exacerbation of the chronic conditions also comes. So he has to differentiate what condition to be given the most priority, because in our hospital setup, one medicine patient with poison will come and the another with RTA. All of the patients will come suddenly. That is how we have to make the triage what patient, but there is some calamity occurs there, because what happens in our institution is, when he may be having a small abrasion and he may be bleeding, that can be attended later, but if the patient may argue these kind of because he is not attended, that time the another one patient with head injury would have come, and the people are very busy with resuscitating that patient. He won't understand the situation. All these problems arises because the emergency medicine people are the one, not only they have to treat the patient, they have to, as far as the India is concerned, that too in our Tamil Nadu is concerned, we have to be expert in tackling the situation also. Any calamity can occur at that time. They may, emotional instances may come, and they may, you could have heard, sometimes they will argue with the doctors and the paramedics, and they may not able to do their job, justification for their job in the emergency department. And also the emergency department medicine, physician should be a multifaceted talent they should have. They should be at times they have to be a surgeon, at times they have to be an anesthetist, at times they have to be orthopedician to fix a fracture, and at times they have to be a neurologist, and at times they have to be a nephrologist, and also neurosurgeon, all these things. So all the specialties comes into play in an emergency medicine. So the emergency medicine physician should learn how the initial period of the emergency should be tackled, and once he is stabilized, they can be handed over to the concerned person. So till then the emergency medicine department is responsible. So in this way, this sort of training is very, very useful to the youngsters as well as and also the learned persons also, because unless we do, because what happens is multiple times, if we do that practice only, we will, spontaneously it will come. So what I mean to say is, whenever the youngsters, whenever you have an opportunity to resuscitate the patient, don't go away. That you involve yourself in the resuscitation and learn things. And I wish the organizers have done a very great job in sensitizing the younger generation for the importance of the emergency care. And in that way, I congratulate the emergency care, Aeme, that is Association of Emergency Medicine Educators, for having organized this wonderful program. And I thank once again for inviting me for such a wonderful program. Thank you all. Thank you.
Thank you so much for your insightful talk embedded with the pearls of your experience, ma'am. It's a really pride to have you, and we are really happy that you could make time from your tight schedule to be with us today for this session. Now I take the privilege of introducing our chief guest, Dr. Siddha S.C. Chakra Rao. So Dr. Rao has done his undergraduate and postgraduate diploma in anesthesia from Rangaraya Medical College, Kakinada. And he served the Andhra Pradesh government from the level of assistant surgeon until director. And in Andhra Pradesh, he formed the Family Benevolent Fund for Anesthesiologists, which was later adopted by the National Office of Indian Society of Anesthesiologists, and is now a very big prototype for several associations which have come up with similar funds. And Dr. Rao, with his close friend, Dr. Mishra, late Dr. Mishra, started the IRC, that is Indian Resuscitation Council, in 2017. In 2020, they started working on COLS, BLS, and CCLS. Now, the Indian Resuscitation Council Federation, now it is Indian Resuscitation Council Federation, now it has applied for affiliation with ELCOR, and it is awaiting approval. Dr. Rao has been behind all this, and he has conducted many workshops for patients and professionals all over India. And his main aim is that 2 hands can serve to revive people from cardiac arrest, and that's his favorite quote. And the COLS scheme is meant for from school children to lay public. And he has recently been honored as the Indian representative for ELCOR, which is a great pride for India. Thank you for bringing us this pride, sir. It gives me so much of pride to introduce you. And I now request Dr. Einstein to honor Dr. Rao with shawl and shield. It is our great privilege to have you as chief guest today, sir. I now take the honor of requesting you to give the chief guest address.
President of today's function, Dr. Nirmala Garu, the Dean of the Medical College here, the Chairman of the AEMA, Association of the Emergency Medical Educators, and the Secretary, Dr. Ashima Sharma, and my good friend, without whom this meeting and this association would have not materialized, Dr. Arunachalam Einstein, Dr. Suresh, who is the senior most person in emergency medicine, and our Salvarajan Garu, who has taken a lot of interest from the beginning to do something to the public and all. Really, emergency medicine is the #1 aspect which we have to learn And the other thing is, it has been neglected by all because it has not surfaced even now. The government of India has made a rule that all medical colleges should have a department by 2022, and it has been extending, and probably it will come in this year, and we should all have the post-graduation emergency medicine, and not only the postgraduate medical degree, we should have the paramedical training, a degree course like TMTs. So this actually, the backbone of the emergency medicine is the paramedical workers who spread throughout the India and take care of the emergencies. Emergencies means many things like an airway or a bleeding or resuscitation of the person with fluids or correction of the acidosis or anything else. And of course, it is not only CPR or anything. So all these things, we have to train them, and everybody should be connected to a central department where they will be watched, or even they will be directed to attend the emergencies through a GPS system. Of course, in the next 3-4 months, our own Indian navigation system will be coming, apart from the Google that is available, and probably we have to request the government to provide this facility to all the emergency medical providers and practitioners so that they can be called whenever they are needed. And even now, the first responder system is not very much practiced in India because we have a lot of issues, the transport, the vehicles, the heavy traffic on the roads, and we have our own customs and so many things. So we have not completely made ourselves alert for an emergency. Even now, even the 108 is working, but there are many lack in the actual working. When there are repairs, lack of diesel, proper drivers are not maintained, and all those things are happening. And we have a lot of rural area where the roads are not available. So we should have an alternative measures also to transport this number of victims that are susceptible for many of these seasons. Not only there are a lot of natural events occurring like storms, cyclones, fire accidents, and snakes is another problem for us. Even heat stroke is a problem for us. So all these things we have to revive. In some of the parts of Andhra Pradesh, people will be going in the hot sun to collect the beedi leaves, and they get sunstroke. And it is very difficult to revive them if it is neglected and all these things. So we should be it is not only the airway that is more important, everything is more important, like the fluid balance and everything. So now we have to encourage this new department. Of course, this emergency medicine is there since many years in many of the corporate hospitals and the advanced medical institutes. But even the medical colleges, there are about 640 medical colleges in India. Even there are no emergency medical physicians. And even last about 6 months back, I went to Safdarjung Hospital. There is no post-graduation there for the emergency medicine. So all these things we have to improve. We have a variety of types of medical colleges, even though it is governed by the NMC. The standards are varied, from one medical college to another medical college. Even in Delhi, the capital of India, the All India Institute has a different standard, and the other hospitals have got different standards. And let us think about what about the hospitals that were started new by the private management. So even in the private management, I see, actually, I started my career as an anesthesiologist in 1977, and as I grew as an additional director and retired in 2009, I have not seen a mannequin available in any place. I have not seen in Andhra Pradesh. I'm telling you, probably you are working in the institutes and you have worked with the mannequins. And really, in 2015, I have learned CPR by the providers of the American Heart Association. And it was very expensive. The BLS has costed me about 8,000 rupees in those days, in 2015. And the ACLS has costed me 16,000 rupees, and I have to go somewhere to stay in a hotel and take the training. So it has come to the mind of many people that we should have our own guidelines. How can we have our own guidelines? There is no research, there is no records, there is nothing in India. Actually, we are doing something and forgetting if the patient succumbs to a cardiac arrest or an emergency, it is all, we'll leave him and go away. If he is all right and he is alive, we take the pride and we don't even record that success also. So this is our system, it is going on. And when we started, actually we wanted to write some guidelines for India. Why there should be guidelines for India? A human being is same everywhere. But the situations and the circumstances that are available in India are different. We have different religions, different languages, different mentalities. We have superstitions, we have myths and fallacies. Even it is very difficult sometimes to teach the doctors also because they have some fallacies. It is very difficult to bring them out and keep them in the good track. So this is because it is observed, right? It is carried away from people to people. So how do you make a chest compression? Everybody has got his own. When the heart is beating only 72 times. No, madam. Thank you, madam. Thanks for gracing the occasion. Okay, madam. Please. You wanted to tell?
Yes, yes.
Yes. Yeah. We are witnessing a very proud moment as we give the Lifetime Achievement Award to senior most emergency physician of India, Dr. Suresh David, in the presence of our chief guest and our
So, for everything there is a reason. When you are compressing 100 to 120, the Indian guidelines tells it is only 120 because we have a reason. And it was debated many times. I went to ILCOR meetings as a guest and honor to South Africa, Cape Town. We have debated, but they don't easily accept. It is not actually actually now the ILCAR is the International Liaison Committee of the resuscitation. So there is a batch from the American Heart Association, the Canadian Heart and this one. There is a European Resuscitation Council. There is a South African Resuscitation Council. There is Asian Resuscitation Council comprising of comprising of only Singapore, Korea, and Japan. India and China are not there in the with people having more than 140 crores of population or 1.4 billion population. They are not there. And so these and Australian and New Zealand, they are the people they are ruling. And when we look back, there is no work done in India. But similar situations were faced and recorded because the American Heart Association guidelines have come in 1966. Since then, we have reviewed all the literature and brought out a similar situation and articles, and we have produced our own guidelines. Then everybody said, how can you write guidelines, you don't have research and all those things? Yes, we don't have research, but similar occasions, when a bystander CPR, a bystander doing a CPR, we named it because there may be a problem with the American Heart Association, but copying or the copyrights or their own rights. So we have changed the nomenclature as COLS, compression only life support, and your two hands can save the life. That is only our aim, and we wanted to teach all the lay people, school children, medics, paramedics, even it is more popular in the Indian Army because they will be going to the war, but somebody wounded, and they have to save. It is only two hands that are available, and the COLS is working now, and now it has become an international nomenclature now. And later, we made it as a BLS as BCLS, ACLS as CCLS, something like that, and we have. But normally, finally, when we treat the victim, everything is same. The most important problem is to approach the victim, collect the victim, call for the help, and what to do when really things are not there. So these are the situations still we are having, even though we do not have a good number of paramedics or trained people. As he says that less than 2% of the people, people in India know about CPR. So this is a very bad situation when it is compared to 95% in Seattle, where there is a success rate of more than 65% for a sudden cardiac arrest. Here, even the educated people, if there is a cardiac arrest, they wait for an ambulance, they wait for a doctor to come, and they don't do anything. Otherwise, at the maximum, they may try to lift him up and make him to sit or do something or make some tulsi tirtha or give him some soda. If that fellow is an unconscious, he will be drowned and we will be fastening the death. So that is our custom and that is our way. And so we have to bring them back, make him to lie down and make resuscitation. So this is becoming a very difficult job, and we are slowly doing it for the last 5 years. We're working on that. And my friend, Dr. Mishra, died of malignancy. And of course, I am also suffering with malignancy, but no problem. I'm still survived. What we are doing is, I have traveled far and wide, north to west, east to west. Every place I traveled, I am facing a lot of criticism and issues. How you can do, how, and I tell you, the American Heart Association is not, guidelines are not practiced in Europe. Europe will practice the European Resuscitation Council guidelines. In Australia, they have their own guidelines. And why not in India we should? Even Africa, South Africa, they have their own guidelines. And do you think that there is a very great research in Africa? Only the southern part, the Cape Town and Johannesburg, they do something. The others, nothing. But here, now we are coming up with a journal. I request you to participate in the sending the articles to the journal. I have given it to Walter Clover, one of the good publishers of the medical journals. And of course, I'm spending a lot of money. Probably the month end or the next month, we will be inaugurating or publishing the first issue. So I request all of you come together and publish. And to make India to keep in the map of ILCAR, we have been struggling, meeting many people. So when an attorney comes all the way from America, he advises a lot of things. And when we do it, again he gives next another 6 months he will come back and he'll give some more tasks. And somehow we are doing and keeping all different specialties on one platform. The emergency medicine physicians, the cardiologists, the critical care people, the physicians, the IMA, and anesthesiologists. I brought them together to a single platform, and now the Indian Resuscitation Council Federation is formed and registered about a year back, and it is progressing. And now it is going to receive, and India is going to be a member in the ILCAR soon. Actually, it should have been done. Actually, I would have announced it here, but the meeting has not taken place, and it will be taken place in Australia. So I'm going there. Probably will be there. So it is only a credit and appreciation. And many of the things, people, they think, no, still American Heart Association is good. So that's what I wanted to tell you. If the American Heart Association is good, why there are European Resuscitation Council guidelines? Everybody has got their own guidelines. And actually, the European Union or European Resuscitation Council has recommended the Indian Resuscitation Council Federation to be in the ILCAR. And also, another letter has come from the South African people, because we have lobbied a lot with them, and they have sent the letters, and he also knows many of them, and we are successful. Why means our main intention is to provide resuscitation for a very, very, very small price. It need not be in thousands. So it should. So we thought the BCLS or the BLS has to be given with a booklet for about 1,500 rupees with a lunch and tea, snacks and everything. And we are doing it. And for school children and layperson, the COLS is completely free. We are doing it. Now we have already initiated an app, and for all your trainers, we will authorize you to use the app. We are not, of course, it is in the, Android, but it is not accessible to everybody, because if it is everybody, then the certificates will be sold without doing the training. It can happen in India. So it is only for recognized people who can do some resuscitation. They are allowed, and they will be given the permission to enter into the app. And now it is ready. Actually, today we have trained about 50 people, and I have asked Lukman to enter all the things. But the only thing is we have to enter only through the Android phone, and it is taking little time. But after the entry, the person will get a beautiful certificate to his phone, just like what we did for the vaccine of the COVID. So slowly we will be rising, and I think it will take another 5 years to compete with any Western world. So first of all, our mindset has to be changed. Our mindset has to be changed. First of all, we should come together and work together and achieve the higher targets. That is the most important thing. And when I talk to the cardiologist, okay, you wanted to do CPR? Okay, you do it. No, I want your help. But the thing is, I don't want to discuss all the things. So I struggled a lot to take an interview and a letter from the Cardiologists Association that we wanted to back up. Of course, they will not be available. They will be available always in the catheterization lab. But we want their support. Like that, the critical care people. Now, next week, I'm conducting a workshop for the critical care people in Indore. They have invited me. They have actually left everything for us on the resuscitation part. Like that, we are progressing, and definitely we will progress. But still, there are people that they comment what these people are doing and all those things. When still people think that it is only 100 to 120, or no, we don't lose the time when you wanted to resuscitate. Even 1 minute delay will decreases the survival by 7 to 10%. Is completely recorded. Don't wait for a golden hour. Golden hour is only for the fractures and other things, but not for this other resuscitations. So actually the government of India wants to establish the centers, emergency centers for every 50 kilometers on the highway. And it has been there for the last almost 17, 18 years. It was postulated, but we don't have hospitals on the in that much of a distance, and we don't have the specialists to treat. We have only the primary health centers. The primary health centers, their mindset is different, and they're actually, our primary health centers is only to tackle the communicable diseases and the family welfare programs. So as this happens, definitely now there is a move, there is a call from the Road Transport Department, central government, to train their people on who are patrolling on the highway on the CPR. So now actually in Andhra Pradesh we have established the training centers in every medical college and even the nursing institutes. But we are coming up to establish these similar centers in all the other states. Now the NELS has come, National Emergency Life Support and all those things. So whatever it is, even the NELS, whatever we have written in our books, it is copied from there and it is there. We don't bother about copying or everything. What we want is somebody has to do CPR and save lives. Whoever does it, no problem. Even if you copy our books, no problem. That is the thing. What we want is we have to save the life, and everybody should be trained as a lifesaver. That is the thing, and I'm very happy. This is a real auspicious day today that an emergency medicine association, of course there are many associations that are there, but people like Dr. Suresh and other people, they have come forward to join hands with the new people, and the very young association, and I have seen people, youngsters are very enthusiastic, and youngsters have got more capacity to learn, and they are learning. I'm very happy, and I'm sure that this emergency association of the emergency medical providers, educators will be number one in future, and it will be, I wish that this society will be, our association will have a grand success in future and saves life. And the most important, the backbone of this, any association